A very good morning to one and all. On behalf of Chettinad Academy of Research and Education, the Indian Society of Teledermatology and IIDVL Chennai City Chapter of Tamil Nadu branch, I extend my warm welcome to today's event. The World Psoriasis Day 2021, organized by Chettinad Academy of Research and Education and partnered by Indian Society of Teledermatology and IIDVL Chennai City Chapter of Tamil Nadu branch, with its theme United Now Act, is sure to serve you an academic feast. Today is going to be an innovative day filled with information on psoriasis and all its aspects like epidemiology, pathology, clinical aspects, including hair, nail, and joint involvement, childhood psoriasis, and treatment aspect. Due to travel and other restrictions, we are having this event as a hybrid model. I request you all to make the best of today's academic feast with 13 different presentations, including 6 reputed international speakers. It is the earnest request from the organizers to all the delegates to please send your queries for discussion through a WhatsApp text message to the following number 90944 44553 or through the chat box option available on Zoom. I repeat, the delegates are requested to send in their queries in the chat box or through a WhatsApp text message to the number provided. We may begin our morning session now. Starting with the first session of the day, we have young budding dermatologist Dr. S. Soundarya ma'am from Chettinad Academy of Research and Education to make her presentation on topical therapy in psoriasis. May I request Dr. Padam Kumar sir to please chair the session.
Share screen.
The presenter and the chairperson are both physically in the venue with us to begin the session.
Good morning, everyone. Psoriasis, as we all know, is a chronic autoimmune papillosquamous disorder with a worldwide prevalence of about 2 to 3%. It's a lifelong disorder with recurrences and remission, and so far there is no cure. It has a wide array of presentation, ranging from the thick scales over the palmoplantar region to the thin, minimally indurated plaques over the flexures. So the topical therapies which we will be covering today will include moisturizers, topical steroids, vitamin D and A analogues, calcineurin inhibitors, coal tar, diethranol, and salicylic acid. So before going into each drug separately, we must know the factors affecting the percutaneous absorption. The factors that increase the percutaneous absorption include proper hydration, occlusion, concentration, the vehicle used, lipophilicity, presence of inflammation and irritation of the skin, cutaneous vasculature of the affected region, body surface area involvement, pre-treatment with keratolytics. And the factors that decrease the percutaneous absorption include thickness of the stratum corneum and the molecular size. Roughly, the pathomechanism of psoriasis includes hyperproliferation and abnormal differentiation of the epidermis with predominant T cell activity and vascular changes. So for a topical therapy to be efficient, it should have an anti-inflammatory, anti-mitotic, anti-pruritic, and anti-angiogenic effects. Among the drugs that are previously mentioned, topical steroid acts on all levels, whereas the vitamin D and A analogues have anti-mitotic and anti-inflammatory effect in addition. Calcineurin inhibitors and coal tar have anti-pruritic effect in addition. Indications of topical therapy. It can be used as a monotherapy in less than 10% of body surface area involvement. It can be used as an adjuvant along with the systemic therapy when the body surface area is greater than 10%, as it helps in reduction in the duration of the systemic therapy. It can also be used as a maintenance therapy in stable psoriasis. Moisturizers, as we all know, there is a barrier disruption in the psoriasis as evidenced by reduced stratum corneum hydration due to lack of ceramides, natural moisturizing factors, and free fatty acids. Moisturizers can be used as an adjuvant in all types of psoriasis. So here we prefer emollient as the moisturizers as it contains free fatty acids, squalene, and pseudoceramides, which are lacking in the psoriatic skin. One important moisturizer worth mentioning is urea, which at a lower concentration has humectant activity, whereas at a higher concentration, it has keratolytic effects that can be utilized well in palmoplantar psoriasis. Adverse effects are rare unless the patient has hyperhidrosis and there is presence of occlusion. They include miliaria rubra and occlusive folliculitis. Next is the topical corticosteroids. So they form the first line treatment. They are most commonly used and can be universally used in all grades of psoriasis. It is effective both as monotherapy and combination with topical and systemic agents. So the topical corticosteroids can be divided into 7 classes based on the American classification from class 1 to class 7. When compared to the least potent corticosteroid, the super potent steroids are 600 times more potent when compared to the potent steroids, which are around 100 to 150 times more potent. And when compared to moderate steroids, they are 2 to 25 times more potent. So we have to be careful in using topical steroids of the areas like mucosa, scrotum, eyelids, face, and flexures, as these have the maximum penetration. Adverse effects are maximum in steroids, and they include local and systemic adverse effects. Local effects include steroid atrophy, telangiectasia, purpura, PIH, stellate scars, exacerbation or masking of infections, milia, tachyphylaxis, and rebound phenomena. Over the face, it can cause topical steroid-dependent face, acneiform eruptions, rosacea, perioral dermatitis, hirsutism, and erythema. Systemic effects are seen only when we use potent or super potent steroids on large body surface area for a long duration. They are the most effective and have the most number of side effects as well. Next is the vitamin D analogues. They include calcitriol, calcipotriene, maxacalcitrol, and tacalcitrol. Calcipotriene is FDA approved in psoriasis. When used as a monotherapy, they can be used twice a day, whereas in combination therapy, especially with steroids, they can be used once a day. At physiological concentration, they have keratinocyte proliferation and provide resistance against ceramides, whereas in pharmacological concentration, they have the opposite effect, like anti-proliferative effects. They promote differentiation and keratinocyte apoptosis as well as barrier stability. They have synergistic effects with coal tar, diethranol, betamethasone, and clobetasol. And they should be avoided with salicylic acid, ammonium lactate, and hydrocortisone, as they cause increased degradation of the vitamin D analogues. When we are using it with phototherapy, we should use it after the phototherapy session, as vitamin D has phototherapy sparing effect. Adverse effects: they are well tolerated steroid sparing drugs, can be used safely in children, genital flexures, face, genital psoriasis, nail psoriasis, and in erythroderma. Rarely, when we use it at a cumulative dose of greater than 100 grams per week, we can get hypercalcemia. Vitamin A analogues, so tazarotene is commonly used. It is also FDA approved for psoriasis, available in a concentration of 0.05 to 1% in both cream and gel formulation. One important adverse effectiveness of this drug is that it has a half-life of around 20 minutes, which can be used as a short contact therapy, thereby minimizing the side effects. Side effects are same as that of the retinoids, that itching, burning, irritation, erythema, xerosis, retinodermatitis, and hypersensitivity. They can be minimized by concurrent use of topical corticosteroids, short contact therapy, and treatment-free intervals. Next one is the calcineurin inhibitors. They are macrolide immunosuppressants, and they are not FDA approved in psoriasis. They have large molecular size, which limits its penetration into the hyperkeratotic thick psoriatic plaques. And they are only effective in the genital inverse psoriasis, psoriasis over the face in the children. Why they are effective in genital and inverse psoriasis is because of minimal scaling, low induration, thin skin, and presence of occlusive effect. They also have a very low potency of side effects, and they are usually not preferred because they cannot penetrate into the chronic plaque psoriasis. Next is the older therapies like the coal tar and the diethranol. They were used extensively in the older days in the form of Ingram's regimen and the Gokerman's regimen, but due to the messy nature, irritant potency, and staining effects, they are rarely used nowadays, but they can be used in recalcitrant psoriasis, scalp, and the palmoplantar psoriasis. Diethranol is available in the form of cream, ointment, and paste at a concentration ranging from 0.1 to 4%. We can initiate the therapy at 0.1 to 0.5% over the affected site, and we can keep it in contact for around 10 to 20 minutes. It can be used twice a day, then gradually increasing the dose to a maximum of 1 hour and the dose to the maximum of 1%. Short contact therapy, we can ask the patient to apply it at the affected site and keep it for around 30 minutes. Overnight application can be used in the palmoplantar psoriasis, where the patient applies 0.5 to 1% over the affected site and keeps it overnight. And the response is usually seen in 2 to 3 weeks, and they are continued till the psoriatic lesions heal, that is, till the lesions become flat. One advantage over here is maintenance therapy is not required. It has 5 times more penetration in the barrier disrupted skin when compared to the normal skin. Adverse effects include staining, irritation, burning, contact dermatitis, folliculitis, and photosensitivities. While using over the face, we have to be cautious that it shouldn't come in contact with the eyes. It has photosensitivity, and we should also avoid it in contact with areas with fissures. Contraindications include unstable psoriasis, erythrodermic psoriasis, pustular psoriasis, pregnancy, lactation, presence of hypersensitivity, genital psoriasis, and impaired renal function. Case if we are using the diethranol and there is progression of lesions or signs of irritation, we should discontinue it immediately, as it can lead on to Koopman's phenomenon and also erythroderma. Next is coal tar. They are resins which have been used in psoriasis for greater than 100 years. Crude coal tar form is most commonly used. And as I already mentioned, they are used in scalp, palmoplantar psoriasis, and chronic plaque psoriasis. It is available in ointment, lotion, solution, and foam formulation. The foam formulation and the shampoo and lotion formulation are commonly used and has better compliance. So when it comes to thick scales, they can be applied over the affected site, left overnight. Next day, they can be removed with vegetable oil. And for minimal scaling over the scalp, we can use it in the form of shampoo. Both works well when compared with salicylic acid. Adverse effects are same as that of the diethranol. When it comes to carcinogenicity, it is seen only in occupational exposure and in animal studies. No cases with psoriasis which have been treated with coal tar have reported carcinogenicity so far. Contraindications will be the same, like unstable psoriasis, erythrodermic psoriasis, pregnancy, lactation, and signs of irritation. Advantages are it is effective, economical, and produces long-term remission. Patients with psoriasis who have been treated with Kokerman's regimen had a remission of almost 1 year. And one more advantage is they can be used in recalcitrant psoriasis, elderly patients, and especially with systemic comorbidities. Last one is the salicylic acid. So this is the most common topical keratolytic that is used. It has a high lipophilic effect, so it acts on the stratum corneum and has a desmolytic action. Hence, the scales are shed faster, and whatever topical agent that we are using in combination has a faster onset of action. This doesn't act on the mitosis, hence they are not preferred as monotherapy. So we should be avoiding its use with calcipotriol and phototherapy. With others, we can use it. Side effects: when used on large body surface area, it can lead on to salicylism. Other side effects include hypersensitivity, dryness, erythema, itching, and irritation. When it comes to pregnancy, all the drugs fall in the category C except the vitamin A analogues, which falls into category X. Topical steroids of lower mid-potent strength are usually preferred in pregnancy, as 40 to 60% of the patients improve during the pregnancy. We can taper the dose and stop it. Moisturizers can be used freely. So in summarizing, when it comes to the face, genitals, and the flexures, least or mild potent steroids are usually used. Vitamin D analogues and calcineurin inhibitors can be used as a monotherapy. When they don't work, we can go in for a combination therapy or use a mid-potent steroid, that short duration. And palms and soles which have the thick scales, we can use keratolytics like salicylic acid or urea. We can use super potent or potent steroids for a short duration and then taper it, or use a combination therapy along with vitamin D analogues, A analogues, coal tar, or diethranol. This produces faster resolution and we can taper the drug. Scalp psoriasis, for mild scales, we can use coal tar with or without salicylic acid in the form of shampoos. Moderate scalp psoriasis, we can use betamethasone along with calcipotriol, it works well. In severe forms, we can use potent steroids with or without vitamin D analogues, A analogues, coal tar, or diethranol. Scalp, the side effects of steroids are less prominent as due to the presence of hair and the thick skin. This also hinders the efficacy of the topicals. For trunk, we can use potent steroids, vitamin D analogues, coal tar, and diethranol. So in psoriasis, while treating, we have to keep in mind what site we are treating, and the proper selection of the topical agent will enhance the effectiveness and also minimize the undesirable side effects. Thank you.
Thank you, Dr. Soundarya. I would like to congratulate you. You have covered on the entire topical aspects of psoriasis. I have some questions for you. So, what is the role of topical therapy in erythrodermic psoriasis?
In erythrodermic psoriasis, since there is presence of excessive transepidermal water loss, moisturizers should be used as the first line of treatment. And the other drugs like the vitamin D analogues can be used at a concentration of 100 grams per week. In a study, they have used around 300 to 360 grams of calcipotriene per week in a patient. And they have only reported mild biochemical hypercalcemia, which was reversible within 3 days of cessation of the topical. Topical steroids in the form of mid-potent or low-potent strength can be used depending upon the fingertip units, alternating with the body sites.
Moisturizers, what do you prefer usually?
We can use emollients in psoriasis.
So, another question for you. What is the role of topical bexarotene in psoriasis?
Topical bexarotene has similar efficacy as that of the tazarotene. Their efficacy is well documented in mild to moderate psoriasis, and they can also be used in combination with topical steroids and phototherapy.
Okay, thank you, doctor.
Thank you.
Yeah, I would like to thank the organizers for giving me an opportunity to chair this session. Thank you very much.
Thank you, ma'am, for the precise talk on topical therapy. Thank you, sir. We will now move on to a very important topic, histological differential diagnosis of psoriasiform pattern by Dr. Rajav Shekhari, sir, and Dr. Vinod Shekhari, ma'am, from Noida. May I request Professor S. Nirmala, ma'am, Head of Department from Satyasai Medical College, to please chair the session. Dr. Rajav Shekhari, sir, and Dr. Vinod Shekhari, ma'am, we request you to start sharing the screen.
Good morning. Next, we'll be going to the histopathological aspects of psoriasis. I now request the speaker to continue with this lecture.
I think we can. You can see the screen and hear the voice. Hello.
Yes, sir. You're audible.
Good morning, everyone. It's an honor to be part of World Psoriasis Day, and we will be discussing differential diagnosis of histologic psoriasiform picture. Now, this is a very good slide which shows, this is a skin biopsy, and it shows evenly elongated rete ridges. These are the rete ridges. This whole thing is the epidermis, and below that we have the papillary and reticular dermis. So rete ridges are part of the epidermis, and once they are regularly or evenly elongated, we get what is called a psoriasiform reaction pattern. And that is what we are going to discuss today. Psoriasis is the prototype of psoriasiform reaction pattern. Now here is a biopsy from a patient of psoriasis. What we see is mild hyperkeratosis, and we see evenly elongated rete ridges. We see the papillary dermis here and the superficial vascular plexus. Both show inflammatory cells around blood vessels. What we also observe is that the granular layer is not very prominent, and the epidermis above the papillary dermis is thin. So the acanthosis or hyperplasia of the epidermis is contributed to mostly by elongated rete ridges. On hyper, what we are seeing is this scale crust housing neutrophils. We see very little or sporadic granular layer cells. This is one. So what we are seeing here is mostly agranulosis with occasional granular layer cells, evenly elongated rete ridges. The papillary dermis shows tortuous blood vessels, and we have a perivascular infiltrate involving the superficial vascular plexus. So if I were to recapitulate the findings, we have scale crust housing neutrophils, we have elongated rete ridges, we have suprapapillary thinning, we have tortuous blood vessels in the papillary dermis, and we have a superficial perivascular lymphocytic infiltrate. When we put all these findings together, the diagnosis is psoriasis. We will come to hear about this tortuosity of blood vessels many times in the session, and I would like to have especially the junior doctors remember that. Now this is another case showing parakeratosis within a thick stratum corneum housing neutrophils here, and we see that they are staggered. We have a focus here, a focus here, a focus here. So, and we have rest of the findings, except that in this particular case, the papillary dermis is much more edematous than it was in the last case. This is also a feature of psoriasis, which shows the lesion is still evolving. And this is what we see, this constellation of features in plaque psoriasis. Now let us look at the variants. This is involvement of the nails. The nail is showing pitting, and once the biopsy was done from the nail bed, what we saw was presence of the granular layer, a thick stratum corneum, and psoriasiform hyperplasia. Many times we don't see neutrophils within the scale, but when we do a clinical pathological correlation, this is good for psoriasis. Now the presence of granular layer cells in a nail bed biopsy in psoriasis is paradoxical. At other sites, we see hypogranulosis. In the nail bed, we see the presence of granular layer cells. And this photo has not been photoshopped. These are the kind of biopsies we see in real practice. Now, this is scalp psoriasis. This is part of a hair follicle, and this is part of a hair follicle. Between the hair follicles, we have what we call interfollicular epidermis, and it shows psoriasiform hyperplasia. Then we have the thick scale and staggered paranuclear foci with neutrophils. Very characteristic of psoriasis. The other thing that we find very often in scalp psoriasis is a bit of papillomatosis. Not all biopsies, but many biopsies show it. And we would still call it psoriasiform reaction pattern with all the features of psoriasis. Now, at this site, one of the important differentials is seborrheic dermatitis. In seborrheic dermatitis, what we see is parakeratosis around the follicular ostium. This is also called follicular lipping. Besides the other features, of course, here we have confluent parakeratosis with scattered neutrophils, hypogranulosis, psoriasiform hyperplasia, and in addition, we have parakeratotic follicular ostial lipping. So when we put these findings together, along with superficial perivascular infiltrate, we have seborrheic dermatitis. Sometimes we also see inflammation around the hair follicles, which is not seen in this particular biopsy. And at times, the mid-dermal vessels also get involved by the inflammatory process. That does not rule out psoriasis. Now here is a case of pustular psoriasis. If we look at this focus, what we are seeing is an aggregate of neutrophils beneath the stratum corneum. Here is a scale crust housing a few neutrophils, which is good enough for psoriasis. But if we were to look at the epidermis below the below this pustule, below the subcorneal pustule, we wouldn't be 100% sure that we are looking at psoriasis. So what we do is we look at the epidermis adjacent to the pustule on either side, and mostly we do find psoriasiform acanthosis or evenly elongated rete ridges. Then we have hypogranulosis and all the rest of the features along with perivascular inflammation. One thing which is very characteristic of pustular psoriasis is spongiform pustulation, which means that beyond the main pustule, there is spongiosis within the epidermis, and in these foci of spongiosis, we see neutrophils. Now, this is psoriasis on palms and soles. So in this case, this is on the soles of this patient. The characteristic thing is a very, very thick stratum corneum, which is normal for this site. And we see psoriasiform hyperplasia. We also see a bit of spongiosis, like this focus here, this focus here. Spongiosis at this site can be mild and it can be severe. When it is severe, it can really bring other differentials into the picture. But here, what we have to concentrate on is within the stratum corneum, we see these staggered foci of parakeratosis housing neutrophils. Now, here I would like to tell you a little story. When we started sending some of these patients to the surgeon for biopsy, some patients were not comfortable getting biopsy done on an OPD basis. So we used to send them to the hospital, and the surgeon would do a nice cleaning of the lesion, and we would lose the scale. And then it was really problematic. So we had to sort of educate our surgeon and tell him that we need this scale, so please do the cleaning in such a way that the scale is not removed. This area is very, very important to resolve the differential diagnosis in psoriasis and other conditions. So we have all the other features plus this very thick stratum corneum, and sometimes the lab will call and say, is this tissue bone? This is so thick and so hard that it can be quite difficult to cut sections. And it needs a lot of expertise to get such a neat section from the palm and the sole. Now, this is palmoplantar keratoderma, which is a common differential at this site. And what we see here is marked ortho hyperkeratosis. Ortho hyperkeratosis would mean that there are no parakeratotic foci, and this orthokeratosis is resting on areas of the epidermis which are dulled or a bit depressed. And this is how palmoplantar keratoderma looks. There are no scattered or staggered foci of parakeratosis with or without neutrophils. Now, when keratin dominates in a biopsy which has psoriasiform reaction pattern, this is a lot of keratin. We have slightly uneven or irregular psoriasiform hyperplasia, but it does come into the differential with psoriasis. And we also see papillary dermis here, which is thickened. So hyperkeratosis, focal hypergranulosis, the granular layer is thick and prominent, acanthosis with elongated rete ridges, all are not of equal length. So we would call this uneven acanthosis or uneven psoriasiform hyperplasia. On high power, what we see is vertically oriented collagen bundles in the papillary dermis. The blood vessels are also aligned perpendicular. Now, this collagen in the papillary dermis is realigned as a consequence of spirited rubbing over the lesions over months and years. It's not rubbing for 1 or 2 days. It is rubbing of pruritic lesions over months and years. The collagen gets realigned. We see parallel orientation of collagen bundles and vertically aligned blood vessels. And this is lichen simplex chronicus. Sometimes we can see the underlying disease in lichen simplex chronicus. In such cases, the patients have been rubbing, usually with the ball of the finger, and for prolonged periods of time. And what we see here is, let me just first define what we're seeing. We're seeing hyperkeratosis, we're seeing some hypergranulosis, we're seeing a thickened papillary dermis, we're also seeing tortuous blood vessels, and we are seeing inflammation involving the superficial vascular plexus. In addition to that, we see foci of hypogranulosis with parakeratosis. Here we are not seeing neutrophils. So this is psoriasiform hyperplasia. In this patient, we did 2 biopsies because we were not sure that his lesions were lichen simplex chronicus or psoriasis with lichen simplex chronicus. So sometimes careful observation can lead us to identify the underlying disease where lichen simplex chronicus features are superimposed because of prolonged rubbing. So this was psoriasis with lichen simplex chronicus. Similarly, a good example of lichen simplex chronicus with identifiable underlying disease is lichen planus hypertrophicus. Now, we are talking of psoriasiform hyperplasia with lots of keratin. This is very thick keratin, which is normal for palms and soles. We see a nice psoriasiform hyperplasia. See these evenly elongated rete ridges. There is inflammation involving the superficial plexus. The blood vessels in some papillae are tortuous. In addition, we are seeing granular layer here, which is not hypergranulosis for this site because the granular layer at this site is 8 to 10 cells thick. So this is clearly hypogranulosis at this site. And we also see spongiosis, which is seen in many biopsies of psoriasis from palms and soles. So palmoplantar psoriasis can show significant psoriasis. Sometimes it is so much that it is difficult to make a diagnosis of psoriasis unless we observe the stratum corneum and see these scale crusts housing neutrophils. So when we see these scale crusts staggered in the stratum corneum housing neutrophils, the diagnosis is psoriasis on palms and soles. Now with spongiosis, other conditions that enter into the differential diagnosis are allergic contact dermatitis, nummular dermatitis, dyshidrotic dermatitis, EAD reactions. Now allergic contact dermatitis and dyshidrotic dermatitis would enter into the differential diagnosis when there is spongiosis in a biopsy that looks like psoriasis on palms and soles or on hands and feet, especially palms and soles, or even on the sides and fingers and sides of toes. So the key is clinico-pathological correlation. You would see what sort of lesions these are, what is the distribution of lesions, are they sharply demarcated or not, and so on. Now, other things that we have to consider, especially in our setup, is one of them, and very important, is treatment-modified psoriasis, and this is really problematic. Patients usually apply all sorts of creams and lotions before they come to the diagnosis, come to the dermatologist for a proper diagnosis. And if a biopsy has been taken when the patient has not been put off steroids, local or systemic, what we get is a picture of treatment modified psoriasis. And sometimes it can be difficult. The report would go psoriasiform reaction pattern. It can be a bit frustrating for clinicians who think their patients have psoriasis. Now, the first things to disappear with application of antifungals or steroid creams are neutrophils within the stratum corneum. Now, unless a pathologist sees neutrophils within the stratum corneum, he or she is not going to give a diagnosis of psoriasis. The report will be returned as psoriasiform reaction pattern. When other features are there, like suprapapillary thinning, tortuous blood vessels, this is a very important finding which is seen throughout the age of a psoriasis lesion. So once we see these findings, we can with significant confidence say this looks like treatment modified psoriasis. Clinico-pathological correlation is advised. Dermatophytosis, especially vesicular, can look exactly like psoriasis. It can give rise to neutrophils in the stratum corneum, hypergranulosis, tortuous blood vessels, psoriasiform hyperplasia with evenly elongated rete ridges. It can look exactly like psoriasis. So whenever there is a doubt, one would like to do a PAS stain, which is pyritic acid shift, or other stains for fungus, and look for and look to see if this could be dermatophytosis. But also remember, the biopsy specimen sent for evaluation may not show fungal hyphae or fungal spores. So if we don't see fungal hyphae or spores, we don't rule them out 100%. But what we say is there is no evidence of dermatophytosis in this biopsy. Again, we would need clinico-pathological correlation. Atopic dermatitis can look psoriasiform, will show spongiosis when the lesions are chronic. So psoriasiform hyperplasia in diseases which are not psoriasis signifies chronicity, such as in allergic contact dermatitis and its other lookalikes. Drug eruption can be psoriasiform, it can be psoriasiform spongiotic. So these differentials, these conditions would also enter into the differential. Now, eosinophils are not requisite for the diagnosis of allergic contact dermatitis, nummular dermatitis, dyshidrotic dermatitis, and EAD reactions. We can see these, we can diagnose these without the presence of eosinophils in the biopsy. But when eosinophils are present, they are present usually in perivascular location. They can be present in the papillary dermis, in the upper reticular dermis. They also can be present within the epidermis in foci of spongiosis, what is called eosinophilic spongiosis. But one message that I would like to give right now is we don't rely on a single finding to make a histological diagnosis. We always take more than one finding into consideration to come to a diagnosis. That is, we look at the constellation of features. Now, in this case, the lymphocytes are a little out of focus because I was trying to focus more on eosinophils. This is a beautiful eosinophil with a bilobed nucleus and very pink or reddish cytoplasm. That is how it looks on sections. This is a eosinophil. This is an eosinophil. Here is a cluster of eosinophils. There's another one here, another one here. Now, these are not very many. This is a mild eosinophilic infiltrate. Besides a perivascular lymphocytic infiltrate, eosinophils can be fewer than this or many, many more than this. Now, so my message to all the junior dermatologists is clinical pathological correlation is key to diagnosis when we have psoriasiform reaction pattern and psoriasis and spongiosis. Now, treatment modified psoriasis can look like this. We see all the features of psoriasis, but what we are not seeing is neutrophils within parakeratotic foci. So, but we see tortuous blood vessels. See, look at this blood vessels. It's pretty tortuous within the papillary dermis. There's inflammation. There are all the other features except for neutrophils in the stratum corneum. Within foci of parakeratosis, I'm saying this again and again and again, because if this feature is absent on biopsies, the report will go back as psoriasiform reaction pattern, treatment modified psoriasis or partially treated psoriasis cannot be excluded. Clinical pathological correlation is advised. Now, we also have spongiotic psoriasis. Whedon recognizes it. And in one of our discussions with Dr. Jacob Thomas, he said something which was really the result of his many years of practice and excellent experience, that psoriasis and atopic dermatitis are at two ends of the spectrum. So this could be atopic dermatitis. There is spongiosis, there is psoriasiform hyperplasia, there is hypogranulosis, a bit of hypogranulosis. But of course, this was from a patient who had been treated partially for psoriasis, because once we see hypogranulosis, we tend to give the first differential as partially treated psoriasis, or in this case, spongiotic psoriasis. So when we see spongiosis in a biopsy that looks otherwise good for psoriasis, we don't need to rule it out entirely, but we need to write a note for the clinician. Association with infection. Psoriasiform reaction pattern can be seen in dermatophytosis. Here in the stratum corneum, we see fungal hyphae and cluster of spores over here. The fungal hyphae tend to find this place, this niche, very cozy to stay. That is in the stratum corneum when there is not much plasma. So right above the epidermis in the stratum corneum in the absence of plasma. Now we are seeing a bit of spongiosis here. When we do this, when we see this, it's always a good idea to get a PAS stain done to rule out dermatophytosis. And this is another clue when PAS must be done. These are neutrophils in foci of spongiosis within the epidermis. This warrants a PAS stain, which may turn out to be positive or negative. Now, this patient clinically has these kind of lesions, and this is what his biopsy looked like. Scale crust with neutrophils in the stratum corneum, and a bit staggered as well here and here and here. Hypogranulosis, psoriasiform reaction pattern, and a perivascular infiltrate, very good for psoriasis. But when I looked at high power, the cells were looking a little larger. The cytoplasm was more than I was comfortable thinking these were lymphocytes, and these cells turned out to be plasma cells. See, this is the nucleus, and this is amphiphilic cytoplasm. This is not pink. This is a different, this is kind of pinkish purplish. An eccentric nucleus, a perinuclear HOF, this clear space adjacent to the nucleus, an amphiphilic cytoplasm. This one is another good plasma cell, and all these here are plasma cells. So once we see plasma cells and a psoriasiform reaction pattern, remember we could be looking at a mimicker. So we have this clinical picture. We have plasma cells with a psoriasiform reaction pattern, and We asked the patient to get a VDRL done, which turned out to be positive. So this was syphilis, secondary syphilis. We can have psoriasiform reaction pattern with a lot of lymphocytes within the epidermis, what are called intraepidermal lymphocytes. Here is this case. This is quite evenly elongated rete ridges, but what is baffling here is the presence of mononuclear cells within the epidermis. They are present singly as well as in clusters. So this was pretty doubtful for MF. This is in hyper. Look at the number of lymphocytes. Usually, we don't see as many lymphocytes. When we see so many lymphocytes with very little spongiosis, the spongiosis, the extent of spongiosis relative to the number of intraepidermal lymphocytes is really not much. So instead of calling it spongiosis, I would like to call it epidermotropic lymphocytes with a little bit of spongiosis. And then we see this psoriasiform hyperplasia with a little bit of spongiosis here. And the dermis, the upper reticular dermis, is full of these lymphocytes. These lymphocytes are usually of small to medium size. But usually what we see is the lymphocytes which are within the epidermis tend to be a little larger than lymphocytes in the dermis. And here is hyper. Look at these lymphocytes. And the characteristic thing is that around the lymphocytes, there is perinuclear clearing. This is very characteristic of mycosis fungoides. We got immunohistochemistry done, and what we got was, what the report said was that this was an antigen deficient infiltrate in the epidermis and the dermis. Immunohistochemistry was supportive of mycosis fungoides. So these look a little bit like psoriasis, but we have to be very careful when we're looking at biopsies. CPC is very, very important if we don't want to give really funny diagnosis. So sometimes we can have epidermis that looks psoriasiform on a this is on top of a dermal tumor, which is mesenchymal. In this case, this is a dermatofibroma. And let us look at this psoriasiform reaction pattern. So we have elongated rete ridges. Also notice that the sides of these rete ridges and the bases are pretty dark. We call this a dirty fingers pattern. And this is a dermatofibroma, on top of which many times we have acanthotic epidermis. It can sometimes be psoriasiform. And now we are going to discuss a single case in some detail.
A female, 16 years old, who has juvenile idiopathic arthritis, uveitis, and hidradenitis suppurativa. She's being managed by Dr. Sujata Sani, who is pediatric rheumatologist. Since she has hidradenitis suppurativa, uveitis, so she chose to put the patient on adalimumab, 40 milligram subcutaneous every 2 weeks. And this all has helped the patient, and she has been doing reasonably well. Uveitis disappeared, arthritis came under control, even hidradenitis suppurativa was under control. But after 15 months of adalimumab treatment, what Dr. Sahni notices is these psoriasiform lesions on the feet, on the scalp, on the shin, and the ear. And this is what has been concerning to Dr. Sahni, that adalimumab is the treatment for psoriasis as well. And this patient has developed these psoriasiform lesions. So she sends the patient for the workup. And what we did, we took a biopsy from the scalp, and this is what Vinu has reported.
So very clearly we see a nice psoriasiform reaction pattern over here, and this is on the hair follicle, since this follicle is in the fat, we know this biopsy is from the scalp. And here I see a bit of spongiosis. I see papillary dermis, which is spongiotic. So I have all the features of psoriasis, except it doesn't have a very good scale. So psoriasiform reaction pattern, and I started looking at different foci in the dermis, different fields in the dermis. I noticed that the infiltrate had eosinophils.
So once she reported that this is the eosinophils and psoriasis, so once the Vino reports is psoriasis, so this is a new onset psoriasis, which is paradoxical development of psoriasis on anti-TNF therapy. Now, there are enough reports and single case reports in the literature which says paradoxical development of psoriasis on anti-TNF therapy. Now, the most recent report has been in the March 2021 as well. But I have chosen the article from JAD 2017 to compare our patient with the information provided in this article. So this article has documented that 216 such cases identified till August 2016, and out of these, 70% patients occurred in the first year of the treatment, and in our patient, this started 15 months after starting the treatment. This is very well with the JAD report that it is 15 months. Now, they said that the 2/3 of the patients were on infliximab. Our patient was on adalimumab, TNF alpha blocker. And 72% patients were females, and our patient is also female. And then they have not found any personal history of psoriasis or psoriatic arthritis in the patient before they were put on anti-TNF therapy. And in our patient as well, there has been no history of psoriasis lesions in this patient before she was put on adalimumab. Also, positive family history is seen in about 11.8% of the patients, and in our patient we inquired and we could not find any family history in psoriasis in our patient. 102 cases out of these 216, 102 cases were biopsied, and what they realized that the 88% patient had typical psoriasis features under the microscope, whereas 12% patients had psoriasiform dermatitis features. And Vino has report released says psoriasis, please look for a drug-induced psoriasis because there were eosinophils seen in this histopathology. 50% of the patients cleared on withdrawal of the TNF blocker, whereas half of the patients, they need additional treatment. This is what the JAD has reported, and what we followed, what we did. We asked the patient to withdraw the adalimumab, and what we have found that in 4 months, and you see the lesions before the treatment was started, and this is what the lesion has cleared. You can see this small pigmented mole, you can see that, and this is the lesion, and this is all has cleared in 4 months after withdrawal of the therapy. So we find that this is a very interesting case that probably so far 300 odd cases have been documented in the literature, and we have felt that this is a good case to share with our audience. Thank you very much.
Thank you, madam and sir, for your very informative and educative lecture. And one practical point which you have pointed out is the scales are very important when doing a biopsy for psoriasis, which will have the parakeratosis, which is an important feature for psoriasis. That's why we also tell our postgraduate students not to wipe the skin too much before doing the biopsy. Then regarding the new onset psoriasis, I think when we start biologicals like adalimumab and infliximab, we should note this point because they develop psoriasis even without a family history of psoriasis. Thank you, Madam and Sir, for your lecture.
My
Thank
pleasure, sir. Our pleasure. Any questions? Any questions?
I think
Any
there are no
questions?
questions, sir. Thank you.
Well, if there are no questions, because I'm sure there are young dermatologists in the audience, there is one point I would like to make. Sometimes we see eosinophils in biopsies of authentic psoriasis. In the note, I always like to write, it would be worthwhile to rule out drug-induced psoriasis. And it is not 100% that the presence of neutrophils always means that psoriasis is drug-induced. But we must keep that possibility in mind.
Thank you, Madam. Your point is well taken. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you very much.
We are now going to listen to an unique presentation on global psoriasis atlas by Professor Christopher Griffiths, sir, an officer of Order of the British Empire from Manchester. May I request Dr. Jaika Thomas, sir, to please take the session forward.
Good morning, everybody. In my role as one of the core organizing team members, it was a pleasure that I could interact with so many of the overseas speakers who are experts in psoriasis. And of them, I would really consider my good friend, Professor Christopher Griffiths, as a real master in psoriasis. He has been heading the International Psoriasis Council for a while. And now I find that apart from being the foundation professor of dermatology in the University of Manchester, he was a past president of the BAD, the British Association of Dermatologists, of the European Society of Dermatological Research, of the European Dermatology Forum. As I told you earlier, he is a co-founder of the International Psoriasis Council and Psoriasis from Gene to Clinic, which is going to be held on the 8th and 9th of December at London, where I'll be part of it. Already 2 of my papers are selected for that. The very impressive point about my good friend Chris is that he's been awarded as the Officer of the Order of the British Empire by the Queen of England. He's Fellow of the Academy of Medical Sciences, Editor-in-Chief, Rook's Textbook of Dermatology, and apart from that, now, currently he's working seriously on the Global Psoriasis Atlas. And Professor Chris Griffiths is going to talk to us today on the Global Skin Atlas. I heard his talk about 2 weeks ago when he did it from the International Psoriasis Council. I'm not sure, but I did hear it. Unfortunately, he's not able to be here with us because it's a Sunday morning. I think he keeps holy the Sabbath day. So we'll be having a recorded version. Gentlemen, can we have the recorded version, please?
Well, hello, my name is Chris Griffiths, and absolutely delighted to be presenting on this important day, the World Psoriasis Day, to the Indian Society of Teledermatology. I'm going to discuss the Global Psoriasis Atlas, which hopefully most of you will have heard about. So psoriasis is a common immune-mediated inflammatory disease, but the question is, how common is it? What is its natural history? And what is the access to best care for the disease globally? The agenda for my talk is as follows. I'm going to talk about the history of the Global Psoriasis Atlas, which I'll shorten to GPA, the structure of the atlas, what we've achieved so far in our current ongoing work, and how the GPA is an exemplar for other inflammatory skin diseases, which we are looking to develop atlases for, and also introduce you to a healthcare survey that we're running at the moment. So for me, my association with the atlas, and really the very sort of beginnings of it, came from a systematic review that Professor Darren Ashcroft and myself wrote and published in the Journal of Investigative Dermatology 9 years ago now. And Professor Ashcroft is Professor of Pharmacoepidemiology at the University of Manchester. And what we found with this systematic review was that there were big gaps in our knowledge. Although studies on the prevalence and incidence of psoriasis have contributed to a better understanding of the burden of disease, further research is required to fill those gaps in understanding the epidemiology of psoriasis and trends in incidence in the disease over time. That meant that really there was a need for a global study of current disease incidence and prevalence. So that was 9 years ago. About the same time, the International Federation of Psoriasis Associations, or IFPA, had been lobbying the World Health Organization through their World Health Assembly to get psoriasis recognized as a serious non-communicable disease. And they require significant praise for achieving this. And indeed, in 2014, the World Health Assembly agreed that psoriasis is a serious non-communicable disease. But with that came the directive from the WHO that there's a need to draw attention to the public health impact of psoriasis and to publish a global report on psoriasis, which included the global incidence and prevalence of the disease and emphasizing the need for future or further research in psoriasis. Then the other part of the equation is that the International League of Dermatological Societies, back in 2011, 2012, when the president was Wolfram Sterry from Berlin, he and I were discussing how impressed we were with what had happened in the mental health community, where they had launched this Grand Challenges in Global Mental Health. And we felt that we should be doing this for psoriasis, and actually for skin disease in general. And so in 2013 in London, Professor Rod Hay and myself chaired a meeting to put together a plan called the Grand Challenges in Global Skin Health. And we looked at a number of different conditions, everything from scabies, skin cancer, eczema, aging, of course. And we focused in on psoriasis because of how common the disease is, and because there's funding and the knowledge to try and take forward a global psoriasis atlas. So we published this in the British Journal of Dermatology, the burden of skin disease, its effect on the life course, its effect on its social impact. And then we laid out in this paper in the British Journal of Dermatology the importance of taking forward research across skin and skin health, but also in psoriasis. To get information about how to set up such a research project or atlas, we ran a series of workshops under the auspices of the International Psoriasis Council, the IPC, where we brought together experts in not necessarily psoriasis, but in skin disease epidemiology in general, and produced this a further paper, the Global State of Psoriasis Disease Epidemiology, a workshop report in the BJD. And then this WHO themselves published a short report, just 60 pages, it's well worth reading, which sets out the research agenda. And again, being a key area of healthcare research is the epidemiology of psoriasis, its incidence and prevalence on the global level. So we had support from the IPC, IFPAR, and the ILDS. And after a lot of discussion, we felt that the best exemplar for an atlas was the one that had been developed by the diabetes community, the International Diabetes Federation. Now in its 20th year, and you can see here, this is what we aspire to. This is a web-based atlas. This is not a coffee table book that you might be used to from an old-fashioned atlas. This supplies all the information you would want to know about psoriasis from any part of the world. This is an example from the Diabetes Atlas. And you can see here they've got the prevalence of the disease, whether it's increasing or not, what access to care is, and how it affects the population, and also the health economics of the disease. So our vision was that the Global Psoriasis Atlas will be the leading epidemiological research on psoriasis globally, thereby informing research, policy, and healthcare provision worldwide for psoriasis. This is the core team that ran the Atlas. We launched it in October 2016 at the EADV meeting in Vienna. And then we got the first tranche of funding from 2017 to 2020. We're now in the second tranche of funding through to 2023. I have the privilege of directing the Atlas. Professor Darren Ashcroft is the research director. Dr. Tatiana Moll is a consultant dermatologist in Zurich. She's our medical coordinator. And Rebecca Swan, also based in Manchester, is our program manager. And then we're linked to the International League of Dermatological Societies through their project manager, Caroline Bach. But the work of the Atlas is totally dependent on our fabulous worldwide network of regional coordinators and also national coordinators. You can see here that we cover the main regions of the world, and some of you will be aware that Professor Raja Kapalan is our Southeast Asia region coordinator. And as you can see, it is very well developed, particularly in the Western Pacific region and also in South America through the auspices of Claudia de la Cruz from Chile and Ricardo Remiti from Brazil. So as I've mentioned, we launched in 2016 and the first phase began in April 2017. The funding comes from industry and the Leo Foundation. It comes to the International League of Dermatological Societies. They act as the fiscal custodian. And so really the first 3 years were spent putting together the mechanics of the Atlas, the website. And that was launched fittingly on World Psoriasis Day, the 29th of October, 2 years ago. And this is the website. You can go onto this to see all the fabulous things which are on this site, everything from basic data about epidemiology through to patient stories. We're now in phase 2. And we are focusing, of course, on epidemiology, prevalence and incidence, increasingly on early diagnosis of psoriasis, the burden of comorbid disease that adds to the overall burden of psoriasis, and importantly, the economic impact to both the individual and to society. This is the key paper that we published. This was the further comprehensive systematic review, which was published in the British Medical Journal about 1.5 years ago now. And this shows with certainty that at least 60 million people around the world have psoriasis. It's probably going to be higher than that, but we know it's a minimum of 60. The prevalence is highly variable, from highest in Scandinavia to low or very low in the Far East. And we only have good data, really robust data, from about 1 in 5 countries. So there's a long way to go. This is where we need your help. So Some examples of further work that we've done. This is work in our colleagues in Israel using electronic health records on the Clalit Health Services. And what we're able to show here that there's been the prevalence of psoriasis is increasing, but the incidence is stable. And the way that we've seen the same in the United Kingdom, and we've seen the same in Taiwan. And the way that we interpret this is that the prevalence is increasing, and that's because people with psoriasis are living longer than they were previously. They still live shorter lives than people who don't have psoriasis with the general population, but we're now getting more people who are living to a greater age. So the incidence is not changing, but the prevalence is. We've also done some work recently in Chile using their waiting list repository, their national one. This was work showed that the incidence of psoriasis in Chile is about 22 per 100,000 patient years. So it's appreciably less than we see in Europe, which may be about 4 times that. And interestingly, late-on psoriasis occurring for the first time after the age of 40, seems to be more prevalent than early onset disease, psoriasis occurring for the first time before the age of 40. So it's the opposite to what we see in Western Europe and the United States. We have 3 PhD students who are working very closely with us on the atlas: Maha Abu Tabik from Iraq, Alex Trafford from the UK, and Paisley Ngambi from Zambia. I'll show you a little bit of their work. So this is the work that Maha has been doing. And one of the things we've realized when we've been traveling the world and talking to people in the field, particularly say in Tanzania or Myanmar or Bangladesh, is that quite often the default diagnosis for people with psoriasis is tinea corporis. So it's inaccurately diagnosed. It may take a long time before the diagnosis of psoriasis is confirmed or actually thought about for the first time. So this may sound pretty obvious, but what we have done is to develop clinical diagnostic criteria for making a diagnosis of psoriasis in the field by people who are not necessarily dermatologically trained. So there's an essential clinical diagnostic criteria, which is a well-demarcated lesion with or without silvery white scales, and then at least 4 of these 8 supportive diagnostic criteria. And of course, note here that we don't refer to the term erythema, and we are cognizant that in deeply pigmented skin and brown skin, lesions may be grey in colour and not pink or red. And this was work that was done working closely with the International Psoriasis Council, and we ran an E-Delphi exercise with a number of over 50 of their dermatology experts, their psoriasis experts. The next phase of this is now to develop a feasibility testing of a training tool for psoriasis diagnosis to be used in the field. And what we've done here is so we're taking a leaf really out of what's been used in natural history. So these are drawings or paintings of psoriasis to bring out the key diagnostic criteria. And we're going to use this training tool in addition, or to be used alongside the clinical examination-based diagnostic criteria. This is the work that Alex Trafford has been doing, looking at the association of psoriasis with cancer. Now, we know that skin cancer prevalence is increased in people with psoriasis because of certainly in the Western world, because of the association with ultraviolet radiation and sunlight, which patients use to try and maintain control of their disease. But what we've been able to show, there's a 22% relative risk of cancer occurrence in severe psoriasis and 22% relative risk of cancer mortality in severe disease. And overall, there's a risk of cancers. So squamous cell carcinoma, basal cell carcinoma, yes, of course, but also lymphoma, esophageal cancer, hepatobiliary cancer, pancreatic cancer, and bladder cancer. And we're now running cohort studies in the UK, Denmark, Israel, and Taiwan, looking at the incidence of cancer, site-specific cancers, and then looking at cancer mortality. We're not able to do this in Israel because there's no linkage to mortality data. But the preliminary information from this, which will be presented at Psoriasis from Gene to Clinic, is that we're seeing the same cancers across these 4 global populations. Before COVID came along, we were able to do some field studies. This was work that was done, funded by the Grand Challenges Research, the Global Challenges Research Fund, where we were able to take a team to Tanzania to work at Moche, the Regional Dermatology Training Center. Some of you may have visited there in Kilimanjaro, Tanzania. And Tanzania has a population of 57 million people with just 31 dermatologists. So the diagnosis and treatment is by necessity from non-specialist healthcare workers, and that's where what we found was that the diagnosis is often not made very early on. Topical therapies are mainly coal tar, salicylic acid preparations, and methotrexate is the only systemic therapy that's used, and then only used sparingly because the patients have to travel maybe for 2 or 3 days to get to the Moshi Dermatology Center. Because of the difficulties in access, methotrexate is only used for about 6 months at a time. We did a couple of field surveys. There'd been one study from the northern lake area, of northern Tanzania, done several years ago by a registrar at that time, Sam Gibbs, who sadly passed away earlier this year, who showed that there was probably at a 0.1% prevalence of psoriasis, therefore making it probably pretty rare. And that's exactly what we found. We saw 300 people and there was no psoriasis. Following the directive from the WHO, which is that it doesn't matter where anyone with psoriasis lives around the world, whether it be Bulgaria, Bolivia, Britain, Bahrain, they should get access to the best available care locally. And Tatiana Moore is, as I mentioned earlier, is our medical coordinator. When she was a registrar 3 years ago, she visited South America and visited 11 countries in South America to take forward this healthcare survey. And this is the basis for what she is now, I'm going to tell you about. So the sort of data that she was collecting was drug prescription data, the proportion of dermatologists able to prescribe systemic drugs in any one country, and this is in South America, wildly variable from Ecuador, from Bolivia, which are the lowest, to Costa Rica, which is the highest. So this global healthcare survey or study, which any of you can take part in, is the global mapping of psoriasis to gain a better understanding of the common psoriasis characteristics, but also the available treatment options and the differences in quality of life, the burden of disease, and the influence of the level of education on the treatment response. So this is, as I mentioned, based on work that Tatiana did. She visited Chile and Brazil as part of an IPC research fellowship. Beginning of 2020, I was able to have the pleasure of accompanying her for the first week or so of this survey in Chile. And she visited 43 centers, 27 in Brazil, 16 in Chile in the early part of 2021, and saw almost 1,500 patients. This is the sort of data that she's got, is that if you compare Brazil in the light blue with Chile with the dark blue, you can see here that in Chile there's a difference in the access to treatment of patients with moderate to severe psoriasis. And then if you look at the severity of disease, the disease is maybe a little bit more severe in those patients who are seen in Chile, but not a lot of difference between the two countries. This global healthcare survey, which is electronic, you can gain access to this. It would be fantastic if we can get data from India. This is sort of the screenshots that you will see. And everything down to the treatments that they're using. We're doing some other studies, of course, around the world. We've been rather limited in what we can do in the field because of COVID, but things are starting to open up again now, and hopefully by 2022, we'll be back out in the field. This is a study we're doing with Dr. Chun in Johor Bahru district in the state of Johor in Malaysia, where we're using their population electronic health records to look at psoriasis prevalence. This is in Qatar with Professor Martin Steinhoff. They have a population of 3 million, large number of patients with psoriasis, very good electronic patient records, and we're mining that information, particularly looking at multimorbidity, diabetes and cardiometabolic disease. This is with Professor Wayne Gulliver, Professor Proton Raman from Newfoundland in eastern Canada, where they have a sort of founder effect population, very large cohort of psoriasis patients who have been followed up for close to 20 years. And here we're going to look at epidemiology, comorbidities, particularly cardiometabolic syndrome, and the economic impact of psoriasis in that community. Then in Myanmar, with my colleague, Dr. Sue Lewin from London, we were planning to, we set up a charity, the Burma Skincare Initiative, to promote excellence in skincare in the country. And we were hoping, actually, beginning of this year, to visit the country again to do further work on an epidemiological survey, the healthcare survey as well, and also to establish a patient association in Myanmar. Of course, not only do they have COVID, but in February this year, tragically, there was a military coup in the country. So really our attention is now turned to essential emergency skincare. But we're hopeful that we can run a workshop, probably by webinar, early next year. And then moving from to another part of the world completely, in Greenland, very large country indeed, with a small population, just 58,000, no dermatologists. And we are looking to do an initial pilot study with Professors Jacob Tyson and Klaus Zachariah from Copenhagen in May of next year to gain information about the key aspects of psoriasis in that country, and then put those questions into the healthcare census, which is going to take place in Greenland in 2023. And then Tatiana Moore, working with Alexander Navarini from University of Basel. We are looking now at pustular psoriasis, doing linking in with the Global Psoriasis Atlas to do an international global survey of the prevalence of pustular psoriasis. So we'd like you to engage with us on social media. We have a very strong social media set up with both Twitter, Instagram, Facebook, and this is the crucial way that we can interact with patients and also yourselves. So for instance, this is on the Atlas, this is on the website, Important to Talk About Psoriasis. This is just an example of something just recently. Psoriasis has tweeted 20 times the past 24 hours. So it's important to talk about psoriasis. We've got patient involvement. This is one of my patients from Manchester, talking about the Global Psoriasis Atlas. This is a patient, Paul, from the Philippines. You know, these quotes are so important. Now, I have psoriasis, my sickness does not define me. I think that is crucial. These people know that there's help available. And then this is Barbara Hannon, another psoriasis patient from Sweden. So you can find us on Facebook, LinkedIn, Twitter, Instagram. The Atlas is moving from strength to strength. It's now viewed by the dermatology community as an exemplar for other skin disease atlases. We've had very positive discussions with Professor Carsten Floor, representing the eczema community. We now have funding to set up a global eczema atlas. And then with colleagues, your colleagues in India, we've had very good positive discussions about the vitiligo atlas, and to a lesser extent, the hidradenitis suppurativa atlas. So this is our website address. You can go onto that, you can download the data from your region and country, and you can access all of our resources and subscribe to our newsletter. These are the contacts again. Rebecca Swan is probably the most important person here, this contact. And this is the Atlas again. These are our funders, the Leo Foundation and industry, but we're arm's length from industry. That comes funding comes through the ILDS. So thank you very much for your attention. I'm sorry this is that you'll be viewing this over the weekend, and I probably won't be able to join you for questions most likely, but I'm very happy to take questions by email at a later time. So thank you so much.
Thank you very much, Professor Griffiths, for this presentation on the Global Psoriasis Atlas. This is a very new concept to the Indians, I'm very sure. And I must tell you, particularly impressed about the comorbidities that you had mentioned, particularly about the cancerous comorbidities. We all know about the cutaneous comorbidities that could occur with psoriasis, but the systemic comorbidities that you mentioned about are very impressive. I must promise and assure you that my colleagues from India and I are certainly very eager to be associated with your global psoriasis atlas. And all you have to do is have to pinch us and we'll be there to work along with you. Thank you very much once again for being with us, although not physically, virtually. We look forward to meeting you very soon in person. Thank you.
Thank you, sir, for the brilliant presentation. We now move on to the next presentation on psoriasis in Libya, War, Medical and Economic Burden, by none other than Professor Ibrahim Al-Mukahal, sir, from Libya.
I'm back again in this virtual program to introduce Professor Ibrahim Al-Mukahal. He is also due to his preoccupation, not able to join us live. So we have a pre-recorded version from Professor Ibrahim. This is the first time we are getting to meet him. As a matter of fact, a dermatologist from Benzahir, Libya, this is the very first time that we get to meet each other. The Professor Ibrahim is Professor of Dermatology, Faculty of Medicine, University of Benzahir. And his educational qualification quite impressive. Apart from his MD, also holds an MSc and a PhD. He's part of the SPIN Foundation, where I am also involved, the Skin Inflammation and Psoriasis International Network, head of the Psoriatic Unit of Benghazi Medical Center, training supervisor of Libyan Board of Dermatology, member of Arab Board of Dermatology, Jordan. All are places, or the names of places which we are quite familiar with, particularly Libya as a country. But then we are not familiar with a dermatologist from Libya, and we are very lucky indeed to have him with us. Can we have his presentation, please?
Everybody, I am honored to participate in World Psoriasis Day by Indian Society. My talk today will be about psoriasis, war, medical, and economic burden. Psoriasis is a chronic inflammatory skin disease with no clear cause or cure. Psoriasis affects people of all ages and all countries. The reported prevalence of psoriasis ranging from 0.9 to 12%. Psoriasis is a serious global problem with at least 125 million individuals affected worldwide. Psoriasis has an unpredictable course of symptoms, a number of external triggers, and significant comorbidity. The etiology of psoriasis remains unclear. The role of the immune system in psoriasis causation is a major topic of research. There is evidence of genetic predisposition. Psoriasis could be an autoimmune disease, but no autoantigen that could be responsible has been defined yet. Psoriasis can also be provoked by external and internal triggers, including mild trauma, sunburn, infections, systemic drug, and stress. The prevalence of psoriasis in general population of Libya is unknown. There is gaps in data. It has been reported sporadically in isolated hospital-based studies. Registration of psoriasis cases is not necessary in a clinics, and therefore real result data are difficult to find. It's also difficult to assess the prevalence and incidence in Libya due to the massive population movement associated with war situation. More than 1 million people displaced in other Libyan cities or immigrated to other countries. In Benghazi, Libya, until December 2020, a total of 4,700 Libyan patients registered in Psoriatic Unit Benghazi Medical Center. The current result lead to some questions in the change in the prevalence and incidence rate of psoriasis during the war situation in war burden. We note in our practice the relation between the appearance and course of psoriasis under the extreme conditions of war in Libya. The negative impact of this condition on people's life can be immense. A number of our patients were soldiers in active duty, civilians enrolled in army, paramilitary formations, civilian living in an area that was frequently shelling from the nearby front line. The stress event in the front line, injuries, killing, leg amputation, the fighting against friends and relatives of the same family, which they now belonging to the enemy side, accelerate exacerbation of psoriasis. Most civilians described their stressful event and psoriasis as strong and catastrophic after losing of their family members and poor psychological support. The Libyan fighters usually do not like to complain about the stress. They have to be brave, and some of them give us an order to give the injection which ends the psoriasis. Psoriasis causes great emotional, social, economic, and medical burden. Quality of life in general is often significantly impaired. Psoriasis is more stress sensitive than many other diseases. The state of war in Libya affects many psoriatic patients. Patients experience bad days when psoriasis flares. Aggressivity, depression, anxiety, social phobia, sexual dysfunction have been reported in our patients. Cost and availability of essential medicines. The treatment used for various skin disorders, including psoriasis, can be expensive, lifelong, and often not completely financed by healthcare authority. Self-funding of treatment often difficult for the patient and their household budget. Due to the war situation and shortage of the cash liquidity in Libyan banks made the people unable to get their money from their accounts. Economic burden for treatment expense can add a significant socioeconomic burden on an individual level. The costs of psoriasis are significant for both patient and healthcare authority. There is a little information concerning the real cost of psoriasis incurred by our patients. Patient visits to public hospitals are free of charge. Systemic traditional medicines and emollients are often not available in governmental hospitals, so they must buy them from private pharmacies. The majority of moderate to severe psoriasis patients are still treated with topical steroid, Divonex, Divobet, and topical immunomodulators. Non-biological systemic therapy, including acitretin, cyclosporine, methotrexate, and phototherapy. To whom conventional therapy or phototherapy are inadequate, for example, patient have blood pressure, we can use cyclosporine, or lipido profile high, also acitretin, we can use patient with renal disease, cyclosporine and methotrexate. Liver disease, we can use cyclosporine, methotrexate, and PUVA. Patient with arthritis, psoriatic arthritis, phototherapy and cyclosporine, not effective. Patient have heart failure, can use tumor necrosis factor. Patient with inflammatory bowel disease or Crohn's disease, we can use interleukin 17, ixekizumab or secukinumab. There is significant advance in the treatment of psoriasis during the last decades, including new generation of biologicals and JAK inhibitors. Biologic therapy became available in Libya for the treatment of psoriasis with tumor necrosis factor alpha blockers, Remicade, in 2006. And the first patient was treated in our department, which is later bombed and destroyed. The current available treatment in dermatology departments in Benghazi and Tripoli, including ustekinumab, infliximab, and ixekizumab. The cost of treatment is fully covered by Ministry of Health. During the years of 2018 and 2020, 3 years, Remicade, Remsima, this is biosimilar, Stelara, and Taltaz were used for our psoriatic patient. Total of 243 psoriatic patients were treated with these drugs, 106 with ustekinumab, 2 of them with hepatitis B, and 2 children, 11 and 13 years old, 82 patients with infliximab, Remicade or Remsima, 2 patients with hidradenitis suppurativa, and 46 patients with ixekizumab, Taltz, for psoriasis and psoriatic. This is some of our patients with severe psoriasis, which involving visible area and sensitive area, which maybe get a good result with biological treatment. Also, this is a severe palmoplantar psoriasis treated with biologicals. Phototherapy is not available in hospitals in Benghazi, only found in some private clinics, and has been estimated to be costly for our patient, travel cost and time cost. The biologic therapy costs is fully covered by Ministry of Health and have led to that Libyan patients favoring biologic therapy over phototherapy, fast and free. This lead to higher total cost for the Society for Psoriasis treatment. Patients receiving systemic medication and or phototherapy have higher costs than those who were receiving only biologic treatment. Unmet needs and recommendation. There is a need for better quality data on incidence and prevalence of psoriasis in Libya to understand better the size and distribution of the problem and appropriate healthcare, specific guidelines for the management of psoriasis in Libya, specialized clinic involving both dermatologists, rheumatologists to improve early diagnosis of psoriasis and psoriatic arthritis, a patient education in the form of collaboration between patient and medical societies, allow more dermatologists access to new therapy through conferences and scientific meeting, increased cooperation between the governmental and manufacturing companies, free samples through free samples. Additional care for patients with psoriasis require not only treating skin lesions and joint involvement, but is also very important to identify and manage common comorbidities that already exist or may be developed, including cardiovascular and metabolic disease, as well as psychological disorders. Thank you.
Thank you very much, Professor Ibrahim. for your nice presentation. In short, I would want to call it as psoriasis in uniform and ununiformed. Because the way you had really put the pieces like a jugglery piece together, it was really very interesting to listen to the different developments that have been taking place. I have been as a visitor to Libya more than 25 years ago, and somehow we didn't get to meet each other at that time. I wish we had, but I'm sure we'll be meeting each other more frequently, if not in person, at least virtually. I don't see any questions coming up in this, so we are extremely grateful to you, my colleagues and I, for accepting to be part of us. Thank you once again.
Thank you, sir, for the vivid presentation. We will now listen to the pre-recorded session by Professor Najib Das, sir, from Tunisia on the topic Nail Psoriasis Differential Diagnosis. It is my pleasure to invite Professor Jaika Thomas, sir, Head of Department at Chetnad Academy of Research and Education, to please take the session forward.
Professor Najib Das, a popular name, not only in his own country, in Tunisia. He is well known to us in the American network where we keep discussing cases. And he has, to us herself in India, been an earlier speaker. Now, Dr. Das, Professor Najib Das, the Professor of Dermatology at Tunis in Tunisia, is the Board of Directors for the International Society of Dermatology. And I'll be telling more things because when we pre-recorded his talk, my colleagues, Professor Parimalam Kumar and Professor Yuva Dhanlakshmi, who are the chairs and co-chairs of the scientific schedule today, were also there along with me. And we really had a wonderful good time with Professor Das, and we learned a lot. We did learn a lot from him, which you'll be seeing shortly. Can we have the recorded version, please?
Hello, everybody. It's nice that we have with us Professor Najib Das, who's a professor of dermatology in Tunisia. He's been holding several posts. He's with us, and that too, his favorite topic is psoriasis, and that too nail psoriasis. Professor Najib Das, can we have your presentation, please?
Okay, thank you very much for inviting me. I'll be talking about nail psoriasis differential diagnosis. Conflict of interest known. You know, the prevalence of nail psoriasis varies between 15 and 80%. The impact on quality of life is evident. And nail psoriasis have a broad spectrum of nail dystrophy which are associated with psoriasis. And differential diagnosis between nail psoriasis and other nail dystrophy could be very challenging. So psoriasis may affect all the components of the nail unit, and diagnosis will be discussed as it may involve each part of component in turn. So we will start with the matrix involvement. And nail matrix feature include pitting, leukonychia, a red spot in the lunula, and crumbling. So nail pits are superficial depression in the nail plate that move distally with nail growth. These are pitting. Nail pits are due to psoriasis of the proximal nail matrix that causes abnormal keratinization with the presence of parakeratotic cells in the uppermost surface of the nail plate. Pits are typically irregular, spaced, and almost exclusively seen in the fingernails, with rare occurrence with 2 nails. The number of pits is important because when they are less than 20, the diagnosis is non-specific, and when they are more than 60, the diagnosis is more evident. And moreover, the incidence of nail pitting rises with increases in the severity of psoriasis. It has been shown that regular pitting could be converted to rippling or ridging. Both lines are a consequence of sporadic irritation of the nail matrix and may spread to the nail plate, resulting in an important loss of the nails. What is pseudo-pitting, which has been reported by Dexa, which is uncommon in this reported clinical case that salmon-colored patches and pitting were a consequence of the involvement of the only nail bed and not matrix. Nail pitting should not be confused with other diseases because they may be seen in alopecia areata, eczema, and lichen. Another nail matrix feature is onychomydesis, which is the separation of the nail plate from the matrix area. It could be, a sign of psoriasis and also as a side effect of retinoid used in psoriasis. Onychomydesis has been associated with infection, autoimmune diseases, critical illness, and any medication. Another sign of the involvement of nail matrix in psoriasis, trachyonychia. It is characterized by a roughness of the nail surface. Trachyonychia may be related to lichen planus, alopecia areata, chemotherapy, and ichthyosis. In psoriasis, the nail may be affected by true leukonychia due to involvement of the matrix, but the middle and the distal part of the matrix. And apparent leukonychia due to onycholysis and by parakeratosis deposit in the nail bed. And leukonychia could be seen in onychomycosis. And other apparent leukonychia in anemia. Punctate leukonychia is usually due to repeated minor trauma to the matrix. Psoriatic red lunula. Red spot in the lunula are a result of a modification of the amount of blood beneath the nail. So, red lunula could be seen in lichen, alopecia, could be congenital or idiopathic. And now, let's move to the nail bed features. And the first one is subungual hyperkeratosis, which is an accumulation of scales beneath the nail plate. Subungual hyperkeratosis involves the distal nail bed and hyponychium. In psoriasis, subungual hyperkeratosis is usually silvery white, but may be yellow or green or brown if there is secondary coloration. Subungual hyperkeratosis is most commonly found in nail psoriasis, ichthyosis, onychomycosis, and also onychomycosis, different type of onychomycosis, in Dari disease, lichen, in calcinosis, calciphylaxis, or that it could be seen in Crassus capitis, Sézary syndrome, and so on, and chronic eczema. Onycholysis is a nail bed fissure. The detachment is due to a significant lesion at the hyponychium where parakeratosis interfere with the adhesion of the nail plate to the nail bed. Onycholysis usually originates distally and or laterally and advances proximally toward the nail markings. This separation occurs along a convex line. An erythematous border around the onycholytic area is diagnosed for psoriasis and most frequently seen in fingernails. Bacteria and yeasts may invade more easily in the presence of onycholysis. And the two main causes of onycholysis in the two nails are trauma and onychomycosis. So differentiating distal subungual onychomycosis from psoriasis is especially challenging, especially in the two nails. Onychomycosis can be distinguished by the presence of other nail findings, particularly yellow patches and stripes. Other dermatologic conditions caused onycholysis include eczema, lichen, the oil drop or salmon patch discoloration is a yellow rich brown drop that occurs in the nail bed and or the hyponychium. The oil drop may be seen in the central part of the nail, or it may be surround an onycholytic area in the distal nail bed. Splinter hemorrhagic also involves the nail bed and appears as a thin, linear structure, usually not greater than 2 to 3 millimeters, arranged in the long axis of the nail. Several conditions other than psoriasis may cause distal splinter hemorrhagia. They can also be found in onychomycosis and eczema. Psoriatic paronychia. This suggests that scales formed and retained beneath the proximal nail fold act as foreign bodies. There is neither inflammatory cells nor fungal material. These are some cases of psoriatic paronychia. And chronic paronychia may be associated with nail infection caused by moles, pemphigus, acrodermatitis, psoriatic matrix. And when we have the possibility to have nail matrix and nail bed involvement in psoriasis with different, nail crumbling is a nail feature which is related to a thick dystrophic nail plate as well hyperkeratotic nail bed. Yet some cases of nail psoriasis, pustular psoriasis, sorry. Yes, so nail psoriasis and onychomycosis. As you know, onychomycosis may mimic each type of presentation. So to differentiate onychomycosis from psoriasis is especially challenging in the tulips. It is important to consider the possible coexistence of both diseases, which was reported to occur in 50% of patients. For example, this patient, he had 2 big tulips, and he had also onychomycosis and psoriasis. Onychomycosis can be distinguished by the presence of other nail finding, particularly yellow patches and soils. These are some cases of onychomycosis and psoriasis. We have here a new pad. This paper is talking about the expression of antimicrobial peptide in nail psoriasis and normal nails. It discusses the increase in AMP in psoriatic skin lesion and the role as an autoantigen in psoriatic patients. So, which is the diagnosis? A clinical diagnosis of nail psoriasis can be different, as the symptoms are common features of many nail disorders. The presence of multiple signs in different nails is highly suggestive. More than 50 irregular pits in the fingernail, onychopathy with erythematous border and salmon patches in the nail bed, for example. Another sign, which is the inefficiency of antimycotic treatments. And don't forget, laboratory investigation is essential, and dermoscopy and histopathology may be of great help in the diagnosis. Many studies have shown the importance of dermoscopic features in nail psoriasis. The most frequent observed signs are splinter hemorrhage, pitting, and distal onycholysis. So take home message. Nail psoriasis has several clinical manifestations, especially pitting and onycholysis. About 1 to 5% of patients manifest with nail change only. Don't forget, always rule out onychomycosis. They can be combined. Therefore, a correct diagnosis is the key of the implementation of successful treatment. Thank you very much, and looking forward to seeing you face to face next time.
Thank you very much, Professor Najib Das. Can we have a very short discussion, if you do not mind?
A short
discussion on the topic?
Yeah.
Thank you.
Of course.
I have 2 of my colleagues. You already met Dr. Parimlam, who's a scientific chairperson. I have one more colleague, Dr. Dhanalakshmi, Could you put your video on, please? Who is also part of the scientific committee, and she's the joint scientific chair. It is very, very interesting, Professor Das. Particularly, I like the take-home points when you said multiple signs in different nail plates. That is one thing which I have never heard of so far. Pitch in one nail, onycholysis another nail, subungual hyperkeratosis another nail. That is fantastic. That would really help, particularly the residents, if I tell them this when I go back to work. Look for multiple signs in different nails. Of course, about the number of pits, regular or irregular pits, we already keep telling about 20. Some people say 20, some people say 50. You said more than 50 irregular pits that could be there. And another important point that I did appreciate and I have to pass on, when they are doubtful, give a course of antimycotic treatment. And if the nails do not show any changes, then probably you are looking at psoriasis only.
Yeah.
On the other hand, maybe if you try a drug like methotrexate on these patients, and if they do show some improvement, then we could think of psoriasis. But if they worsen, then we know that they're getting immunocompromised and the fungal elements are growing more and more. Am I right?
Yeah. So you have, I don't know exactly what happens in India, but in India we have a problem, especially with GP, general practitioner. They have almost no training in dermatology. So everything on the nail for them, it's onychomycosis. And I have seen patients who have been treated with onychomycotic during 2 years without any improvement, And it was simply psoriasis. It can be combined. We can see a little improvement, but not more. Not more. So what we are doing here, especially on the International Psoriasis Day, we are doing a session, a training session for GP to show them the difference, if it's possible to show them, the difference between onychomycosis and nail psoriasis. And to tell them if you don't see any improvement, you have not to continue with antimycotic. You have to change the idea, to change the view, and to think of other diagnoses. Maybe psoriasis, maybe lichen also. So
I wish that I could be part of those tutorials that you're planning to take to differentiate onychomycosis from psoriatic nails. Let's see, I think my colleagues will also have some points to add on. Professor Parimalam and Professor Dhanlakshmi. Yes, Dr. Parimalam.
Sir, good evening. Professor, sir, good evening. I am Dr. Parimalam. Am I audible, sir? One important point which you mentioned, erythematous border along the onycholysis.
yeah,
Is really very useful for us because in our area we see a lot of onychomycosis and it is indeed difficult for us. So with this one erythematous border, if you are able to see, and if you are not able to find fungal elements on 3 repeated scrapings and nail clipping examination, we straight away go and treat the patient as psoriatic nail. And I have one doubt, sir. What is your experience if there is an isolated nail with subungual hyperkeratosis? How would you proceed?
yes.
Single nail with subungual hyperkeratosis. There is no other finding as pitting, no area of dermatophytosis in the skin.
Yes, The erythematous border is very important for the diagnosis of nail psoriasis with onychomycosis. And there's another problem or another point to be pointed, that many, even for onychomycosis, when you have investigation, laboratory investigation, you have to check with, a laboratory who has the skills, because any laboratory can't make the diagnosis of onychomycosis. Every examination is coming with positive. So I would be very happy to share with you some clinical cases if possible.
Yes, sir.
Clinical cases. If you have clinical cases, we'd be very happy to share them with you, and we can discuss that. And Professor Thomas, we are together in RxDerm, with the group RxDerm. You don't know?
I'm not able to get you, Professor Das. Tell me again.
RxDerm, with the group RxDerm, with Stephen, with Pam.
No, I'm not in that group.
Above. Because I think I saw you posted something, no?
No, I'm not in that group. Yeah, I'm with the spin, but I'm more towards alopecia and hair disorders and alopecia. I am in the scientific committee of the spin, and I wish I could really join in most of your tutorials. You know, it's lovely, lovely.
Maybe we'll meet each other in Paris next year.
Yes, we will. We will do that.
Fantastic.
Already, Anne-Claire has sent me an invitation. I will be there.
So please feel free to tell me, what do you wish from Tunisia?
I'll tell you. We're going to meet more often. Dr. Dhanalakshmi, Professor Dhanalakshmi, she is a recently retired professor from the premier institution, Madras Medical College, where currently Professor Parimalam is. Yes, Professor Dhanalakshmi.
Good evening, sir.
Good evening. Good afternoon.
Actually, very good, sir. Thank you. Sir, and the onychomycosis for a dermatologist is difficult to diagnose when we have a doubt whether it is due to psoriasis, whether due to eczema or lichen planus. We have to think so many diseases which can cause nail changes. For a general practitioner, for every nail change, they think it is only onychomycosis, fungus. They not even think about whether it is dermatophytosis or any other molds. They treat empirically only fungal infection like that. Even I had a recently one case that treated with the itraconazole for 6 months, daily 200 milligram like that. Without any improvement, patient came. Then on searching, I luckily got some patches on the back and some other knee, somewhere patches, psoriatic patches. So that is, of course, it is proving that it is psoriasis, not improving with antifungal treatment. So it is difficult when they coexist, sir, when fungal infection and also the psoriasis nails coexist. That time, as sir, Professor Jacob Thomas sir told, we have to treat the fungal infection first. I think that will be the better thing, sir. So after treating the fungal infection, we have to go for the psoriatic nail. Of course, when we treat other ways with the psoriasis, along with the other body parts, this also will start responding most of the time. Is it so, sir?
Yeah. And for onychomycosis, the treatment is well known, and especially we have to remove the maximum of the nail plate to reduce the duration of the treatment. But the onychomycosis, especially mold infection is very difficult to treat. With antimycotic and everything, it's very difficult to treat. So these cases may be very challenging with psoriasis. So we have to check the whole body, especially the scalp. Maybe we'll see some lesion of psoriasis or the examination order to check the whole body is, for me, is mandatory. We don't have to focus only on the nails or on the only one part of the body. A full exam is mandatory. I assume that the diagnosis, especially when we have only lesion or nail lesion, could be very challenging, very challenging. Professor Thomas, I will send you some cases which were very challenging, and you will see the difference after treatment only with topical treatment.
That's indeed very kind of you, Professor Nath. Indeed, very kind of you.
My pleasure, my pleasure.
We'd love to have.
I will
Yes,
send
Professor.
you this photo. I will send you this photo.
Please.
And you can share them with your
Very
colleagues.
kind of you. Very kind of you. Yeah, Professor Parimalam, you want to say something?
Professor, sir,
Yeah.
in your vast experience, do you think nail psoriasis is closely associated with arthropathic psoriasis? Has it got any significant?
When you have nail psoriasis, the arthritis component often is almost here. So it is often associated or combined with arthritis. As prognostic, nail psoriasis, I think, is the first step for arthritis, and we should be very, very, very aware about that.
Thank you, sir.
Now, all this while, the teaching is affection of the nail bed. You can get the oil drop site, you can get onycholysis, subungual hyperkeratosis, splinter. When the nail matrix involved, pitting, crumbling, leukonychia, red spots. Yeah, so that's what we have been teaching, you know. And today, I must tell you that I personally learned a new lesson. When you get multiple signs in different nails, you can bank on a diagnosis of psoriasis. But one last question, Professor Nath. What is your experience with nail psoriasis in children?
In children, I have some cases, especially pustular psoriasis. Especially pustular psoriasis.
Yes, okay.
Especially pustular. I have some cases, but not as in adults. But the same things, the same feature could be seen in children.
Because I have had difficulty in differentiating, because I've worked in pediatric dermatology for about a decade. I found it difficult to differentiate the pitting in psoriasis in children and pityriasis rubra pilaris. There's always been a difficulty unless and until I do a biopsy or a skin lesion and then decide on it. So with the permission of my colleagues, Professor Parimalam Kumar and Professor U.R. Dhanlakshmi, I really grateful to you, Professor Das. Please share your pictures with us and please join us whenever possible. Okay? Namaste to you. Namaste in India means good morning, good evening, good afternoon, good night. Thank you very much.
Thank you. It was my pleasure.
Thank you, sir.
In Paris.
Yes, we will meet in Paris.
You know, I know the city very well. I can be your guide to the city.
I'm really honored. I'm really honored. Bye-bye.
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 Right.
Bye-bye.
Thank you, sir.
Thank you, sir.
Have a great
Thank
day.
you, sir. Thank you.
Stay back, Parimalam and Dana.
Yes, sir.
Nazreen, give us some time, please. We want to have a small discussion.
Sir, Nazreen can stop the recording, right?
Thank you very much, Professor Najib Das. We have a few questions coming up, and I see that Dr. Punchi from Amaravati has asked, kindly discuss the duration of treatment, side effects, recurrences, the financial aspects. I can discuss few of them only. The duration of treatment would much depend on the type of psoriasis and the type of modality of treatment that you're using. Similarly, the side effects also. Recurrence rate is quite high, but I always keep saying even remission is low. So where's the question of recurrences? And financial aspect again depends on the molecule that you use. If you're going to use a poor man's cyclosporin, like methotrexate, it's fine, but the duration of treatment has to be taken care of. I will now request my colleague, Professor Parimalam, to answer another question from Dr. Punchi. Have you seen any case of onychomycosis and psoriasis of nails? Kindly comment. He means in the same, not, you would have seen number of onychomycosis, number of psoriasis of nails. The question is in the same patient.
When we have a doubt whether it is psoriasis or tinea angoium, we do a scraping. In a known patient with psoriasis having nail psoriasis, sometimes scraping results do come as positive and indicates coexistence of psoriasis and nail fungus in the same patient. For such patients, we do treat them with systemic antifungal drugs.
Thank you, Professor Parimalam. I have a question for you, my good friend, Professor Dhanlakshmi. Same Dr. Punchis wants to know, and I have a few comments from you. He says, I have seen a case vitiligo, psoriasis, and lichen planus. I'm sure, again, he means in the same patient. Your comments, please, Professor Dhanlakshmi.
Of course, very rarely we see this combination. Normally, psoriasis, lichen planus, they are good friends, as well as psoriasis and vitiligo, they are also good friends. But 3 in 1 patient is difficult. But we have to treat which is more symptomatic. And vitiligo is a long-term treatment. Maybe psoriasis, maybe the burdening the patient. So we have to attend the psoriasis first. And while attending the psoriasis, most of the drugs which acts on psoriasis also works on the lichen planus. So they will do better with that. Vitiligo can be taken as a last one. So because that is an asymptomatic and also it takes long time. But most of the time the JAK inhibitors, what is available now in the market, it is useful in all the 3. So that can be, it's worth trying on that.
Thank you very much, Professor Dhanlakshmi. That was a nice comparison of being very good friends, and maybe we could call them as first cousins, because all the 3 of them are IMIDs, immune-mediated inflammatory disorders. So there's no surprise whatsoever, Dr. Punchi, that these 3 can occur in the same individual. And as what Professor Dhanlakshmi rightly pointed out, the JAK-STAT inhibitors, which I'll be talking about post-lunch, are a single molecule that can be useful for all the 3 diseases. Thank you very much. With this, we'll close the session, and I request the computers to take over.
Thank you, sirs, for the wonderful talk and for sharing your knowledge with us. We will now move on to the next session on nail psoriasis. Dr. S. Vaishnavi ma'am from Chettinad Academy of Research and Education is present with us in the venue to make her presentation on nail involvement in psoriasis. And Dr. Dinesh Kumar sir is here with us to chair the session.
Thank you and a very good morning to everyone. So the next session is on nail involvement in psoriasis, carrying forward the discussion on nails and psoriasis. We have with us a young dermatologist, Dr. Vaishnavi S. She is a senior resident from the Chettinad Academy of Research and Education. She has completed her MBBS from Chettinad itself and MD Dermatology from SRM. Dr. Vaishnavi, I request you to start your talk, please.
Thank you, sir. A very good day to one and all present here. I'll be presenting a short topic on nails and psoriasis. So, psoriasis of the nail unit usually occurs along with skin involvement, or it can also occur alone as the only manifestation of psoriasis. It has a very strong association with psoriatic arthritis. And the prevalence among patients with pre-existing psoriasis is between 4.2% and 74%. The lifetime incidence, though, of nail psoriasis can be as high as 90%. Isolated involvement is quite rare, between 1 to 5%. A mean delay of 9 and 11.5 years has been reported in the onset of nail psoriasis, and this may be the reason for the lower prevalence of nail psoriasis in children. Nail psoriasis has a very detrimental effect on the psychological as well as the physical aspects. So it can cause severe pain in the patient. It is associated with significantly worse psoriasis severity scores. It also causes embarrassment and stigmatization to the patient because of the nail lesions. It is also associated with a poorer quality of life and a greater number of days unfit for work. There's an increased prevalence of anxiety and depression among patients who have nail psoriasis. And it is more often patients with nail psoriasis suffer from psoriatic arthritis very commonly. So coming to the significance of nail involvement in relation to psoriasis as a whole, nail psoriasis is associated with a greater severity of psoriasis, and it's very common in patients who have joint involvement. The presence of nail psoriasis in patients with psoriatic arthritis varies anywhere between 32% and 97%, which is really high. And there's almost a threefold higher risk of patients with nail psoriasis to develop psoriatic arthritis. So because of this, nail psoriasis is an independent predictor of psoriatic arthritis. Now, coming to the anatomical aspect of things, the nail is connected to the underlying bone, the distal phalanx, through this mini entheses network that is fused with the extensor tendon, which crosses the DIP joint. So here we can see the distal phalanx and the nail matrix. This anatomical connection of the nail matrix to the musculoskeletal system proves that nail psoriasis can be an early indicator of psoriatic arthritis. It's also believed that the nail lesions are caused as a reaction to the abnormal tissue stress and inflammation rather than as an autoimmune response on its own. Nail psoriasis may be a predisposing factor in fungal and bacterial infections, which occur in 4.6 to 30% of nail psoriasis. Fungal infection of the nail is very, very common in nail psoriasis. Coming to the anatomy of the nail unit, the nail consists of 4 epithelial structures. So we have the nail matrix, which produces the nail plate. We have the nail bed that provides the attachment. And we have the hyponychium and proximal and lateral nail folds that protect the nail plate. The nail bed has a very firm attachment to the ventral aspect of the nail plate by way of parallel longitudinal ridges and grooves. These will interlock with and bind the nail plate tightly to the nail bed. The nail bed also contains a very rich vascular system within these parallel longitudinal grooves. In a healthy individual, the nail elongation speed is approximately 0.1 mm per day, but in people with psoriasis who are on treatment, it increases by around 10 to 25%. The clinical signs of nail psoriasis, it can occur in all portions of the nail unit. It can occur in few nails or even all 20 nails. So nail matrix psoriasis, these are all the various findings that we can see in nail matrix lesions. Pitting is because of the altered keratinization of the superficial nail matrix. Leukonychia are these opaque white spots, also because of parakeratosis. The red spots in the lunula are because of the vasodilatation and the suprapapillary thinning. Crumbling can be seen when the entire nail matrix is involved. Tracheonychia are these Bue's lines. It's very commonly seen in acute erythrodermic psoriasis. Onychomatosis is the separation between the nail matrix and the proximal nail plate. The thickening of the nails can be seen along with these longitudinal ridges. And finally, total nail dystrophy can be seen. Nail bed psoriasis mainly consists of splinter hemorrhages, subungual hyperkeratosis, salmon patch, and when the salmon patch extends to the distal part of the nail, it becomes onycholysis. Salmon patch is also called as the oil spot sign. So comparing fingernail and toenail psoriasis, fingernail psoriasis is a little more common and the lesions vary a little. So in fingernail psoriasis, the most commonly seen features will be pitting, salmon patch, onycholysis, and then comes subungual hyperkeratosis and splinter hemorrhages. While in toenail psoriasis, subungual hyperkeratosis is very common, along with diffuse yellow-brown discoloration of the entire nail plate. And then we also see onycholysis and splinter hemorrhage. Other findings in psoriatic nails, we see acropustulosis, which is the destructive pustulation of the nail unit. It can occur in palmoplantar pustulosis, in pustular psoriasis, as well as in acrodermatitis continua of Hallepio. And its main complication is resorptive osteolysis of the digits. Subacute and chronic paronychia also can be seen. So this happens because of the involvement of the proximal nail fold and where there is loss of cuticles. Psoriatic onychopathy is a very uncommon variant of psoriatic arthritis. It involves psoriatic onychodystrophy or onycholysis, soft tissue thickening over the distal phalanx, and periosteal reaction without any DIP involvement. We can also see anonychia, the absence of the nail, absence of nail growth, transverse ridges, and longitudinal striations. Now, psoriatic nails is very common in female sex, and particularly these three signs are very commonly seen in nail psoriasis. These are the transverse grooves, onycholysis, and splinter hemorrhages. In particular, transverse grooves have very strong association with distal interphalangeal arthritis and enthesitis. Coming to the diagnosis of nail psoriasis, a nail biopsy can be done. Different imaging can be done like ultrasound, MRI, and then we have the dermoscopy, capillaroscopy. In addition, we also have optical coherence tomography and confocal laser scanning microscopy. Now, nail biopsy provides information on the histopathological nail changes, which can help to confirm a very difficult diagnosis of nail psoriasis. But it is rarely performed because it's a very invasive procedure, because it's associated with bleeding, pain, permanent scarring, nail dystrophy, and increased risk for secondary infection. Nail clippings must be done to identify any fungal infection. It can also be done to identify parakeratosis and subungual hyperkeratosis. Now, where will you take the nail biopsy from? The site is important and it depends on the features that we see. So it can be done from the nail bed, it can be done from the distal or the proximal matrix, depending on the signs that we see in the nails. Longitudinal nail biopsy can be done in any clinical sign. It gives the maximum information as well, but then it also causes the maximum disfigurement. So it's not usually done. The biopsy findings, the nail plate is usually composed of conified cells without nuclei arranged in lamella. In a psoriatic nail, we may see pits, splits, and they're all lined by parakeratosis. The nail bed is usually devoid of granular layer. In a psoriatic nail, we will see hyperkeratosis, parakeratosis, and neutrophils migrating into the epidermis with some focal hypergranulosis. The nail matrix also, there's no granular layer, but in psoriatic nail, we will see hypergranulosis. The hyponychium does contain a granular layer, but in a psoriatic nail, we will see hypogranulosis. Grover et al. Has proposed a diagnostic criteria for nail psoriasis. One major criteria, with or without any minor criteria, will give the diagnosis. So the major criteria includes two: the presence of neutrophils in the nail bed epithelium and the presence of neutrophils in adherent parakeratotic fragments of the nail plate. The minor criteria include the presence of hyperkeratosis along with parakeratosis, serum-like proteinaceous exudates in the horny layer, and focal changes in the granular layer. Psoriasiform hyperplasia of the nail bed epithelium with dilated blood vessels. Dermoscopy gives a 10-time magnification. So we usually see pits. They will be irregular depressions surrounded by a whitish halo. We can see splinter hemorrhages, which are longitudinal red, black, purple marks. Onycholysis can be seen, and they're seen as a homogeneous white patch, or you can see longitudinal striations, and they usually have a reddish-orange halo around them. Salmon patches can be seen. They're also reddish-orange, irregularly shaped and sized patches. And dilated and tortuous blood vessels can be seen in the distal part. And then comes videodermoscopy, which gives a 10-time to 1,000-time magnification. Iorizo et al. Showed that by using videodermoscopy, the capillaries of the hyponychium of the nails, which are affected by psoriasis, they'd be visible, dilated, tortuous, elongated, and also irregularly distributed. And the capillary density was different in each patient, and that positively correlated with the disease severity. The ultrasound of the nails, it's a real-time non-invasive investigation, but it requires a high-resolution ultrasound machine with a high-frequency probe. It detects not only the minute morphostructural anomalies, but also the minimal blood flow changes in the superficial soft tissue level. Thus, it's a very great tool for the global assessment of disease severity in psoriatic arthritis. So this picture shows the ultrasound view of the nail. We can see the nail plate, the nail bed, the nail matrix, and the distal phalanx. So what it does is we can measure the thickness of the nail matrix, A, B is the thickness of the nail plate, and C is the thickness of the nail bed. We can also assess the morphological changes in the nail plate by using ultrasound. So nail bed changes, we can see thickening of the nail bed, shown in the first picture. In the nail plate changes, we can see hyperechoic deposits in the ventral plaque. We can also see thickening of the entire ventral and the dorsal plaque, which finally leads to these wavy thickened appearance of both the plates. In addition, nail bed changes, we can also see increased blood flow in the nail bed by power Doppler. Optical coherence tomography. In this, infrared light reflected from the nail is measured and the intensity is imaged as a function of position. Now, is this a better tool than the ultrasound? Now, OCT provides images of tissue pathology in situ with a higher axial resolution. It also measures the thickness of the nail plate with greater accuracy. Thus, it has the potential to provide quantitative data, and it may be a more accurate and objective surrogate outcome measure. Confocal laser scanning microscopy is a new non-invasive diagnostic tool. It helps to visualize the cell structures of the skin up to a depth of 300 micrometers. And it lies on the principle that increased optical resolution and contrast of a micrograph is obtained by using a spatial pinhole to eliminate out of focus light. This enables reconstruction of 3D images in nails. So this is a very promising tool in the diagnosis of nail psoriasis, as it gives better information on the microscopic structures of the nail plate as compared to the optical coherence tomography. Once you diagnose nail psoriasis, it's important for clinicians to be able to assess the severity in order to determine an optimal treatment strategy, as well as to monitor the response to treatment. So here we have the nail psoriasis severity index. Here we have to divide each nail into 4 equal quadrants, and we have nail matrix lesions and nail bed lesions. So we have 4 nail matrix lesions and 4 nail bed lesions that we will assess the nail for. That would be in a score of 0 to 80 if it's only fingernails. If it includes all finger and toenails, it will be up to 160. Now, the modified NAPSI, here we will be assessing only the entire nail plate rather than dividing them into quadrants. but it has a low sensitivity when you're following up the patient. Now, the target NAPSI, here during the follow-up sessions, what we do is we will assess only the most maximum involved nail. So only that one nail will be assessed during the follow-up. In a modified target NAPSI, we have a more advanced scoring system with mild, moderate, severe. Other scoring systems are also used, like the Psoriasis Nail Severity Score, the Baran system, the Canavo system, Nail Area Severity Score, and the Nijmegen Nail Psoriasis Activity Index tool. The most commonly used would be the NAPSI score and the modified NAPSI score. In addition, also the global visual analog score is also used because it's very consistent and reliable. It's used a lot in clinical settings. Coming to the challenges in treating nail psoriasis. Now, topical drug delivery is very poor. Because of the slow rate of nail growth, it takes a longer duration for treatment, and that questions the long-term compliance. In addition, there's potential significant toxicities of the various systemic agents, so it's not recommended for pure nail psoriasis without skin or joint involvement. And there's a dearth of good quality evidence for the management of nail psoriasis. Substantial progress in understanding the pathogenesis of psoriatic nail and joint disease has been going on, and there's several highly effective therapies now available for moderate to severe disease. However, the nail psoriasis research is far more limited. Determining an appropriate treatment course also can be challenging. So that leads to the under-treatment of nail psoriasis. In a Dutch Psoriasis Association survey, only 16% of the patients were receiving treatment for nail psoriasis per se. Coming to topical therapy, that's the first line of treatment for mild nail changes when the changes are limited to only few nails and when nail psoriasis is the only manifestation of the disease. Here we have the various topical therapies like corticosteroids, vitamin D analogues, 5-fluorouracil, cyclosporin, tazobactam, anthralin, combination treatment that is tacalcitol on weekdays with clobetasol on weekends, and dexamethasone iontophoresis. These were taken in detail. But the limitations of topical therapy are that it's messy. It has only modest efficacy. It inadequately penetrates the nail bed and the nail matrix. And also we have the usual complications of topical corticosteroids in long term. So we do have atrophy of the nail and the phalanx, the nail striae, telangiectasias, tachyphylaxis, and complications of systemic absorption of the topical. International therapy is usually given when only one or a few nails are involved. We can give corticosteroids, methotrexate, or cyclosporin. These are effective in subungual hyperkeratosis, in transverse ridging, pitting, and nail thickening, but they are very painful and time-consuming. The other side effects are that they can cause subungual hematomas, short-term paresthesia, and atrophy at the injection site. Phototherapy with NB-UVB, there has very superficial penetration, so it's not used for nail psoriasis, but photochemotherapy with PUVA can be used. It works very well on nail bed psoriasis like onycholysis, salmon patches, and subungual hyperkeratosis, but nail matrix lesions, it doesn't work very well. Photoonycholysis and subungual hemorrhage along with local pigmentation are very dreaded complications of photochemotherapy. Ionizing radiations and lasers, these are not very commonly used, but ionizing radiation, it's very inconsistent and it gives satisfactory results. It has adverse effects like pigmentation, early local inflammation, and late fibrosis. And there's also a potential for development of malignancy years later. Lasers, we have the pulse dye laser, which is used in quite a number of studies recently. And it has equal efficacy to photodynamic therapy in the form of a decrease in the NAPSI score. It mainly improves the nail bed psoriasis. Coming to systemic therapy, a variety of systemic agents have been tried in nail psoriasis. Of these, methotrexate, retinoid, cyclosporin, leflunomide have been the most extensively explored, and they have a moderate efficacy. But it's an inappropriate treatment for the treatment of nail psoriasis in the absence of significant skin and joint disease. Other agents also like azathioprine, tacrolimus, calcipotriol, they are yet to be completely fully assessed in nail involvement alone. Methotrexate in comparison with cyclosporin, methotrexate works very well on nail matrix lesions, while cyclosporin works on the nail bed lesions. In a study, methotrexate produced NAPSI score improvements of 7%, 31%, and 35% in 12, 24, and 48 weeks respectively. But cyclosporin was found to improve the NAPSI score by 40, 72%, and 89% respectively. So that seemed to be a better option in this particular study. Retinoids, acitretin and etretinate are used. Their effects strongly depend on the dosages which are used. So in dosages which are quite high, it can worsen nail psoriasis by inducing paronychia and nail fragility. These are at doses recommended for skin psoriasis. But at lower doses, it can prove to be fruitful without causing any of these side effects. So Tosti et al., he gave a low dose acitretin of 0.2 to 0.3 mg per kg per day for 6 months, at the end of which the NAPSI reduced by a mean of 41%. Conventional treatment gives very unsatisfactory, tedious, it's inconvenient, has moderate efficacy, and there's incomplete clearance in psoriatic nails. So then came the introduction of the biological response modifiers. In real-world prospective studies, they have shown that biological therapies are significantly more effective than conventional therapies, and they bring about a rapid control. So the biologics and small molecules that have been tried in nail psoriasis, we have the Tnf alpha inhibitors, we have the interleukin 17A inhibitors, secukinumab and esakizumab. We have interleukin 17 receptor antibodies, the brodalumab, interleukin 12-23 inhibitors, ustekinumab, and small molecules like apremilast and tofacitinib. TNF alpha inhibitors, infliximab has been the most extensively studied. And comparative studies of different TNF alpha inhibitors have shown that infliximab provides greater improvement in nail psoriasis compared to etanercept and adalimumab, but it is also associated with a higher risk of secondary fungal infection, even in patients who have nail scrapings negative at baseline. Ustekinumab, it's a monoclonal antibody targeting the P450 subunit of interleukin 12 and 23. In a recent study by Patazzi et al., subcutaneous ustekinumab 45 mg was given at baseline at week 4 and then at every 12 weeks till week 40. So at baseline, there was a 73% improvement of NAPSI score. At week 16, there was a 37% improvement. At week 28, there's like a 9% improvement. In week 40, there was complete clearance. So it was reported to be very effective in nail psoriasis. Now, interleukin 17A inhibitor, the esakizumab, has been seen to be more effective than etanercept in an uncover 3 study. Guselkumab has been seen to be better in a voyage trials, and tofacitinib and esakizumab has been shown to have best efficacy in treating nail psoriasis in a meta-analysis done this year. So all of these results, they suggest that targeting the interleukin 17 and 23 pathway may be a more effective long-term treatment for nail psoriasis than blocking TNF alpha. So the treatment recommendations from the medical board of the National Psoriasis Foundation. These recommendations suggest that nail-only psoriasis, high-potency steroids with or without calcipotriol can be used. And in very extensive nail psoriasis, when it's very recalcitrant, when there's failure of topical therapy, we can start them on adalimumab, etanercept, intralesional steroids, ustekinumab, methotrexate, or acitretin. For significant skin and nail disease, the recommendations are adalimumab, etanercept, and ustekinumab. For significant nail, skin, and joint disease, the recommendations are adalimumab, etanercept, ustekinumab, infliximab, methotrexate, apremilast, and golimumab. So nail psoriasis is a very early indicator of psoriatic arthritis. It causes physical disability as well as a very negative psychological impact on the patients. So there's a need for awareness and understanding of nail disease among rheumatologists, primary care providers, and dermatologists so as to improve the identification and management of psoriasis. Thank you.
Thank you, Vaishnavi, for the overview of nail psoriasis. It was a very good revision for all of us, and it would have been of immense help to the postgraduates. Now, this concludes the session, and we move on to the next in the schedule. I request Dr. Surya to take over the proceedings. Thank you very much for being here with us.
Thank you, sir. Thank you, ma'am. Let us seek the Almighty's blessings. I request the gathering to please join us for the invocation. I invite the chief guest and the honorable guests present to please come onto the dais. I now invite Dr. Siri to sing the invocation song.
Wait.
हे गणनायक विघ्न विनाशक बुद्धिप्रदायक सुखदायक सिद्धि विनायक बाप्रमथनायक सिद्धि विनायक बाप्रमथनायक गजराज मस्तक वरदायक गजराज मस्तक वरदायक हे गणनायक विघ्न विनाशक बुद्धिप्रदायक सुखदायक हस्तपरशुधर पाशाङ्कुशधर मुक्तिप्रदायक दीनोद्धारा भक्तियोर्नमिसुवे एकदन्तनि निन्ना भक्त कैवारी शुभकारी भक्त कैवारी शुभकारी हे गणनायक विघ्न विनाशक बुद्धिप्रदायक सुखदायक. Thank you.
Thank you, Dr. Siri. The age-old Indian tradition of commencing any event goes by lighting the traditional lamp. Light is a symbol of truth, knowledge, and understanding, a symbol which defeats darkness and serves as an array of hope. It gives me great pleasure to introduce our chief guest of the day, Dr. Sudha Ramchandran ma'am. She is currently the National Operations Head for the Occupational Health Division with Apollo Life Wellness International Limited. I take this opportunity to call upon our esteemed chief guest to please light the lamp. And I request Dr. Professor U.R. Dhanalakshmi ma'am, Professor Parimalam Kumar ma'am, Professor S. Nirmala ma'am, Dr. Madhu ma'am, Dr. Raj Shekhar sir, Professor Jayakar Thomas sir, Dr. Dinesh Kumar sir, and Dr. Padam Kumar sir to please join the chief guest in lighting the lamp.
Shubham kurutvam kalyanam arogyam dhanasampadam. Shubham kurutvam kalyanam arogyam dhanasampadam. Shatru buddhi vinashaya दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छाहि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
May I now invite Professor Jayakar Thomas sir to please welcome the gathering.
Good afternoon, everybody. It's indeed my pleasure to be here this afternoon for giving the welcome address. At the very outset, I welcome my good friend and colleague, Dr. Sudha Ramachandran, to this event. To us, Madam Sudha, this is a very auspicious occasion for us. We do this every year from the World Psoriasis Day, which is actually on October 29th. And almost every year, if not from the time of its inception in 2004, from 2006, we have been observing it. And we have different people coming and joining us, sometimes politicians. Last year when I was in Stanley, at that time, health minister had come. And we have had different people, but some of the people have been regulars with us, if not every year, at least very, very frequently. I have to welcome Dr. Rajsekhar, who's seated there. Thank you very much, Rajsekhar, for being with us. He gives us a lot of encouragement, a lot of information on the rheumatologic aspect or the arthritis aspect of psoriasis every time. Now, why are we having it today, the 31st October, is for convenience of everybody. We keep it to the Sunday, which is closest to October 29th. That's why we have done it today. One change. Now, to be very formal, the Chettinad Academy of Research and Education, along with the Indian Society of Teledermatology and the Chennai City chapter of the Indian Association of Dermatologists, Venereologists, and Leprologists of Tamil Nadu, is united, as the theme says this year, united with the 60 million people worldwide with psoriasis in celebrating and observing October 29th annually as the World Psoriasis Day. Today, we share our thanks to the dermatologists, rheumatologists, researchers, professors, physicians, psoriasis enthusiasts, dermatological societies, and the pharma companies, particularly today's sponsor. We have with us IPCA Laboratories, who are working to create a brighter and clearer future for psoriasis patients all around the globe. With the theme of United, this World Psoriasis Day, we remember that we can do so much more together than we can do alone. Now, from the Indian Society of Dermatology point of view, although Professor Parimalam will be talking, I think Professor Dhanlakshmi will be talking more on that. The Institute is a proud supporter of the World Psoriasis Day and is united with all to change the perception of psoriatic disease. I always nowadays started calling it psoriatic disease rather than just psoriasis. We will ensure equal access to medicines, stop and remove the stigma, advance holistic care, and prepare the health workforce to properly care for psoriasis patients. Now, our next partner, the Chennai City chapter of the Indian Association of Dermatologists, Venereologists, and Nephrologists of Tamil Nadu, is honored to unite with the global community and organizations in a shared celebration of psoriasis research, treatment, and innovation. Now, being innovative has always been the Chennai City chapter's theme. And as you have seen earlier, we had so many overseas speakers with us. Some of them could come live, some of them couldn't because of their personal commitments. We hear the specializers from all around the world explain what being united in psoriasis treatment means to them and what is most rewarding about treating psoriasis patients. The Chennai City chapter president, Professor Parimalam Kumar, also discusses what the CCC is doing to unite in the fight against psoriasis. So we want to expand our knowledge. So I would request in this welcome speech to expand your psoriasis knowledge and join experts on World Psoriasis Day. This webinar will cover personalized medicine in psoriasis. Just 2 or 3 days ago when I was in Madras Medical College, I explained what this P4 medicine or personalized medicine is all about. And psoriasis could be the best example for P4 medicine, focusing on registries, big data, and artificial intelligence too. Advocacy is another thing that we embrace. Advocate for your patients by contributing to scientific and medical psoriasis research to improve the understanding of patients' experiences, particularly during this ugly pandemic that we went through, and probably we are coming to an end of it, but because we have learned to explore and also to manage the difficulties of the pandemic. I once again welcome our chief guest, Dr. Sudha, our non-dermatologist supporter, Dr. Raj Segar, all my friends who are present here, as well as those viewers who are online watching this occasion, because this is a very, very precious occasion for the Indian Society of Teledermatology. And this time, fortunately, we had the CARE, that is the Chettinad Academy of Research and Education, join us. So unite, my dear friends, ladies and gentlemen, let us start uniting for action against psoriasis on this World Psoriasis Day 2021. Thank you.
Thank you for those motivating words, sir. To say a few words about the conference, we have with us Professor Parimalam Kumar ma'am. Vice President of Indian Society of Teledermatology and President of IADVL, Chennai City Chapter.
Dear delegates, very good noon to all. On behalf of the organizing team and on behalf of Chennai City Chapter of the Indian Association of Dermatologists, Venereologists and Leprologists, Tamil Nadu branch, I extend my warm greetings to you all. Today, we all have united through this CME, which is held as a hybrid model, the new norm. To act to control psoriasis, we have with us 5 eminent international speakers, of whom we have already listened to Professor Chris Griffiths, OBE Sir from Manchester, Professor Ibrahim Al-Mukahal from Libya, and Professor Najib Das Sir from Tunisia. Dr. Emmanuel Mahi Sir will be joining us from Paris. From India, we have experienced world-renowned dermatologist Professor Jayakatama Sir, dermatopathologist to whom we listened to this morning, Dr. Vinu Sekri, Dr. Rajiv Sekri, and other experienced dermatologists and young rising stars as speakers. Dr. Raj Shekhar, an eminent rheumatologist, is here with us to share his experience. Let us unite to control psoriasis and give our patients the best quality of life in terms of health. Thank you all.
Thank you, ma'am, for those inspiring words. I now invite Professor Yuva Dhanlakshmi, ma'am, to say a few words.
Very good afternoon to my dear faculty members and delegates. Today, we have joined here physically and virtually to observe the World Psoriasis Day. On behalf of the Indian Society of Teledermatology, as a small core group, as a small team, we first observed the Psoriasis Day in the year of 2006, World Psoriasis Day by 2006. And after the foundation of INSTED, that is in 2007, every year we have been observing the day, World Psoriasis Day, with various activities like inviting the psoriasis treated patients and whoever experienced the burden of psoriasis. We have shared some of their views in previous observation days. And this year is the 15th World Psoriasis Day observation for the INSTED. Today we are partnering this day, and which is held as a hybrid model due to many travel constraints and other restrictions. I am sure with the experienced speakers from various parts of the globe having joined this meeting, we all will become more knowledgeable and more confident and be able to control the burden of psoriasis in a better way. I wish you all a wonderful and memorable day with an excellent academic feast. And I thank you all for joining this day.
Thank you, ma'am. We will now felicitate our esteemed chief guest, Dr. Sudha Ramchandran, ma'am. It is now time to felicitate our speakers. I invite Dr. V. Rajshekhar sir onto the dais to receive the memento.
His father was my teacher.
I now invite Dr. K. Rajkumar sir to receive the memento. I now call upon Dr. Vanati ma'am to receive the memento. I now invite Dr. Soundarya ma'am to please come on to the dais. I now call upon Dr. Vaishnavi ma'am to collect the memento. I now request Dr. Sudha Ramchandran ma'am to please say a few words.
Good afternoon, ladies and gentlemen. I should first say thanks to Jaker and team. One fine day, Jaker just called me and said, I want you to come. All that I said was yes. Now I realize I'm very much lower. After health minister, it's not an easy game to fill a gap. And my thoughts go back to my MMC days. We approached the dermatology department with a little awe and respect and fear because we had the fantastic person called Professor Tambaya, who was professor for us, a person who could tell the governor of some Madras those days to come and meet him saying, my OP starts at 6. He was not one to bend rules. We had teachers that way. And so the dermatology connection stopped with that for us because I went into neurology and neurosurgery. But my main interest was occupational health because my father was one of the doyens in the field. And working with occupational health, I realized there's so much that each specialty can contribute to occupational health because it's a conglomerate of all the specialties that the factory medical officer has to deal with when he is in a factory. I'm sure you'd have all read about the occupational skin diseases, but we come to know that a lot of people are not taking history of the occupation of any patient when they come. History taking was dinned into our heads by our professors like Rajshekar's father and all that. It was didn't. History taking was the most important part. We didn't have CT scans and all these fancy tests that Dr. Vaishnavi was talking about. It was opening a different field for me to look at and hear those tests. But history taking is still, I feel, maybe I'm the old school, I still feel that's a very, very important, because that gives you an indication to where are you going. Gone are the days when people had a family doctor who would first screen the person and tell you go to this specialist or that specialist. Everybody diagnoses. It's self-diagnosis or Google diagnosis now. So they immediately, ask for a neurosurgeon. They come with a CT scan and MRI. If you don't want one, they're saying, what sort of a doctor? You don't want tests. Same thing, they'll come to a dermatologist for whatever it is, maybe a drug reaction, maybe a chemical reaction, maybe allergic reaction, whatever it is. But unless people go through the history, I still belong to the old school where history is an important part, because those were the days where only chemical industries had occupational diseases. Am I right, Jacob? So it's not so now. Even the unorganized industries or unorganized people who are working, like say agriculture. How many people have you seen, how many agricultural have you seen using a glove to use the pesticide for the field? Things like many of us go to a parlor for something or other. How many of the hairstylists use a glove? They use a dye. I'm just giving a couple of examples, but there are many, many, many more industries. So when you're taking that history, my request is to the younger generation, please take not only the current job history, what they have been exposed to earlier. Because in one of our studies in occupational health, we realized some of the children were exposed to certain things. The parents work in an agricultural field, and they don't have creches in the villages. So the child is taken, put in a tuli there in the field or put by the side of the field. The child is automatically exposed at a very, very young age to insecticides, pesticides, and everything. So nobody looks at this kind of history taking. That is one. Second thing is the lot more of, what shall I say, businesses or jobs lead to dermatological problems. Gloves were not used by everybody except a surgeon those days. Now everybody, including your doorman, has a glove. So that would certainly lead to a wet, sweating inside and wet. So my request, I wouldn't say even a suggestion, my request to all the upcoming dermatologists, I'm not a specialist to talk on psoriasis. Maybe that's why I was called, because I'm one person who's not going to talk psoriasis at all today. So I'm not talking psoriasis, but I'd like to bring to your notice, there is something like this. We have an Indian Association of Occupational Health, which is 70 years old, 73 to be precise. But how many of us doctors know about it? I was passionate because my father was a specialist in that. But then when I started the department in Apollo and said that this is the head department I'm heading, occupational therapy, madam, occupational medicine is not considered by many to be a specialty. It is a much more difficult specialty than other fields. You look at only one, it's not so here. The factory medical officer has to look at every sphere from prevention to curative. And we in this field feel that prevention is better. When some chemical factories started, we request the doctor to make sure they talk to somebody like you in your specialty so that they can tell them what are the precautions to be taken. It's much easier to prevent than somebody getting it, struggling with it, and curing it. So my request again is only two things. One is be clear about the history that you take. Second thing is be aware that there's something like this, which you can definitely help. That man will not be sacked from a job. He'll be transferred to another job where he will not be in contact with the chemicals. or he will not be, he will take precautions when he is in contact with something. So this is my request, and I'm very happy to be here. I know we are getting used to, earlier days it was a joke to talk to an empty room. But now empty rooms are what we talk to, because people are across all over the country or all over the state, wherever they are. And in a way, it's a much better thing, because sitting at home, we don't have to spare the time to come and go, but we can get more knowledge sitting at home, which is a plus point. That's the only plus point I can think of Corona. I can't think of anything else which Corona has helped us to live with. And I endorse Jacob saying that we hope we are coming to the end, but the threat of third wave, fourth wave is still there. So we have to be careful in what we do. Take care, because you have to touch the patients. You can't, yes, you can do teleconsultations. I agree with you. But then somewhere or the other, you have to be in touch. Again, my request is only this. Please be aware of a faculty like occupational health, and look at the history of a patient when they come, what their exposure is now and has been in the past. Thank you once again to all of you for inviting me. It's been my pleasure. Thank you.
Thank you, ma'am. Gratitude is the inward feeling of kindness received, and thankfulness is the natural impulse to express that feeling. May I invite Dr. Padam Kumar sir, our vibrant conference secretary, to deliver the vote of thanks.
Good afternoon, one and all. It's my privilege to propose the vote of thanks today. First of all, I would like to thank the Almighty for the successful event today with more than 200 registered delegates worldwide. I next thank a beloved founder and president of Instead, Professor J.K. Thomas sir, for his constant guidance and support. I thank a president of IADVL Chennai City Chapter and vice president of Indian Society of Teledermatology, Professor Parimalam Kumar ma'am, and the vice president of IADVL Chennai City Chapter, Professor U.R. Dhanalakshmi ma'am, for the guidance and support. I thank Dr. Dinesh Kumar sir, the past secretary, and Dr. Uday Preet Sidhu ma'am, a joint secretary, for being besides me and helping me throughout. I wholeheartedly thank Dr. Sudha Ramachandran madam to readily accept our invitation to grace the occasion. Thank you, ma'am. I thank our eminent international speakers, Professor Christopher Griffiths sir, Order of British Empire from Manchester, Professor J.K. Thomas sir from India, Professor Ibrahim Al-Mukhal sir, Libya, Professor Najib Dar sir from Tunisia, Dr. Emmanuel Mahe sir from Paris, and our national speakers, Dr. B. Rajashekhar sir, Dr. Rajiv Shekari sir, Dr. Vinu Shekari ma'am, Dr. Rajkumar sir, Dr. Varnati ma'am, Dr. Saundarya ma'am, and Dr. Vaishnavi for delivering a wonderful academic feast. I thank all other faculty members who have been chairing the sessions and making the academic even more soundful. I also thank Dr. Annick Lay, the project manager of Skin Inflammation and Psoriasis International Network, for helping us in roping in some of the speakers for today. Special thanks to the IPCA laboratories for being the academic partner of the event. I thank Dr. Nandini, Dr. Surya, and Dr. Sigri for helping us with the MC and the invocation song. All are from Chettinad Academy of Research and Education. I thank Mr. Julius and Mr. Rajagopal and the entire ET audiovisual team for assisting us with the technical support. I thank the management of Hotel Savera for hosting us in these difficult times to help in smooth conduct of the event. I thank Mr. Ravi from the Jagan Offsets for helping us with the certificates. Last but not least, I conclude by thanking all the delegates for actively participating and making the event a grand one. Thank you all.
May I take this opportunity to request Professor J.K. Thomas sir to please give away the certificate for those young children who've been supporting us all the time holding the mic. You please leave the mic and come. Please come forward. Dr. Surya. Dr. Surya and Dr. Nandini, who've been comparing this event since morning, and they have stayed with us late night for the rehearsal too. Thank you. May I now request Sir to please give the certificate to that sweet voice of Dr. Siri. Thank you, sir.
We will now continue with the academic session.
One minute, I'll just log in again.
So, my dear friends, till our friend Dr. Rajsekhar gets his slides ready, I will take advantage of a few minutes. Dr. Rajsekhar is a good friend of the dermatologists. He is also a blood relation of another dermatologist. Most of you know him, some of you don't know him, Professor S. Jayakumar, the former professor of dermatology from Madras Medical College. Apart from that, he's a very good friend of ours, and he's always been with us to talk about psoriatic arthritis and arthropathy. He was with us earlier to talk on cutaneous vasculitis and vasculopathies. With a vast experience of about a quarter century in rheumatology, he is affiliated well with the Indian Medical Council, the General Medical Council. Now, these two are not like the Indian Medical Association or the other medical association we talk about. This is Indian Medical Council. We might need his help for so many other things. Member of the Indian Rheumatology Association, member of the ART, whatever it means, I do not know. Association Rheumatologists of Tamil Nadu. He's currently very active as a senior consultant rheumatologist of Apollo Hospitals, Chennai, Arthritis and Rheumatism Center. Attended many national and international conferences, participating as faculty in these conferences, published articles in national and international journals. Are you having difficulty in that? And while we continue to wait for maybe another half a minute or so for Dr. Rajasekhar to start, I'll request the younger dermatologists to follow this lecture very, very carefully. I remember having recently taken a class on psoriatic arthritis, and this is not going to be anything like that. See, when a rheumatologist's perspective is not totally, at least to a great extent different, I've tried my best to get into learning more and more of psoriatic arthritis and differentiating it from the other forms of seronegative arthritis. We don't really worry much about the seropositive, although Dr. Rajasekhar worries much about this seropositive arthritis. We are always thinking in terms of the seronegative arthritis when we want to think as a differential diagnosis for psoriatic arthritis and arthropathy. It might be a revision for most of us, and it might be something new for the younger generation. They will be hearing more on what we recently discussed, Casper's criteria, Grappal's criteria, and all that. He could tell us better than we know in our books, from our books. A little bit of connectivity problem, which we have never had whenever we had a internet program and a webinar. Are we set, Dr. Rajasekhar?
அடுத்தது இதுதானே அடுத்த ஸ்லைட் போகும். Good afternoon, everybody. First of all, I must thank Professor Jacob Thomas and Professor Parimalam for remembering me again. It's a great pleasure to be back with you. I missed it last time due to some personal reasons. And thanks, Professor Jacob Thomas, for a great introduction. The topic given to me is psoriatic arthritis, and I've just put there as 2021. So over the years, we were getting, the last 10 years, we're getting excited about all the newer drugs, the biologics, and every year, one after another was coming, and we were talking about it a lot. But now in the last 2-3 years, things have slightly shifted as the more and more biologics come. Probably we are not that interested on that, and the focus is more on the associated conditions along with psoriatic arthritis that we often neglect. Both the dermatologists and rheumatologists often neglect, and we treat either the skin or the joints. And I liked when Professor Jaker said the psoriatic disease, and I think that is how it should be called. It's not, psoriasis is no more a skin disease. Psoriatic arthritis is no more a arthritis alone. It's much, much bigger syndrome. So it's not a new disease at all. It was reported about the association between psoriasis and arthritis as early as 1818. And a good 42 years later, it actually got the name psoriasis arthritic. But almost 100 years later, it was identified as a separate clinical entity for the first time and was called as psoriatic arthritis. The prevalence of psoriasis, we know it's about 1 and 3% of the population, but the prevalence of psoriatic arthritis is still not very well known, possibly between 0.3 and 1%. The psoriatic arthritis has distinct clinical patterns: the distal arthritis, which involves the distal interpharyngeal joints, the oligoarthritis, less than 5 joints, polyarthritis, multiple joints, and the worst scenario, arthritis mutilans with the destructive joint disease. And completely different is primarily involving the spine, the spondyloarthritis. And it is a heterogeneous disease with several clinical domains. Inflammation of the synovium producing the arthritis, inflammation of the insertion of the tendons, ligament, joint capsules producing enthesitis, swelling of the whole digit due to synovitis and tenosynovitis producing dactylitis, and then the sacroiliac vertebral joints producing inflammatory spondylitis. And then the other domain is the psoriasis and nail disease. So what is this psoriatic arthritis? It is a chronic immune-mediated form of arthritis that occurs in some patients with psoriasis. It's a complex inflammatory disease with heterogeneous clinical features, and it complicates about 30% of patients with skin psoriasis. There is no diagnostic criteria or tests available, and it is commonly, the diagnosis is made by identifying inflammatory musculoskeletal features in the joints, the enthesis, the spine, in the presence of skin and nail psoriasis. Usually the rheumatoid factor and the anti-CCP are absent, and there is no or very little relationship between the severity of musculoskeletal inflammation and the severity of the skin or nail psoriasis. Often in clinical practice, we find everything that the joint disease looks probably like a psoriatic joint disease with a distal interpharyngeal joint involvement or a dactylitis, but there is no skin lesion, which happens years later or a small patch hidden somewhere. The reason for this heterogeneity is probably explained by differences in the genotype, especially in the HLA region. And we need to understand this better for a personalized approach to treat psoriatic arthritis. Well, probably this is the most important slide of the day: early diagnosis. Treatment of psoriatic arthritis early leads to better long-term outcomes. And sadly, most of the patients have significant diagnostic delays. Early diagnosis is everything in psoriatic arthritis. Just a few pictures. This is a typical damaged small joints of the hand, typical dactylitis of the foot, and the worst scenario, the arthritis mutilans with lot of damage to most of the joints. And this is not a joint problem alone. This is just inflammation of the it is an enthesitis inflammation of this the tendon. This slide might interest the dermatologist sitting here. Plaque psoriasis is the commonest phenotype in patients with psoriatic arthritis. So I think you need, if you see a person with plaque psoriasis, I think you need to dig a little deeper, ask a few more questions. Koebner phenomena is well known to you, but we have something called deep Koebner phenomena, and which might trigger a psoriatic arthritis. So recently, a few weeks back, I had somebody who was going around for nearly for 4 or 5 months, one orthopedic surgeon after another, after he had a small injury to the foot. And they've done an MRI, they've done everything, and they continue to treat. Actually, it was a psoriatic dactylitis. So that's an example of a deep Koebner phenomena. A few more pictures for you. The third row, the X-rays alone, I'll tell you. The one on the right is a typical penicillin cup deformity. The one in the middle, completely damaged wrist joints. And the first one is the sacroiliitis. So as I mentioned earlier, the fundamental in psoriatic arthritis is early diagnosis. How early is early? Ideally, we want them within 3 months of onset of symptoms, at least 6 months, certainly not later than 12 months. It's completely different. If you are going to catch somebody early and start aggressively treating, within the first 12 months, the disease goes a particular way. And the future of that person is different from another one where it has taken 2 or 3 years, and then the joint damage has set in, and then the future of that person is completely different. It's the same disease, it's just the timing of the diagnosis that really matters. Diagnostic delay as little as 6 months is associated with a poorer response to treatment. Early intervention and immune modulating or anti-inflammatory drugs improved clinical and radiographic outcomes. And there's another important issue is we don't know what are the factors that are responsible for the skin, the cutaneous to the synovial enthesial inflammation. So but this is very, very important. If we know that, we can halt it much earlier. So the cutaneous to synovial enthesial transition and the factors are certainly not known still. And we require a better definition of disease phases and characterization of the genetic, environmental, and immune-related events that precede PSA if we want to make an earlier diagnosis of psoriatic arthritis. And there are a lot of problems. People have tried to plan a predictive model for PSA, but obstacles at different level. At the macro level, the transition from the psoriasis to psoriatic arthritis often goes unnoticed or acknowledged with a major delay, leading to a poor window of treatment opportunity. So that is that window of opportunity, that first 12 months, where you can completely change the disease and give a different future. And we often miss that. And some of the reasons are all these aches and pains, musculoskeletal symptoms are quite common in general population. Somebody has got psoriasis, just complains of some vague pain. You are not going to think about as a psoriatic arthritis onset. So even recently I saw somebody with that being treated for 3 years as tennis elbow. It was just an enthesitis of psoriasis related. So that was again because tennis elbow is such a common condition and so easy. And he has again seen a lot of orthopedic surgeons and came here to get a diagnosis. And patients also often overlook musculoskeletal symptoms as something very usual that happens. At the meso level, well, even in Chennai, we have got about 25 rheumatologists, but the access to rheumatologists for various reasons are less. The referrals are less. And at the micro level, of course, people, because it's an up and down disease, relapsing and remitting nature, the monitoring goes completely awry after the initial few months of treatment, and once they get a little better. And to add to all this, in the last year and a half is the COVID, which has stopped. So many consultations have been cancelled and postponed. All adds to the problem to develop something which will help us make an early diagnosis. So if that is not possible, is there something else possible? Yes, in an ideal world, we need a test. We need a good biomarker. Sadly, none so far. So this is a paper that talks about, they have done a lot of reviews, and they still found that useful set of markers is not established yet. There was just one that was promising, that is CXCL10, which the group gave a strong level of evidence to predict development of PSA in psoriatic patients, but it's not that easily available. So the importance of timely detecting psoriatic arthritis in a psoriatic population and finding more biomarkers contributing to early detection remains high. So this is for both of us. Psoriatic arthritis is just not a joint disease, it's much more than that. And for you, please look beyond the skin. They tend to have or get a few other diseases too. No clear reason why all these happen, why these go hand in hand. Could be, with the current evidence, it could be inflammation. So all these need to be looked at, both the dermatologist and the rheumatologist, right at the onset to have an optimal outcome. So identifying these comorbidities is of utmost importance. And some of them listed here are very important, like the cardiovascular disease. Cardiovascular disease is one of the most significant comorbidities in rheumatic diseases in general and psoriatic disease in particular. As there is increased insulin resistance, endothelial cell dysfunction, and the development of atherosclerosis due to a systemic inflammation. And all these have been found completely independent of the traditional cardiovascular risk factors. So it's very, very important that we pick these early cardiac problems, which are much more common in psoriatic arthritis patients than the general population. In rheumatoid arthritis, they have done few studies to see whether aggressive treatment has made an effect on this, but no study has specifically examined the effect of aggressive psoriatic arthritis treatment regimes on the risk of cardiovascular events. Similarly, diabetes, metabolic syndrome, obesity, all that needs attention. There is an increased prevalence of these in most studies with psoriatic arthritis. And among the diabetic patients, psoriasis is generally associated with higher rates of microvascular and macrovascular complications. And these psoriatic arthritis patients have a high BMI compared to the general population. In patients with psoriatic arthritis, metabolic syndrome and insulin resistance are highly prevalent and again found to be independently associated with the severity of underlying psoriatic arthritis. So there could be several mechanisms between psoriatic arthritis and diabetes: unhealthy lifestyle, inflammatory cytokine milieu, and all these drives insulin resistance, as well as shared genetic loci for susceptibility to psoriasis and diabetes. Osteoporosis, we don't have good data so far, but since other inflammatory rheumatic diseases, osteoporosis was reported in higher numbers. So we hope the further studies are going to put a little more light into the issue of osteoporosis, but definitely that needs to be kept in mind. It doesn't end there. Inflammatory bowel disease. There is an increased incidence in patients with psoriasis, and a pronounced risk was found in patients with concomitant psoriatic arthritis for Crohn's, but not for ulcerative colitis, and we don't know why that is so. Yeah. So one debatable issue between the gastroenterologists and the rheumatologists, whether non-steroidal NSAIDs may exacerbate IBD. I mean, we have no choice. We do give, but at a smaller dose, and the gastroenterologists don't agree to that. And between these two diseases, there is no data for an appropriate therapy if there is when both of them together. So we still continue to treat with the common medications used to treat both the conditions. And the one more issue while we are selecting the biologics is the anti-TNF alpha medication. The monoclonal TNF alpha receptor blocker, etanercept, was not shown to be effective in the treatment of IBD associated with psoriatic arthritis. So if there is IBD, I think we have to avoid etanercept and look for the other TNF blockers. Loads and loads of autoimmune problems on the eye, and these can often precede or progress even despite the treatment. So again, looking at the eyes to pick up early inflammatory process there and send them to an ophthalmologist. The good news is, as for the malignancy, well, it did not show any increased risk of solid malignancies, but the other malignancies have been seen increase in patients with systemic autoimmune rheumatic diseases. Liver, I mean, this is a very, very common problem. There is increased prevalence of liver disease in patients with psoriasis and psoriatic arthritis. There are very few studies have actually directly examined the relationship solely in psoriatic arthritis, but quite a few have been done on psoriasis. And there is an increased prevalence of non-alcoholic fatty liver disease, especially when it is along with the metabolic syndrome or high cholesterol, obesity. The medications can contribute to liver disease, and especially higher rates of non-alcoholic steatohepatitis and fatty liver disease may occur in psoriatic arthritis using methotrexate. Especially the development of NASH is associated with a cumulative dose. The longer you use, the chances of liver disease. Also, more so in the presence of obesity or diabetes. So the most important thing here is monitoring, regularly monitoring, at least once in 3 months. Please check your liver function test when you put patients on an NSAIDs or the methotrexate. To me, this is such an important thing. I'm sure all the dermatologists are seeing depression and anxiety. It could just be the psoriasis, it could be the arthritis, or the inflammatory. It's not a good combination, and we see them in about 30% of patients with psoriasis, and significantly higher in patients with psoriatic arthritis than in the psoriasis alone. And there have been few papers talking about TNF blockers was associated with reduced rates of depression and insomnia. And they also required less antidepressant use. So these two are important day-to-day thing in your clinical practice. Loads and loads of patients we see with depression, anxiety, with psoriatic arthritis. Fibromyalgia, this is not only a problem for the patient, it's a problem for the treating doctor as well. The domains like enthesitis can be so confusing with fibromyalgia. And in psoriatic arthritis, we almost find half the patients have some element of fibromyalgia. And aches and pain here doesn't mean there is a worsening of the arthritis and It has led often to unnecessary treatment escalation. So we have to be aware of fibromyalgia and differentiate it properly with the different domains of psoriatic arthritis. So all these we need to be aware if we are really going to give a comprehensive medical care, because it has a huge impact on patient care, management, treatment decision, and quality of life, as well as mortality. Again, this slide and this paper, the conclusion on the paper might just open up the dermatologists. Treatment with biologics in patients with psoriasis reduce the risk of PSA development. So you can do a good job much earlier than they reach us. We hardly see those early psoriatic arthritis patients. That's why I keep on telling the same thing to whenever I talk with the dermatologist. I think the most important people are you. And then maybe the general practitioners. And then when they move away from you because they have recognized some joint problem, the orthopods. So they come to us very, very late. By the time they come to us, the job is done by by the psoriasis and the psoriatic arthritis. And it's only catch up once they come to the. So it's such an important thing that pick them early, hit them hard early, control the disease, don't allow it to go to the next stage. So ULR is the European League Against Rheumatism. They've just, and I've just put the same words that they have given. Ask yourself, have you done an echocardiogram? It has become that important now compared to 3-4 years back. So have you done an echocardiogram on a psoriatic arthritis patient? So many of them are having, because of the coronary artery inflammation, early coronary artery disease. And they've also given some good news that PSA is not linked with early death. And the third thing they have said is there anything that might just hint? And they've agreed that those with arthralgia were twice as likely to develop psoriatic arthritis within 2 years. So that simple question by a dermatologist or a general physician, have you got any joint pains, can pick up so many early ones. And if you are doubtful, please send it to a rheumatologist who might make them spend a little bit more and make a diagnosis. And the other thing that might predict is nail pitting, obesity, or a family history of psoriatic arthritis. They are all relevant, though less predictive, but more work needs to be done. So this is universally accepted now. People with psoriasis and psoriatic arthritis had a higher prevalence of comorbidities. So that is something that you have to have. It just needs half a minute. Quickly ask all those questions that are relevant to whatever I have listed. And depression also appeared to be more prevalent in people with psoriasis and psoriatic arthritis receiving biologic treatment. So that's another one as opposed to receiving conventional drugs. It was compared between the IL-1223 inhibitor, ustekinumab, and the methotrexate. So that is something that we need to keep in mind. So why I put this mad rush, the last 1.5 years it has been absolutely dead. Nothing has come because of the pandemic. There are loads of trials are going on. Loads of newer drugs are there waiting to be licensed. All are there. In the next 12 months, we are going to be bombarded with so many newer facts about these diseases and newer drugs and newer modalities of treatment. So we'll just go to the last bit, the treatment. So as we all know, absolutely no cure for psoriatic arthritis. We can only control the disease, prevent damage to the joints, and improve quality of life. The normal things that we do is the NSAIDs to start with. We have the conventional DMARDs, the biological, either like methotrexate, leflunomide, sulfasalazine, biologic agents, several of them I listed in the next slide. In some cases, the targeted synthetic DMARD, the JAK inhibitor, tofacitinib. In rheumatology, we use it when the conventional DMARDs and the biologic agents have been ineffective. And the newer oral medication, Apremilast, that is new to us, not for you. You have been using it for the skin for a long time, but it is recently licensed for psoriatic arthritis. But it is only for minor disease. It's not very good and great one, the PDE4 inhibitor, Apremilast. The other things are the usual things. When things get worse, you go for joint replacements. We have got, if it one or two joints involved, steroid injections locally, and that controls the disease. And physical and occupational therapy and lifestyle are, to me, as important as any of the ones that are listed above. It makes such a big difference if the physical therapy and occupational therapy, small things that could help in day-to-day things, and that prevents injuring the joint more, stressing the joint more. And lifestyle, protect your joints, maintain a healthy weight. All these are important. Exercise regularly, stop smoking, limit alcohol, and pace yourself. Once you start the medicines, you start feeling better. Often I see the first consultation, they are very good, excellent, because they were struggling. Then second consultation on the same medicine, they say, doctor, I got the pain back. The reason they've got is they are not pacing themselves. They suddenly got the benefit of the medicines. They felt good and they want to go back to where they were, and that is not possible. We are only going to be, however well it controlled, it is only going to be 80%. There are loads of biologics that we commonly use, but mostly it's the TNF blockers, adalimumab, etanercept, golimumab, infliximab. And if the skin is worse than the joints, then I use the secukinumab, the IL-17 inhibitors. And the IL-12/23 and pure IL-23 inhibitors are not available here. I have no experience with that. This is a slide that came out in the EULAR just a few months back. So inhibition of these are two new drugs, the ustekinumab. I'm talking about, I don't know whether you in dermatology use that. Yeah. So it is licensed only recent, not even licensed yet. The trials are an excellent ustekinumab and guselkumab. That is the IL-12/23. And the guselkumab is purely an IL-23 inhibitor. So there are several trials have happened, and selective inhibition of IL-23 is more efficacious while maintaining an equally high level of safety. And we are looking forward to that. Two very good trials, Discover 1 and the Discover 2, and together they have done a trial called Cosmos. And all of them have so far shown excellent. Just before I finish, because I don't want to go deep into the treatment of psoriatic arthritis, there are certain recommendations by the European League Against Rheumatism. There are 2-3 associations we follow world over. The ACR, the American College of Rheumatologists, the EULAR, the European League Against Rheumatism, and the BSR, the British Society of Rheumatologists. So they concluded with 6 simple principles and 12 recommendations. I'll just run through that, may not interest you. So simple things. Non-steroidal anti-inflammatory drugs and local glucocorticoid injections are initial therapy for pain. So then arthritis, for those patients with arthritis and poor prognostic factors, rapidly go into conventional DMARDs. And if that is not working, treatment target is not achieved, quickly move on to biologic DMARDs, any of them. The TNF blockers, the IL-17 or the 12/23. The next one is a very emphatic statement. If axial disease and psoriatic arthritis predominates, TNF blockers or the IL-17A secukinumab should be started as first-line disease-modifying drug. The reason why they say first-line disease-modifying drug, none of the conventional disease-modifying drug, methotrexate, sulfasalazine, leflunomide, nothing works on the spine. Absolutely nothing. So we are only giving that. If you look at the rheumatology prescription, everywhere you see sulfasalazine, in angstpon, psoriatic spondyloarthritis. you see methotrexate, you see everything, but then none of them works in the spine. It is given only to prevent the peripheral joint involvement. It treats the peripheral joints, nothing on the spine. So it's a very emphatic statement. The only question is how many can afford it in this part of the world. That's different. Axial disease predominates, biologics first line treatment. The JAK inhibitors are not that great if there is a primarily after a biologic DMARD failure. If you have used a few biologics, you can try the JAK inhibitor tofacitinib. And as I mentioned earlier, for a mild disease, you can have apremilast. Psoriatic arthritis is a disease with heterogeneous manifestations in patients who have manifest or latent psoriasis. So there are basic things that they have done, and they've recommended about 12 things, and the green ones on the right are the level of agreement out of 10, and most of them have been good. So the treatment should be aimed at reaching the target of remission, and if you can't achieve remission, go for low disease activity. So there are a lot of parameters they look, and that is out of scope on this talk here. How do you, what do you mean by remission, and what is low disease activity? NSAIDs may be used to relieve musculoskeletal signs and symptoms. And then local injections, I mean, these are all accepted. Local injections of glucocorticoids should be considered as an adjunctive therapy in psoriatic arthritis. And the next one, I'll wait for Professor Jacob. So this is just for you. Systemic glucocorticoids may be used with caution at the lowest effective dose. I don't think you will agree to that. You agree to that. Thanks a lot. It's one of that, yeah, because it's always a problem between the dermatologists and the rheumatologists. They say, no, man, we have got, I can't mention names, we have got a few who are absolutely against it. And in my 25 years of practicing rheumatology, treating psoriatic arthritis, I have not had a single problem. Pustular psoriasis is what they say, or flare of the psoriasis, but it has not happened to me in 25 years. In fact, we used to, when I was in the UK and Ireland, we used to give 1,000 milligrams of Solumetrol, methylprednisolone, IV, alternate days, 3 times. The skin itself used to clear. But there are a set of dermatologists who are absolutely against it. They don't allow me to give even 1 milligram of steroids. So in patients with polyarthritis, multiple joints, conventional DMARD should be initiated rapidly, and probably methotrexate is the first drug. And the 5th recommendation is early conventional DMARD to be considered if there is any poor prognostic factors. So don't wait, like high ESR, dactylitis, or ACRP. And the 6th recommendation, in patients with peripheral arthritis and an inadequate response to at least one conventional DMARD, you must jump to a biologic DMARD. Either it is a TNF or the IL-17, 12, 23. But if the skin involvement is more, as I said earlier, you go for the IL-17 or the IL-12, 23 inhibitor. And the 7th recommendation is patients with peripheral arthritis and an inadequate response to at least one conventional disease-modifying drug and at least one biologic DMARD, or when a biologic DMARD is inappropriate, then the JAK inhibitor tofacitinib. And as we have already mentioned, it's agreed by them that the 8th one is PDE4 inhibitor if the disease is mild, and if it's an inadequate response to the conventional DMARD or the biological DMARD or the JAK inhibitor. And enthesitis looks a small thing, but it has made us weep so many times as rheumatologists. It just doesn't go. It sticks. In patient with unequivocal enthesitis and insufficient response to NSAIDs, you can start your biologic DMARD even just for an enthesitis. And similarly, we have already mentioned predominantly axial disease. If it is active and has insufficient response to the NSAIDs, DMARDs, and when there is relevant skin involvement, you go for IL-17 or the TNF blockers if there is no major skin involvement. In patients who fail to respond adequately to or intolerant of a biologic DMARD, switching to another biologic DMARD or targeted synthetic DMARD should be considered, and you can switch inside the class itself. And the last one has been recently included, it was not there in the previous recommendation. In patients in sustained remission, cautious tapering of DMARDs may be considered. We do that, but often we used to burn our finger when we go down, but the recommendation itself says that. So I won't look into that. It's the same thing in a chart form. And no talk today in the last 18 months can end without something on COVID. So there are a lot of confusion going on, lot of views from different part of the world from the rheumatologists, who to treat, who should not be treated during the COVID times, any drugs to be avoided. They have finally come with a very simple recommendation. But majority of the pharmacological treatments used in rheumatology is to continue with immunomodulatory or immunosuppressive therapy in patients who do not have infection, and to suspend it in patients with a diagnosis of COVID-19. And then a few more things go on. They say when to restart, that is left to the treating rheumatologist. So that again, it's a gray area there. But end of the day, the rheumatologist's goal, even in the pandemic context, is to ensure adequate disease control and contemporarily to minimize the patient risk of the contagion. Just a last slide before I finish. Whatever we have talked, so much is going on, millions and millions of process at 60 million patients of psoriasis world over. But still, the challenges remain as far as psoriatic arthritis is concerned. The number one is awareness. Still, public is not aware. Professionals, let it be the general practitioners, some of the lesser dermatologists, mainly the orthopedic surgeons. So that awareness challenge continues to be there, and we have to work hard on that if we are going to make a difference to the life of these people. And early diagnosis, we have talked so much about early diagnosis, that's again a challenge. And sustaining treatment continues to be a challenge even for a rheumatologist. Once they get better, the pharmacist tells them, you're taking this medicine for so long, side effects, liver will go, kidney will go. So they tend to believe a pharmacist who have been giving their family medicine for 40 years, then a consultation of 14 minutes with a rheumatologist. So sustaining the treatment is also difficult, and they have to take medicines till the end of their life if they don't want to keep the disease progression of psoriatic arthritis in control. And then the ideal thing we want is a biomarker, and that is missing, nothing we have got. And now the comorbidities having attained higher importance now, as more and more studies are showing how much it impacts the life of a patient with psoriatic arthritis. And looking into all those also, it's time consuming, it's not easy, and we are not doing it. I'm not blaming anybody, I'm blaming myself as well. The comorbidities always take a back seat. And then to monitor for treatment complications, where the patient has to keep coming regularly. Once they feel better, they don't come. So that is again a challenge. And finally, and the most important thing, in spite of all these newer drugs, biologics, the cost of treatment is a major hindrance, especially in this part of the world. That's all I've got, ladies and gentlemen.
Thank you very much, Dr. Rajsekhar. I'm sure, just as I am, most of the viewers and listeners are thoroughly impressed with the importance of examination of the joints. I think just less than a week ago, I was taking class with the residents and talking to them about the joints in psoriasis. And very impressively, you brought out the comorbidities, particularly the cardiometabolic comorbidities that are known. Just 2 days ago, I was talking in Madras Medical College on cardiometabolic. I have just one simple question, not a question, it's a doubt that I have, Is there a possibility that you could predict somewhere early arthritis?
Yeah, I mean, there was a slide, I was talking about it. Absolutely no biomarkers now. I mean, say if you have a doubtful polyarthralgia, you think it's a rheumatoid, you do a rheumatoid factor or anti-CCP. Most of, if you combine and do, 95% of the patients we will catch. Absolutely nothing for psoriatic arthritis. And even the clinical thing, we don't have, I mean, I just put a slide where nail changes might predict early, and polyarthralgia, anybody with psoriasis, generalized aches and pain, we must follow that. 2 years later, some studies have shown a lot of them who have been talking about vague aches and pains have actually developed psoriatic arthritis. But no test available, no biomarkers, nothing.
Genetic markers?
Yeah, that's only CL10. That's the only thing, but it's not still in proper use. It's only in the research area.
The card
Yeah.
And the nod. Genetic markers for psoriatic arthropathy, but as Dr. Rajsekhar has rightly put it, the treatment is lifelong. I do not know how much joint replacement really helps, but I'm a big protagonist of the use of steroids.
Good.
Big. And even Professor Parimalam would agree that we are among the few dermatologists in India who agree that steroids can be used. I know that too in the place that you work. That people jump at adalimumab and ustekinumab, scafo. They jump at because they get a good cut from the pharma. It's unfortunate. And when my patients go to them after using who's the one who started steroids for you? Anyway, and that's outside the game.
It's a poor man's biologic.
It's, exactly, that's the word. Please, my dear friends, understand. It is a biologic. When you're using other biologic, why are you not using steroids? The best biologic that you could have. But what one should remember is, be careful when you're using it, that's all. See that there are no contraindications, keep monitoring the patient. When you can monitor a person before you start the patient on secukinumab, you have at least 40 points to checklist before you start a patient secukinumab. You don't even have 3 things. You have to see blood sugar, you have to do an X-ray, and then make sure that you can start the patient on steroids. That's all. And keep monitoring. That's it. I think Dr. Parimalam wanted to add something.
Can I just interrupt before Parimalam? No, the thing is the skin flaring in steroid. When you give steroid, it doesn't get flared up. It's only when you're reducing it. When you rapidly reduce, you're in trouble. And that is the most important thing. As I told you, in 25 years of rheumatology and using steroid, I have not had a single bad pustular psoriasis. No. Or even a bad flare of psoriasis.
Sir, you were too busy. I could not share this important information. So the moment you left MMC that day after talking about cardiovascular manifestation, the patient whom you asked for the name developed ventricular arrhythmia. He was hospitalized. I mean, he was immediately shifted to CCU, taken care by CCU. Now he is fine. He's off drugs. Sir, just he asked me his name. I said, "Sir, 1 minute, I'll find out." Sir spoke to the patient. Sir went that side. This patient went this side to his ward. On the way to his ward, he fell down. He was immediately rushed to CCU and he was revived. He had ventricular tear. Again, he threw another VT, but he was revived. Yeah. So
the focus has shifted, especially for the younger ones.
I don't think you should be doing what dermatologists 30, 40 years were doing. You look at it as a syndrome, you look at it as a disease, as Professor mentioned. No, it is not just skin. Skin is part of it. So there are so many other things. It's not only psoriatic arthritis and all the comorbidities. In psoriasis, pure psoriasis also, the incidence of all these are higher. So you have to look. That is going to take a little bit more time and more work, but that is a way to go about in psoriasis or psoriatic arthritis from now on. Not like what is happening earlier, just something to apply on the skin. And in fact, one of the, I can't mention the name, one of the older senior dermatologists once asked me, what for you are giving methotrexate for psoriasis? Well, it's going to keep coming back. So I don't think we look at a disease like that. You just apply something and there is no need to give a serious drug like methotrexate. So you people have to completely change. I think we are right in the middle there. And the future, the disease must be looked at completely differently.
Thank you once again, Dr. Asegar.
Thank you,
Very, very enlightening. And not thank you just for today alone. Thank you for all the past information you have given us and for the future information that you're going to update us with. No? A big round of applause, please.
Thank you, and wish you all a very happy Diwali and a happy Christmas for Professor Jacob Paul and
Thank you.
Thanks a lot.
Very much. God bless you abundantly.
Thank you, sir, for your highly informative lecture. Dr. Emmanuel Mahe, sir, will be joining us virtually from Paris for his presentation on proactive treatment of childhood psoriasis. Professor U.R. Dhanalakshmi ma'am is here with us in the venue, and ma'am will be chairing this session.
Hello.
Welcome, sir.
Yes, we can start.
We are waiting for your lecture. Please take over this session.
Is it? Is it okay? You see my slide? So, hello for everybody in India. It's first I would like to thank Professor Thomas for this invitation. It's a sincere pleasure for me to share this moment with you. Here it's early in the morning, and we are now in winter time, and we have difficulties to have the good moment. So for me, it's very important to talk about proactive treatment in childhood psoriasis. I think it's easy for all of us to treat flare-up in psoriasis, but the new challenge, and I think it's as important, is to maintain the treatment effectiveness. So that is proactive treatment. Sorry. So I have some, you see this? No, it's okay. I have some disclosures in the field of psoriasis with many industrials in adult psoriasis and in children's psoriasis. So to treat children with psoriasis, we have two steps, in fact. To manage the management of flare-ups, and then, sorry, you have this problem. You have the same problem in the slide? No, it's okay. So we have the first step is to manage the flare-up, and then to...
Sir, 1 minute. Sorry for the interruption. In the slide projection, there is one small red and yellow column band like it is coming. Can you remove this in your system? There is one thing.
I don't know what it is. I start again.
Yes, sir. Now it is all right, sir.
It's okay.
There is no bad now, sir.
Okay. So the first step is to manage flare-ups, and then the probably more difficult is to maintain the treatment effectiveness and to prevent relapse on new flare-ups. And moreover, I think it's important to, when we treat the children, we will treat the children for many years, 50, 60 years maybe, for this psoriasis. So we have to prevent long-term complications associated to the disease, associated to treatments, acute toxicity, but also cumulative toxicity, and to prevent associated comorbidities. You know, we talk about obesity, cardiovascular disease associated to psoriasis. And when we have a child, the question is if, as a child, higher risk to develop cardiovascular disease in adulthood. So, as I said, in 2021, it's easy to treat children, in fact. We have topical treatment, many treatment, cream, ointment, shampoo, lotions, etc. We have lots of oral treatments, licensed or not, for children with psoriasis. In France, only acitretin is licensed for psoriasis. And now we have many biologics. We have five biologics licensed in France, but also we have guidelines to treat children from US, from Italy, from Germany, etc. So finally, it's quite easy to treat children with psoriasis. And the challenge now it's to be what we call, when we say it's to be proactive. It's to anticipate the disease progression, to limit both the severity and the incidence of new flare-ups. We can say that we can be reassuring with the children and its parents for long-term complications. We know now that children-onset psoriasis does not increase the risk in adulthood of cardiovascular and metabolic comorbidities. We show that in a large cohort of 2,000 adults, and we shown that the onset of psoriasis in children doesn't increase frequency of cardiovascular disease, of diabetes, of dyslipidemias in adulthood. And that is very important. No, it's not, when we treat in children, we don't think about cardiovascular metabolic comorbidities. Psoriasis arthritis, there is not a higher risk to develop psoriasis arthritis. It has been shown in many studies now. But what we don't know is if the psoriasis child start in childhood, does the psoriasis arthritis start earlier? We don't know that. We don't know. We just know that it's not more frequent. The group of Marieke Seger in the Netherlands shows that the child onset, the onset of psoriasis in childhood doesn't increase the risk to develop severe psoriasis in adulthood. It's very important. And finally, we recently shown, it is in publication, that there is no an higher risk of addiction, tobacco and alcoholism, neither of desocialization in adulthood when we look at family history, professional activity, etc. When the child start early, start early. So the therapeutic objective, when we are proactive, in to maintain the treatment efficacy, to prevent the relapse, and to reduce the risk of complication. First, what is the remission? When can we talk about proactive approach? You know that the remission is considered as clear or near clear psoriasis. I always say to the children, the parents, the clearing is defined when the skin is normal. It's not red, it's no crusted, the skin is normal. When we stop too earlier, I think there is a higher risk to develop a new flare-up. And this, to obtain the remission, as you know, we often need long-time treatment, 1 to 3 months of treatment for mild and severe psoriasis. For topical treatment and general treatments is often very long. And I don't know, it's the same in India, but in France, some of my colleagues say you treat 10 days, then you decrease the treatment. I think it's not enough. And the message is really you treat until the total clearing of the psoriasis. So when we are proactive, we have 3 steps for me. First, the first step is the education of children and the parents. We have to explain what is the disease, what is the treatment, what is the objective of the treatment, the project. It can be very long for this step. In the education, we have to prevent triggers of psoriasis in children. They are not the same than in adults. We will discuss this point. Then there is a therapeutic aspect, but it's not the first step in the proactive management. I think that a better understanding of the disease leads to a better adherence to therapeutic project. I have seen many children with their parents, and the parents say that they have seen a dermatologist. He said to me, "I cannot do anything for you. We cannot treat your child." It's not. It's not possible to say that we can treat the children, and we have to explain the disease. We can do it during the consultation. Some of hospitals have therapeutic education programs. We have not these programs in my hospital. It's very time consuming. You have to have a nurse, a psychologue, a dermatologist with 2 or 3 children for many hours, and we have not enough people in my department. So when you do this education, you have to explain what is psoriasis, what are the treatments, and what are the associated measures to prevent relapses. The first message is really to be positive. I think we can be positive with the children. It's very important for the confidence with the family. And what is psoriasis? Finally, it's quite easy to explain. It's a chronic disease with flare-ups. When they understand that when it's a very long disease, it's a message when the family say, "Okay, we'll go with you for a long time." If we say we'll treat, I'll see you 1 year later, it's not possible. So we'll work together for a long time. We have to explain the pathogeny of the disease. And the first step, and I always say, it's a genetic disease. The child don't understand. I think the parents don't understand as well. But I finish to say that it is a susceptibility to the disease. So you have this disease, you can have the disease along your life, but we'll treat. Sometimes there is remissions with treatment and without treatment, but you have to know that we'll treat, and maybe in 10 years, in 20 years, in 50 years, you can have a flare-up. It's an inflammation of the skin. They don't know what is inflammation. They listen to inflammation, what it is. They can imagine what it is. But I explain that the inflammation, it's the redness, it's the reason why the skin is red. And it induces an epidermal renew every 3 days instead of 3 or 4 weeks. And it gives the aspect of crested of the skin. And then there is environmental factors, because in the head of many parents, the disease in the head of the children. No, when they understand that, this point is very important. There is environmental factors that induce the flare-ups, such as infection, stress, physical trauma, but it's not in the head. It's very important. Sometimes I think you have this problem, you explain what it is during 20, 30 minutes, 40 minutes sometimes when it's a very severe form on parents who don't understand. And at the end of the consultation, you say, the parents say, "Yes, doctor, I have all understand," but you don't think it's in the head. It's you say, "Well, we have to start all to restart." And another important point is to say it's not contagious. You know, you have families with psoriasis, and there is in the imagination of the parents, it can be contagious in the family, but also at the school, at the sports. So no, you have to say it's not contagious. For treatment, we have to say that we have no treatment that cures the disease. Actually, no treatment. We can treat the flare-up, but not the disease. It's a long-term treatment. And we have different modalities according to locations and severity. We have topical treatments, lotion, shampoo, ointments, creams, etc., etc. And the severity, we have all treatments, phototherapies, but also biologic therapies. I don't say the term biologic, I say treatment by injections. And we can say at the end of the consultation, we have solutions for all the children and all the psoriasis. It's very important, this message, I think. In France, we have developed educational supports to help dermatologists to explain the disease. For children in 2016, yes, we developed the fairy tale Theo les Psorianotes with a digital form on a fairy tale with a abyss. It's interesting. It was realized for young children. On the story, there is a child, Theo, who have psoriasis, and there is a fairy called Mia, who comes from a planet where everybody has psoriasis. So she explained during the fairy tale how to manage the psoriasis in our planet. And more recently, this year, we developed for adolescents a cartoon called La Ceinture Noire. It's the story of an adolescent who only focuses on sports and forget its family, its the school. And because of psoriasis, he has problems in competitions, disqualified. So he talked to his doctor and we found solution. I can test it. I don't know if you can. Sorry. You see this is the cartoon. There is two steps. We developed it with Novartis. I tried to find financial support for many years. And Novartis, because they developed the cosmetics in children. You see, it's like that. You have. It's happened in La Rochelle, a very beautiful town in France. And Enzo, this is a boy who thinks only about sport, as you see here, have competitions, etc. He has problems with his friend, with his family, with the school. Sorry.
Sorry for the interruption, sir. The slide is halfway seen. It is not fully seen.
Right. At the end of the cartoon, you have explanation of what is the disease, how to treat the disease, and we respond to many questions about sports, about alternative medicines, about websites. It's a discussion with the adolescents. One step of the education is to talk about diets. You have some family, I don't know, it's the same in India, who say, can we test a gluten-free diets? And no, there is no dietary restriction, except for children with overweight or obesity. You know that obesity is associated to psoriasis in children, but also to severity of the disease. What we don't know now, if in children, we know it in adults, is the reduction of the weight can help us to treat psoriasis. We don't know that in children, but we think it's probably important. Céline Fan, one of my assistants, showed recently that there is maybe an impact of the Mediterranean diet on the severity, not the severity, the opposite. It's very good for psoriasis. You know, Mediterranean diet associate fish, vegetables, fruits, olive oil. I don't know if it's possible everywhere. So when we discuss this point, I say to Céline that of course it's interesting. It's a very good diet, but it's also a diet very expensive for many of people, and I don't know if it is directly linked to the diet or to the social level of the families, and she was not able to evaluate this point. Another point is sport. Sport is very important for children with psoriasis. And I often say when I talk about psoriasis that I have the swimming pool test. I think when a child with psoriasis can go back to the swimming pool or to the beach, it is that we have done our job. You know that psoriasis, IBMI, depression limit the sport activity, and we have many children who stop sport because of the psoriasis, and it's not normal. Sports, there is the reference of a very interesting publication who talk about this point. We have many publications that show now that sport prevents frequency of recurrences and severity of psoriasis flares in adults. You can imagine it's the same in children. It reduces comorbidities, obesity in children, and it increases general well-being. So all is positive with sports. So there is no exception, except during flares of psoriasis arthritis, of course, when it's not possible, or maybe it can alter the arthritis. Emollients, it's very, very important. And when we discuss with patient association, they consider that emollients is one of the most important treatment in psoriasis. It's strange, in fact. But it's not like in atopic dermatitis. You know, in atopic dermatitis, you take emollients without perfume, without allergens, etc. It's not the same problem in psoriasis. We can, I say to my patients, you can take emollients that you find in supermarkets, for example. You don't have to go to the offices. You can take the emollients you prefer. It will be the best. Chronic use of emollients have shown to reduce frequency of relapses, like atopic dermatitis, but also it reduces pruritus. And you know that when you reduce pruritus, you limit the risk of scratching. You limit the scratching, of course, on the risk of Commoner's phenomenon. So it's very important for children to put every day emollients on the skin. And you choose the emollients with the family and with the child. He takes the one he prefers, in fact. So we have to prevent triggers. The first is trauma. We'll discuss this point. Infections also. We have to up-to-date vaccine. We can discuss tonsillectomy, antibiotic prophylaxis, psychological support sometimes. But as I often say, I cannot choose for I cannot say the children have to to have a psychological support. I say to the family, go to the pediatrician, your pediatricians or GP, who better know the children, and he will know if it's necessary to have this support. For example, if the parents just have divorce, it's normal if the child has a sport, but has a stress, but I don't know if he really need a psychological support. We have to manage the obesity. We previously discussed this point. And in adult, we've often discussed the inductions of psoriasis by treatment. In children, it's not a major problem. I just find one reference about, for example, propranolol induced diaper rash. Maybe psoriasis, it was not so clear, but we have not frequently this problem in children. We have to prevent trauma, common phenomena such as onychopathy for nail psoriasis, pruritus mainly in the scalp, poor hygiene in nappy area. You know that a napkin psoriasis is often considered as a common phenomenon, and when we discussed of how they clean the nappy area is sometimes very strange. And we have to say you only use soap and water, that's enough, nothing else. We have in France what we call liniment oléocalcaire. It's oil with calcaire. They use everything. But we have to remember that there is nothing better than only soap and water. In sport, it's not rare in children, and the children was very interesting. I don't know if you can imagine the sport. You see he has plaque psoriasis only in the left leg. No, in the right, he has severe palmoplantar psoriasis, but only plaques in the left leg. On the sport, he was goalkeeper in handball. And you know, as this example, only the left leg was in contact with the ball, in fact. And it's probably the trauma of the ball in the leg who made that he has these lesions. We have the same problem with nail. In a soccer player, for example, this children was a soccer player with severe onychopathy of the fingernails. And we have to adapt the tools for the form, the size of the tools to reduce nail traumas. It's quite important. For articulations, I don't know if you remember this very interesting article published in the journal, the European Academy of Dermatology and Venereology 3 years ago. And they show that children who play with, people who play a lot with smartphone develop more psoriasis arthritis. It's not sport, of course. You know, we talk about esports now, but I don't think it's sport as I consider sport. But it's interesting that this movement induces arthritis. So next trigger is infection. This one these children come back from Sri Lanka. And she developed a severe impetigo, as you see. And on the lesions of impetigo, she developed psoriasis. And we can discuss in case of frequent flare-ups after sore throat, for example, antibioprophylaxis. It's not validated in meta-analysis, in clinical trials, but sometimes it can be interesting. I think in case of repetitive sore throats, we mainly have to discuss tonsillectomy with pediatricians. It's quite logical. Vaccines is another point. You know that it can induce flare-ups. In the study that is still ongoing, we showed, for example, that, no, not in the study, it's my experience, vaccination with SARS-CoV-2 vaccination. We have seen that in adults and in children can induce flare-ups, for example. But vaccines can also prevent flare-ups in case of repetitive infections, for pneumonia, for example, for influenza, for example, which can also induce flare-ups of psoriasis in children. So it's very important for me, not only to prevent flare-ups, but also we know that a child with severe psoriasis may have in 1 month, 3 months, in few months, systemic treatments. And it's interesting to start to finish the vaccination before initiating the treatment. When we talk about topical treatments, proactive treatment, I would say the simpler is the better. I see some prescription with 3, 4, 5 creams, with shampoo, a cream for the face, a cream for the leg. I can imagine the mother when she come back to her job the evening, and she have 5 creams. At the consultation, I don't know if you have the same experience. When you say how many tubes of Devobet, for example, you use next month, they say which treatment, the little or the big treatment, and they don't know what they really put. So for me, it's important to have 1 treatment, 2 treatments if you use shampoo, for example, but only 1 cream, 1 ointment, 1 lotion. Generally, it's enough. To be proactive, when you have reached the clearing of the psoriasis, you have 3 alternatives. 1, it's not proactive treatment in the on-demand treatment. You stop the treatment. You start when when the skin become red, become crusted. That is a reactive treatment and not the proactive treatment. In the proactive treatment, you have two ways. Either the gradual withdrawal, excuse me. You say you start with treatment once a day, then 3 times a week, then 2 times a week, then 1 time a week, and you stop after 3 or 6 months. 6 months. I think it's very difficult. It's possible when very localized psoriasis, but I think it's not possible in very in mild to severe psoriasis. I prefer the weekend therapy. It's quite easy, in fact. You say to put the cream on the area usually involved 2 times a week, either the weekend or on other days in the week. Of course, it's not more efficient the weekend than during the week. 2 days or 2 days following, 2 following days or 2 days separate in the week, as the parents want. But the idea is to put regularly the treatment. I prefer this alternative. I never do gradual withdrawal now. For systemic treatments, first we have to minimize pain and toxicity. You know, if you use biologics or methotrexate in subcutaneous with subcutaneous injection, it's painful for the children. For me, it's important to discuss with the child and with the adolescent. Sometimes you say to the adolescent, "Do you want the anesthetic cream?" And the parents respond, "No, he's an adolescent, he's courageous." No. The adolescents say, "Yes, I want the anesthetic cream. I don't like the injection. I don't know what you think. It's not a problem. I don't like the injection. I think when I have a future vaccine, I will take the anesthetic cream." I think it's very interesting. So as to the adolescent, to the child, it's systematic. But for adolescents, sometimes they want, sometimes they don't want. We have to ask that directly to the adolescent. I always do it with the nurse, never with the mother, neither by the father. I think the relation between the child and the mother is not with injection. It's love, but not with not pain, but not painful. So we have to propose to have a calm atmosphere, etc. There is many ways to reduce the pain. It's very important for me. For oxytocin, I never use it in adolescent girls. It's too difficult in front to use it because of the risk of pregnancy, the risk for the girls to be pregnant. So I only use it in young girls and in boys. We have to repeat to use moisturizing to moisturize eyes, lips, skin at each consultation to reduce the risk of intolerance. For methotrexate, it's very important now. It has been proved in children and in adults that the use of folic acid 2 days after the methotrexate intake reduce the risk of digestive symptoms. So we have to really to systematically use it. When to what do we mean? Yes, when for systemic treatment it's important. Generally, we don't know how long to use the systemic treatment at full dose. In adults, we generally say we use full dose at least 1 year. In child, I think we can reduce these periods to six, sometimes less, 6 months. I think there is short flare-ups in children. It's not like in adults. So if it's not necessary to start a treatment for 10 years, as we can propose in adults, once more, we have to be positive and think we can stop the treatment earlier. So the aim is to maintain efficacy and minimize toxicity, of course. So we have 3 approaches with systemic treatments. We have to try to find the minimum effective dose, what is called also optimizing treatment after clearing. And we have two alternatives, either the dose reduction or we can increase dose intervals. To increase dose intervals is possible for biologics. It has been evaluated with etanercept, adalimumab, with secukinumab, for example, and it's efficient. In fact, in more than 75% of people, we know that we have a higher risk of relapse, but I think this risk is acceptable for children. The other way is the dose reduction. It's possible for acitretin, methotrexate, cyclosporine, not for biologics, I think. When we treat a children, we have to approach. Either we start with low doses and we increase the dose until to be efficient, or we start with high dose and we reduce in the after. I prefer the second alternative. I think to say that the children will wait 3 months to increase the dose if it's not efficient, it's not ethical. It's very long, 3 months for children, and it's not the same that an adult who has 30 years of history of psoriasis. Generally, it's very recent. It's a traumatism for the children. So we have to be rapidly efficient. So I generally start with high dose for acitretin, for example, or 0.6 milligram per kilo per day. For cyclosporine, 4 or 5 milligram kilo per day, for example. And when I have the remission, I start to decrease the dose. It's the same for biologic. When we have a clear, I very early start the dose spacing. We can try weekend therapies. It's possible with cyclosporine. It has not been evaluated in children with psoriasis, but it has been evaluated in adults with psoriasis and with atopic dermatitis. And we can do it. I don't use this way frequently, but sometimes it's possible with children. The other is the intermittent treatment. It's not proactive, it's reactive treatment. We say you stop when you can stop, 3 months after 1 month, 3 months, 2 months, 3 months after the psoriasis is clear. And you start if the psoriasis restart. It's possible with etanercept, it's possible probably with cyclosporine as well. The risk for the other biologic is a reduction, is a decrease in the efficacy in about 1/3 of patients because of probably immunogenicity of the treatment, but we don't really know why. Whatever the treatment evaluated, we are 20 or 20, 30, 40% of patients for which the treatment is not efficient, while it was efficient before. So intermittent treatment, why not? But probably only with etanercept. Just for the end, the special focus on adolescents is very important when we have a treatment for a long time. You know that adolescence is a big bang in the children. You have modification of psychism, of anatomy, etc., but you have skin disease at the adolescence, and we have many treatments that can induce this disease as well. For example, acne is induced by steroid and cyclosporine. So we have to be very careful when we use steroids for a long time on the scalp, on the face, but it's the same problem for cyclosporine. Stria distantiae, it's a traumatism for people, and steroids can induce stria distantiae, mainly when you use the treatment for a long time in the same localization. Many children, mainly boys, have androgenic alopecia in adolescence. It's about between 10 and 20% of adolescents who start with androgenic alopecia, and you know that acitretin, methotrexate can induce as well alopecia. So we have to be very careful in these boys. And the other is mainly a problem for girls. You know that cyclosporine can induce hypertrichosis, mainly in girls with dark hairs. And I have a few adolescents who say, no, stop, I don't want any more cyclosporine. She has many hairs in the face, and it's very long to disappear sometimes. So be careful with this girl with a cyclosporine. There are examples. This is a 30-year-old girl who had a psoriasis, a scalp psoriasis, and you see here the psoriasis. And I treated this girl with Clovex, the clobetasol propionate shampoo. And after 2 months, the mother called me and she said, no, it's good for the psoriasis, but she had a skin reaction. And in fact, this girl developed acne of the forehead. So I stopped the Clovex. I don't remember which treatment I proposed. This girl had atopic dermatitis. It was not psoriasis, but it's the same problem in psoriasis. And she developed in many areas severe striae distantiae with a psychological impact, major psychological impact. So we have to really be careful in child, notably with overweight, for example. Don't use, we have not to use for a long time this treatment. This is an example of acne-like eruption in a 17-year-old boy on cyclosporine with atopic dermatitis. The atopic dermatitis was transformed. It was in remission, but he developed this acne. So in conclusion, I would like to say that proactive management of a child with psoriasis is a holistic approach, and it's not just to give a treatment. It's easy to give a treatment, but to discuss with the children is time-consuming, but it's very useful. We have to take into account the child, its environment, and its disease. They all have different psoriasis. And finally, most of measures are very simple for the people. And in conclusion, I would say that the first consultations are very time-consuming, but are good investment for the future of the children, for the future of the parents, but also for the future of our consultation, which will be more short in the future. Just before the discussion, I remember that we have create an international registry to evaluate the impact of SARS-CoV-2 on psoriasis. So if you have children with SARS-CoV-2 who have psoriasis, you can include these children. We now have 70 inclusions, 4 from India, but we can include many children as if you have cases. Thank you very much.
Thank you so much, sir, for the very informative lecture on this childhood psoriasis. I have a few queries about it, sir. So you mentioned about that vaccines which can induce flare-ups, it can reduce the flare-up. So what is your experience about the vaccines and especially COVID vaccines, sir?
COVID vaccines? No, we have vaccines, all the vaccines or only recent vaccines?
Your experience about after COVID vaccines, any flare-up is reported, sir?
Yes, for vaccines, I have no real problem with vaccine in children with psoriasis, but I have cases induced by many vaccines from hemorrhagic fever, for encephalitic disease in Autrichia, for example. I discussed with a friend from Morocco who have some example of psoriasis induced with vaccine. But it's quite difficult. It's the same with SARS-CoV-2 vaccine. But it's always difficult in children who have vaccine every month in the first years of life. Can we always say it's linked to the vaccine or not? And I am not sure there is a major impact. I discussed this point with a colleague pediatricians who say me, you can vaccine even if there is a flare-up after the vaccine. You always discuss the benefits risk of the vaccine. If there is a severe flare-up, you discuss the vaccine, you can test the efficacy of the vaccine. If the serology, for example, for pneumonia is very positive, or for Haemophilus influenzae is very positive after the first vaccine, don't do the second one. So for me, it's not a problem, vaccine.
Thank you, sir, for the information. But here in India, for everything, they blame the COVID or COVID vaccines, sir. That's why we want any supports are there, anything reported. The next thing, sir, your experience of biologics usage in childhood psoriasis, sir. Probably it is different from adults' biologics usage, sir. Any other extra precautions we have to take?
For biologic in children? Yeah. I have I recently I have a registry of children with psoriasis. I have about 60 children with biologics for psoriasis. For me, the benefit-risk ratio is very positive for children. The good news in France is that we only have acitretin that is licensed in France, so it's finally quite easy, even if it is expensive, to use biologics. Rapidly I decrease I increase those intervals between biologics, and we have finished a study in very young children, and we show that we can stop early the biologic in children. I never stop. I first space the intervals, and we can stop early. I think there is transient flare-ups in children, and the interest of the biologics is to control this flare, but it's not a chronic disease as in adults. It's very short, finally short flare of psoriasis, so we can early stop this treatment. It's true for methotrexate, it's true for acitretin, and I remember children I seen with very severe psoriasis. She was 6 years old. We treat with acitretin. It was very efficient. We stopped after 1 year. We decreased progressively the dosage. And there is no psoriasis during many years. And I saw her 10 years after with another flare of psoriasis. So it's not like adult psoriasis. Whatever the systemic treatment, I think we can try to stop the treatment. It's not true for adults, I think.
Thank you, sir. And regarding the weekend therapy with the cyclosporin, sir, so what is the dosage you use? What is the days? How many days, sir? 2 days per week or 3 days per week, sir?
Cyclosporin,
weekend therapies.
I never use it in children. I think it's a treatment of the emergency because it's rapidly efficient. It's quite efficient, but I never use cyclosporin for long term. You know, it's nephrotoxic. It can induce skin cancer after 1 or 2 years of treatment or lymphoma. It's not licensed before the age of 16 in France. So I prefer not to use cyclosporin. It's expensive, it's difficult to manage, and I think it's quite, the safety is not as good as biologic. Biologic are more expensive, of course, but for the long term, I think biologic is less expensive. I don't want to have a children with cyclosporin and he called me 10 years after or 20 years after he developed a lymphoma. I think cyclosporin is very dangerous for children. I prefer methotrexate, even if it's not licensed in France. I prefer methotrexate and acitretin. And I always try methotrexate or acitretin before a biologic, but never cyclosporin. We can sometimes. I don't like this treatment.
Thank you so much, sir, for highlighting the holistic approach of childhood psoriasis management. Just a minute, sir. Our Professor Chega Thomas want to have some interaction with you, sir.
Professor Emmanuel Mahe, I'm extremely grateful to you for having accepted to be with us and to make this wonderful, wonderful presentation. I look forward to meeting you more frequently. Of course, I'll be in Paris for SPIN meeting.
It's
See you soon.
a
Thank
great
you.
pleasure to see you in Paris, but also in Shanghai. I know Sri Lanka, but not India. It could be a pleasure.
Thank you very much.
Thank you.
Thank you, sir, for your highly informative lecture. Now, Professor Jaiko Thomas, sir, will make a brief presentation on tofacitinib.
Good afternoon, everybody. I'm here to talk to you a few words on tofacitinib, the new small molecule that is now available for the management of psoriasis plus a few other dermatologic conditions. But before that, we must know this basic Janus kinase inhibition and STAT or signal transduction and activators of transcription. But these two signals are very important when we talk about certain inflammatory disorders, particularly in the case of psoriasis. The reason is that these signals give us a pathway that mediates cellular response cytokines like interleukin 6 and growth factors like epidermal growth factors. With that basic background, I would just go straight away to the pathogenesis of how dermatologic disorders could occur when the JAK-STAT pathway are affected. JAK-STAT signaling pathway is involved in many inflammatory skin diseases, as I told you earlier, particularly those resulting from type 1 and type 2 receptors associated cytokines. The major cutaneous and associated disorders that have the most promising results with tofacitinib and other include psoriasis and psoriatic arthritis, alopecia areata, variants of alopecia areata including alopecia totalis and alopecia universalis, in atopic disease and vitiligo. Now I'm not going to talk about non-psoriatic diseases today. I'm only going to talk about the psoriatic diseases, although there's a long list of conditions here. For completion's sake, I put that these JAK-STAT inhibitors could be helpful in so many other conditions. But let's talk about their use in psoriasis. Now, this is a diagrammatic representation showing how the JAK-STAT pathway can act in psoriasis. Now, we are looking at a block formation of keratinocytes that is seen in psoriasis in the upper layers of the epidermis. Now, you go further down, you'll find that interleukin 12 and interleukin 23 are JAK-STAT dependent cytokines, which majorly serve as inflammatory mediators of psoriasis. Of course, there's IL-72, but IL-12 and IL-23 have been known for time immemorial as inflammatory mediators of psoriasis. The second point, as I told you earlier, IL-23 and Th17 cells, which produce interleukin 17, another important pathogenic molecule in psoriasis. And now most of the thoughts in the pathogens of psoriasis is slowly moving to Th17. And finally, IL-12 stimulates the Th1 cells, which are most important in psoriasis pathogenesis, and they produce Tnf alpha and interferon alpha. And keeping that in mind, we are looking for a molecule that can prevent the reaction which I showed in the earlier slide, particularly against interleukin-12 and 23. In psoriasis, IL-12 and IL-23 are the JAK-STAT-dependent cytokines which majorly serve as inflammatory mediators. Apart from that, IL-23 stimulates Th17, which we are most frequently talking about. Now, this Th17 will start producing interleukin-17 blockade, and IL-23 by JAK inhibitors reduces IL-17, and therefore these drugs have value in psoriasis. Now, that is why the small molecules, not only the JAK inhibitors, but we also talk about the PDE4 inhibitors. These two are small molecules, but the PDE4 inhibitors act in a different way by the adenine cycler system. This acts specifically against the IL-23. Now, as I told you, the mode of action, the mechanism of action, cytokine binding to its cell surface leads to receptor polymerase. Tofacitinib inhibits this phosphorylation and activation of the JAKs. JAKs cannot phosphorylate the cytokine receptors. Therefore, the receptors cannot dock the STAT. There is no docking station available for the STATs. Since the STATs cannot dock, they are not phosphorylated or activated. Gene transcription and cytokine production are thereby inhibited. And talking about gene transcription, one has to really accept that the genetic biomarkers, particularly nucleotide oligomerase domain, is getting affected. This is a very busy slide showing how tofacitinib has a multi-tiered response in patients with psoriasis. It can act on IL-12, IL-23, and then the IL-23 producing Th17, which in turn produces IL-17. There's so many different ways by which the JAK-STAT inhibitors in the form of tofacitinib can have a multi-tiered response in patients with psoriasis. Just to give you an example, how it acts on the keratinocyte, rapid inhibition of the JAK-STAT signaling in keratinocytes with reduced hyperplasia, starting within 3 days. That's very fast. And we find that no other molecule starts acting so very fast, blocking the signaling of IL-20 and 24 family of the cytokines. Removes the pre-survival effects of the common gamma chains that are being produced. And finally, subsequent attenuation of the central IL-23 produced by producing the Th17 involving IL-17. Now, those are the important steps by which tofacitinib as a small molecule helps in a multi-tiered response in psoriasis. Now, looking at the pharmacokinetics, what is pharmacokinetics? It means what the body does to the drug. There are two terminologies. One is pharmacodynamics, what the drug does to the body, and pharmacokinetics, what the body does to the drug. In terms of absorption, it's very rapid. 74% of it is rapidly absorbed in an hour's time. Gets distributed abundantly to albumin, which is present in all parts of the bodies, in all organs and organ systems, metabolized by the CYP, cytochrome phosphate, pyridine, carboxylic acid, hepatic enzymes, and eliminated by the urine, 30% of them as unchanged drug, which means that they do not cause any damage to the kidneys. However, having looked at all the positive aspects, it's time that we started looking at the negative aspects also. The warning and precautions with regard to use of tofacitinib whether in psoriasis or in any other disease. Please be aware of the serious infections that could occur, including the localized infections. Definitely do not want to have a dry psoriatic plaque turn into an infected plaque. Gastrointestinal perforation, which is rare. They always talk about it as an increased risk, but when you compare it with another small molecule, the PDE4 inhibitor, Premilast, it's much, much less. Laboratory monitoring is recommended. I would recommend it only in the other, particularly in terms of basic blood cell counts, hemoglobin, estimation, etc. And just like most drugs in psoriasis, live vaccines should be avoided. Live vaccines, live attenuated vaccines. There was a question earlier about the use of vaccines when biologics are being used. We never use a live attenuated vaccine. However, it is important that we take this in on a case-to-case basis. What are the contraindications? As always, pregnancy and lactation. And then topical should never be administered with known hypersensitivity, just like in any other drug. The only other thing is when there is severe hepatic impairment, which obviously gives us an axiom that one should always look at the liver function test before we start a patient on topical. So the monitoring should include the lipid profile, the liver function test, the renal function test to a reasonable extent, hemoglobin levels and complete blood count, vital signs. Vital signs which include patients should be monitored for pulse rate and blood pressure. This is something which we do on a routine basis for all patients, whichever drug we start them on. Tuberculosis we look for not only in the case of topical, but also when we use other biological agents, and even in the case of the Premilast, because I'm talking so much in comparison to the Premilast, but I have documented evidence for the use of Premilast in psoriasis. It's about 3 years ago that we have published a paper on the use of the Premilast in psoriasis. We found it to be good, but at the same time, we found it also to have certain side effects, particularly the gastrointestinal side effect, which the patient makes the patient stop the therapy. Most occasions, we don't find that in topical. Now, I'm not a big supporter of any one molecule. What I'm trying to tell is topical is one of the currently available newer molecules in the management of psoriasis, as well as in psoriatic arthropathy and arthritis. We heard a few minutes ago a rheumatologist telling us that he's not been having much experience with topical, but he's definitely had enough experience with the Premilast and found it to be not very useful. Now, with regard to adverse drug reaction, I told you earlier about the position of infections, particularly infections of the skin. We have to be careful about, besides things like pneumonia, influenza, rosacea, etc., which can come along with any drug. Anemia is one thing. If anybody asks me what's the commonest side effect that you get to see in your patients who are put with topical, it is anemia. Headache, hypertension, GI disorders. Nausea, vomiting, diarrhea is a common side effect for almost most drugs. A cough, rash, arthralgia, pyrexia, edema, and peripheral edema with fatigue or with neuropathy is also known to occur, but these are all only anecdotal, doesn't occur on a regular day-to-day basis when topical is being used. As we told you earlier, gentlemen and ladies, we have off-label uses apart from it being useful in psoriasis, psoriatic arthritis. We find it useful in alopecia areata. Now, I'm a big protagonist of this. I really love to treat both children and adults with alopecia areata by giving them topical 5 milligrams or 10 milligrams daily. Vitiligo, yes, You can give oral tofacitinib and it's very useful, but topical tofacitinib in 2%, which is now getting available, is also useful. Atopic dermatitis, honestly, I have no experience with it, but if I were to look at the documents and read literature, I find that atopic dermatitis is also remedied with tofacitinib. And I'm not surprised because personally I feel that psoriasis and atopic dermatitis are related conditions. Now, just to conclude with some of the important points, tofacitinib is a new molecule targeted therapy for come as a big change in dermatologic therapy. This JAK-STAT is an intracellular signaling pathway upon which many different pro-inflammatory signaling pathways converge. We just saw how it kind of starts up with IL-12, IL-23, influences TH70, which in part gives rise to IL-70. Instead of going directly to the IL-17 inhibitor, like a secukinumab or procrastinumab or izokibep, you could try with this. You could try with this first before going to the biologics. Now, numerous inflammatory dermatosis are driven by soluble inflammatory mediators which rely on the JAK-STAT signal. There is growing evidence, my dear friends, that JAK inhibitors are efficacious in atopic dermatitis, yes, alopecia areata, WS, psoriasis, and vitiligo. JAK inhibitors can be administered orally or used topically as I told as a 2% cream to be used and represent promising new class of medications as an anti-therapeutic armamentarium. Thank you very much. And if there are any questions, I should be glad to take them.
Thank you, sir, for your informative talk. The delegates can now ask their queries related to the topic.
Among tofacitinib and apremilast, which one would you prefer in treating your patients?
It's a very nice question, but the question was already answered. I definitely prefer tofacitinib compared to apremilast because of the side effect profile.
Thank you, sir.
Good afternoon, sir. So, what are the other oral agents that tofacitinib can be used with in combination?
In fact, doctor, I don't think we should use anything in combination with tofacitinib. But my experience, particularly in psoriasis, I have found it to be very useful when I start off with cyclosporin. And I start off with cyclosporin only when methotrexate fails. So I start off with the poor man's cyclosporin, namely methotrexate, then go to cyclosporin. And when I am weaning the patient off cyclosporin, I would like to put the patient on tofacitinib. First of all, it is more economical or less expensive than cyclosporin. And then I've already created the plunge against psoriasis by the use of cyclosporin. Therefore, I'd like to go to something milder and at the same time effective like tofacitinib.
So does it require a long profile of investigations before tofacitinib has to be started?
I personally don't do much of investigations. I only look at the blood cell counts and look for anemia before I start off. But keep monitoring the patient. I write on the patient's prescription, consult, and tell the patient to come within 7 days if there is any cutaneous rash or side effect in the form of nausea, vomiting, or any changes in the form of jaundice. I tell them to come. And once they've come after a week, I don't find it to be unsafe at all. It's very safely used. I'm using it in a number of cases, in a number of patients, not only for psoriasis, but for alopecia areata and also for vitiligo, and found them to be useful.
What is the youngest age in whom you have used, and would you prefer a syrup form, sir?
I have used it from the age of 12, and that is what is indicated. Better not to play with any signaling for that matter, not only JAK-STAT signaling, any signaling, we should be very careful. For the younger, we have got your cyclosporine, you've got your methotrexate, you've got your acitretin, which you could use. I wouldn't personally advocate this for children. 12 years and above, yes. Are there any further questions, my dear ladies? No. There is one more. Read it out, please. It's not interferon alpha, quantiferon alpha.
Quantiferon alpha gold is positive. Should we treat TB and then go for tropocytic?
Yes. If quantiferon test is positive, we must treat the tuberculosis first before we start not only on tavacitinib, even on methotrexate, even on cyclosporine, even with apremilast. We will have to treat the tuberculosis or any infection for that matter.
Thank you, sir.
Good afternoon. We are now back for the post-break session. We have with us Dr. T. Vanathi, Assistant Professor, Department of Dermatology, Hillpark Medical College, to talk on pustular psoriasis. And we have with us Dr. R. Madhu, Associate Professor, Madras Medical College, to chair the session. May I request Dr. Vanathi to please start sharing her screen.
Good afternoon, one and all. I'm here to talk about the approach to the management of pustular psoriasis. We know pustular psoriasis is an eruption of superficial pustules in a given distribution, typically with an erythematous base or studded on a background of erythema. Classification, before going to the management directly, I would like to say a few words about classification. Pustular psoriasis can be classified into generalized pustular psoriasis and localized pustular psoriasis. Among the generalized pustular psoriasis, we have the main clinical variants: acute generalized pustular psoriasis, otherwise known as von Jungberg type, and subacute annular cercinate pustular psoriasis. And other specified forms are impetigo herpetiformis, which is nothing but pustular psoriasis in pregnancy, and infantile and juvenile pustular psoriasis. In the localized pustular psoriasis, we have palmoplantar pustulosis and acrodermatitis continua of Hallertau. Generalized pustular psoriasis can be acute or subacute or chronic eruption with generalized pustules. It can arise either from a chronic plaque psoriasis or de novo. Incidence is relatively rare when compared to psoriasis vulgaris. Age is usually 40 to 60 years. No sexual change preponderance is seen except in impetigo herpetiformis, which occurs only in females. In children, male preponderance is there. It can be associated with inflammatory polyarthritis and metabolic syndrome. In the pathophysiology, there is a new genetic mutations have been found, which is called deficiency of interleukin 1 receptor antagonist and deficiency of interleukin 36 receptor antagonist. These two antagonists are needed for controlling the inflammation caused by interleukin 1 and 36 in a normal human being. Whenever there is a deficiency in these two receptor antagonists, it can lead on to unopposed activation of the immune system by interleukin 1 and interleukin 36, activating nuclear factor kappa B light chains and also mitogen associated protein kinase, resulting in inflammatory milieu throughout maintained. And one another mutation, COD14 mutation, which is a gain in function of interleukin 36, which is caspase recruitment domain family member 14 mutation, which causes more of interleukin 36 to act unopposedly. Similarly, adaptor protein family 1 mutation can cause toll-like receptor misfunction and thus leading on to interleukin 36 levels higher and leading on to inflammation continuously. Generalized pustular psoriasis, the predisposing factors are very important. We have to look in for infections including streptococcal sore throat infection, cytomegalovirus, varicella zoster, Epstein-Barr virus, and including SARS coronavirus 2 have been found to be predisposing the patient to get pustular psoriasis. And a history of any topical systemic treatments, psychological stress, pregnancy, hypocalcemia. Drugs, we know corticosteroid withdrawal can cause sudden withdrawal of corticosteroids, or sudden withdrawal even cyclosporin can cause pustular psoriasis. Interesting to note, even terbinafine, amoxicillin, ceftriaxone, the drugs which we use regularly can also cause pustular psoriasis. Other drugs are such as codeine, rituximab, BCG vaccination can also trigger pustular psoriasis. The acute variety, otherwise known as von Jumberg type of generalized pustular psoriasis, patient will present burning painful sensation in skin without prodrome initially, followed by fever, malaise, and waves of pustules. Arthralgia will be seen in 1/3 of the patients. Here we have two types. It can arise from an old known case of plaque psoriasis, or it can arise de novo pustular type. In de novo pustular type, we can see interleukin 36 RN gene mutation. Patient will have severe burning, dryness, tender skin, then followed by high fever, severe malaise, leading on to pinpoint pustules, sheets of which turns into sheets of erythema, pus, and lakes of pus. Even succinate lesion can be seen. Pustular colorate around the scales can be seen. Patient can turn into generalized erythroderma. These waves of pustulation can succeed routinely. Involvement of nails, thickening of nails with subungual lakes of pus, buccal mucosa involvement, even geographic tongue can also be seen in this pustular psoriasis. The diagnostic criteria for acute generalized pustular psoriasis is recurrent episodes of fever with general malaise, multiple isolated sterile pustules, lab abnormalities, elevated WBC count, ESR, CRP, and spongiform pustule in histopathology. Subacute annular generalized pustular psoriasis, relatively it is not as severe as the case of von Jumberg type. This pattern is common in psoriasis of infancy and childhood. We can see discrete areas of erythema with slow centrifugal spread, pustules over the peripheral advancing edge crest, and we can also see a trailing fringe of scale. Mostly there won't be any systemic symptoms in this case. Impetigo herpetiformis, otherwise known as pustular psoriasis of pregnancy. Pregnancy itself, the hormonal changes can itself precipitate pustular psoriasis, usually seen in last trimester, but it can be seen in any trimester, and cases have been reported even the first day of puerperium. But most commonly last trimester of pregnancy, there will be a preponderance of inguinogenital region and other flexures, centrifugal spread, leaving reddish brown pigmentation. There can be even involvement of tongue, buccal mucosa, esophagus, and patient can have severe constitutional symptoms. Death can occur because of cardiac renal failure. And in case of long-standing untreated impetigo herpetiformis, placental insufficiency can cause even fetal death. Infantile and juvenile generalized pustular psoriasis. In children, it can occur at any age, but 25% occurs within first year of life, and 2 to 10 years, bit more common. They have more of annular succinate pattern rather than von Zumberg pattern. Attacks usually settle in few days, followed by repeated waves of inflammation. The differential diagnosis for generalized plaque psoriasis: systemic infection, acute generalized exanthematous pustulosis, subcorneal pustular dermatosis, IgA pemphigus. In case of infants, infantile acropustulosis, and even extensive tinea corporis in adults should also be thought before coming to conclusion of pustular psoriasis. In acute generalized exanthematous pustulosis, we can have history of recent drug intake within maybe 2 weeks. So with withdrawal of that drug, the patient will improve really well. There won't be any family history or past history of plaque psoriasis. There won't be any arthralgia. Even when we look into the histopathology, it will be different than that of our pustular psoriasis. I will show the picture later. In subcorneal pustular dermatosis, this is seen in usually females of 40 years of age, more over the trunk, pea-sized pustules. And histopathology will help in identifying all these conditions. In IgA pemphigus, we know we have 2 types: subcorneal pustular dermatosis type and intraepidermal neutrophilic type. Those conditions can also mimic pustular psoriasis. Here, immunofluorescence will show intercellular IgA deposition. Here, we are seeing acute generalized exanthematous pustulosis. Even some cases have been associated with interleukin 36 orange gene mutation. Here, there is a flexural preponderance. This picture is a case of subcorneal pustular dermatosis. So we have to look into the complications and comorbidities and manage really fast to save the patient, especially in case of acute type. We have to look in for hypovolemia, oligemia, hypoalbuminemia, hypocalcemia. They might have malabsorption. The drugs which we are giving might not be get absorbed when we give orally. Patient may even develop staphylococcal infection, cholestatic jaundice. Even with long-standing cases, they can develop telogen effluvium and amyloidosis. The complication, there is some serious complication. Patient can die with sepsis, renal failure, hepatic failure, respiratory neutrophilic pneumonitis, even ARDS, and death can occur. So the disease usually repeated episodes over a number of years. The prognosis is better when there is clear trigger. In the absence of effective treatment, death can occur. Generalized pustular psoriasis, which is arising from acrodermatitis of Halapi, will have worse prognosis. Investigation, we have to do the routine investigation. Complete blood count will show leukocytosis, more than even 30,000 count. Then lymphopenia, liver function, liver enzymes might get abnormally elevated. Renal function might get compromised because of the oligemia. ESR, CRP will be raised. Some patients will have ASO antibody, anti-streptolysin antibody will be positive in them. So we have to carefully look in for plasma albumin level, and even hypocalcemia can also trigger. So we have to look in for the calcium levels too. In pustular psoriasis, we will see the typical psoriasiform changes to the epidermis like elongation of rete, parakeratosis, and numerous neutrophils migrating from the capillaries into the epidermis. We see the specific spongiform pustule of Coyo in case of pustular psoriasis, along with flattened keratinocytes. Collection of neutrophils along the flattened keratinocytes in upper malphigian layer, and perivascular lymphocyte predominant infiltrate in case of upper dermis. In case of acute generalized exanthematous pustulosis, we will see necrotic keratinocytes and neutrophils mixed with eosinophils. This clue will, and they will not have regular acanthosis, they will not have elongated tortuous blood vessels as we see it in psoriasis. Subcorneal pustular dermatosis, we'll see only collection of neutrophils only in subcorneally. Other features of psoriasis will not be seen. Management, we have to admit the patient general supportive care, removal of possible provocative factors, maintaining adequate ambient temperature, adequate hydration, and in case of precipitating agent, we can abruptly withdraw Tor or ditronol. But tapering of potent topical steroids is very important. We should not, if it is precipitated by corticosteroids, in that case, if it is oral or even topical, we need to taper really slowly. In case of no metabolic threat, even with bed rest, mild sedation, bland emollients, fluid and protein supplementation, patient will become better. So in the topical treatment, bland creams without any smelling agent, perfumes, the cream should be, a bland cream should be applied regularly. Lotions we need to use really regularly. We have to prefer weak corticosteroid creams. In some studies, they have shown potent topical corticosteroid like clobetasol, halobetasol applied for 2 to 3 hours, morning and evening, for first few 2-3 weeks, then gradually withdrawing it, helping the lesions cooling down. They say for the erythema to go, this cooling down corticosteroid wrappings is topical corticosteroid wrappings is very much helpful. But we need to be very careful in withdrawing this procedure. And tar and ditronol should never be used in case of topical treatment of pustular psoriasis. Systemic therapy, according to the recent guidelines, they have described into established therapies and newer treatment. In the established therapy, they are again dividing depending upon the patient condition, whether the patient is having a tolerable non-disabling disease or severe acute disease. In case of tolerable non-disabling disease, acetretin and methotrexate works better because of it is very simple, can be given orally, easily available. In severe acute disease, we might go in for infliximab and cyclosporine. Acetretin should be started with 0.75 to 1 milligram per kg per day. Improvement is usually noted within 7 to 20 days and complete response can be seen in 2 to 3 months. So we should not forget the side effects like xerosis, cheilitis, dry mucous membrane, hypertriglyceridemia, hair loss, liver function abnormalities, bone changes, visual changes, and in a reproductive age group females, we should not give because it is teratogenic. Methotrexate, this is an extremely effective drug in all types of psoriasis, plays a role in pustular psoriasis too. It works even as an antimetabolite and also an immunomodulator. Usually it is given as 15 milligram per week. Instead of oral, here it is preferred subcutaneous because of good absorption rather than going for patient might themselves may have malabsorption. So instead of going for oral methotrexate, we can go for subcutaneous drug. So with methotrexate, we know how to handle it. We have to always check in for the cell count, look for pancytopenia, check into the liver enzymes because the patient sometimes can present fulminant hepatitis, and we have to carefully look into the patient respiratory system also because patient can present with pneumonitis. And folic acid supplementation, we all know it is a must when we give methotrexate. And if it is an acute condition, we need to give something which acts very, very fast. In that case, we go for cyclosporine. Here, we can go for maximum dose like 2.5 to 5 mg. We can go for 5 mg per kg per day, which can be divided into 2 to 3 doses. But we have to look in for the GI disturbances, electrolyte abnormalities, temperature, hypersensitivity, and we should not forget renal perfusion. It should be maintained. We have to look in for hypertension. We have to, because vasoconstriction can cause problem. It can increase blood pressure. Patient with migraine, we have to be careful, but we have to properly hydrate the patient when we are putting the patient on cyclosporine. And it is very, very important because sudden withdrawal of cyclosporine itself we have seen as a cause of pustular psoriasis. So slow tapering is a must here. Infliximab, among the biologics, infliximab is different in that we give it as a intravenous infusion. So the action can be evident within actually very extremely fast onset of action. It is a TNF alpha monoclonal antibody and it neutralizes the soluble and membrane bound TNF alpha. Standard dose for psoriasis can be used here like 5 milligram per kg at week 0, 2 and 6 and even afterwards 8 weeks thereafter. Marked improvement is usually evident within several days, but paradoxically infliximab and all TNF alpha inhibitors, they themselves can cause psoriatic skin lesions. So we have to be careful. If the predisposing agent of pustular psoriasis adalimumab, in that case we cannot give infliximab. We have to choose cyclosporine in that case. Infusion reaction with infliximab is very common. It can be either acute or delayed. 90% is acute. It is even more than anaphylaxis. Anaphylactoid reaction is more common. So it can be very well managed with paracetamol, diphenhydramine, and slow IV infusion. When we reduce the rate, patient will feel better. Sometimes even patient can develop delayed reaction after 1 to 14 days. That can also be managed with paracetamol and diphenhydramine. So other side effects, like with all biologics we see, we have to look in for infection before we start them on any biologics. We have to look in for TB, hepatitis B reactivation. We have to check for congestive cardiac failure also. Echo should also be done before we start the patient on infliximab. Increased risk for infection malignancy can also be seen. Demyelinating disease can also be present with biologics. So other agents which are used in case of pustular psoriasis are secukinumab, an anti-interleukin 17A monoclonal antibody with a dose of 150 mg once weekly at baseline and weeks 1, 2, 3 and 4 and then every 4 weeks. The dose can be escalated to 3 mg per week in poor responders, but maximum improvement will be seen usually within 3 weeks. Ixekizumab is the other drug, which is also an anti-interleukin 17A monoclonal antibody, which can be started in 160 mg at week 0. Then it should be given 80 mg every 2 weeks until week 12 and then 80 mg every 4 weeks. Brodalumab, it is an anti-interleukin 17 receptor A monoclonal antibody. It is given in the dose of 140 mg at day 1, week 1 and 2 and then every 2 weeks. In patient with poor response, the dose can be escalated to 210 mg. And guselkumab, a monoclonal antibody directed against the P19 subunit of interleukin 23, which can be given in the dose of 50 mg at week 0, 4 and every 8 weeks thereafter. So the pathogenesis of anti-TNF alpha therapy inducing psoriasis may be because of unopposed production of interleukin alpha by skin plasmacytoid dendritic cells because of imbalance in the cytokine. The second line therapy for adults include PUVA. Second line will be started in patients which they cannot tolerate the first line therapy or for whom the first line therapy is not giving enough results. We can switch over to the second line therapy. In that, PUVA and other biologics like adalimumab, etanercept, ustekinumab and combination therapy. Etanercept can be combined with cyclosporine, methotrexate can be combined with adalimumab or infliximab. Even azacitidine can be combined with adalimumab, infliximab and cyclosporine with PUVA. Other therapies, there are case reports telling granulocyte monocyte apheresis for the treatment of refractory generalized pustular psoriasis, anakinra, which works against interleukin 1 directly, and even oral zinc, dapsone, apremilast have shown results in some case reports. In case of impetigo herpetiformis, pustular psoriasis pregnancy, prednisolone would be the drug of choice. It should be started like 15 to 30 mg in mild to moderate cases, but in severe cases it can be given as 40 to 60 mg also. Since the condition is usually seen in the later trimester, we have to be careful of pregnancy-induced hypertension also. Per se, prednisolone can also increase the BP. When it is given in the earlier trimester, the main concern is cleft lip developing in the fetus, and even with potential topical corticosteroid growth restriction of the fetus is reported. So we have to be really careful when we are giving prednisolone. In patient not responding with prednisolone, cyclosporine, in some even cephalosporins, they have found improvement in cephalosporins. Another drug like infliximab, adalimumab and narrowband UVB also been tried in certain case reports. In children with acute generalized pustular psoriasis, if they have tolerable non-disabling disease, we can go for acitretin, methotrexate and etanercept, but they are with lesser dosage. In severe acute disease, cyclosporine and infliximab can be tried. Additional therapies in children, narrowband UVB, adalimumab, infliximab can be combined with methotrexate and other biologicals can be used. When we go to the localized pustular psoriasis, acrodermatitis continua of Hallerpeau, Here, patient will have chronic sterile pustular eruption affecting the tip of the fingers or toes, extending locally, may involve into generalized pustular psoriasis. But there will be local destruction of the soft tissue, nail apparatus, sometimes even the terminal digit can get destroyed. Finger, thumb, rather than toes, finger or thumb will be involved first. They will have first redness, pain, scaliness will start, then the pustules will evolve. Patient can have nail dystrophy. There will be prolonged course, there is slow spread, and it will be really refractive to treatment. But for localized pustular psoriasis treatment, we should look for always localized treatment like topical corticosteroids, topical tacrolimus, topical calcipotriol, and topical 5-fluorouracil can also be tried. If they are not responding to the local treatment, systemic treatments with retinoids, methotrexate, cyclosporine, and other biologics can be tried. In palmoplantar pustulosis, we see erythematous scaly plaque studded with sterile pustules, pertaining, particularly it is seen only on palms and soles. It is more seen in women rather than men. Can be associated with autoimmune thyroid disease, anti-gliadin antibodies, diabetes, and Sappho syndrome. It is maybe a part of Sappho syndrome. It is commonly seen in smokers. So the predisposing factors are smoking. In one Japanese study, they've seen oropharyngeal septic foci be the cause of palmoplantar pustulosis. So general measures in managing that: skin moisturization, avoidance of irritants, cessation of smoking. Then first line therapy, topical corticosteroids, oral retinoids, PUA. If they are not improving with plain PUA, retinoids can be combined with PUA. Cyclosporine can also be tried. Methotrexate. With very severe resistant case, infliximab, etanercept, adalimumab can be tried. Other therapies like even topical retinoids, oral tetracyclines, itraconazole, tonsillectomy, gluten-free diet, because anti-gliadin antibodies have been seen in certain individuals. So gluten-free diet seems to helpful in some. And eczema light therapy, narrowband UVB therapy, and case reports of even superficial radiotherapy and high dose rate brachytherapy have been given in case of unresponsive palmoplantar pustulosis. Tofacitinib may also have a role in management of the palmoplantar pustulosis. So this is a 52-year-old female who presented with subacute circinate lesions of generalized pustular psoriasis. After 2 weeks of acetatin, the lesions melted away like anything. The patient was so happy, and we gradually withdrew the drug. And patient actually after 1 year again came with a similar symptom. The predisposing factor we are not able to find out, but she is responding with acetatin very well. With even 1 month of total acetatin, she was symptom free for the past 1 year. So to summarize, in a case of pustular psoriasis, first look into the patient. Determine the need for hospitalization. Supportive care is a must. We have to identify and discontinue the precipitating agent in case of drugs especially. And we have to initiate treatment to control skin disease. And we have to look into the extracutaneous complication and try to avoid them to save the patient. Thank you.
Thank you, Dr. Vanti. That was indeed a lucid presentation, and you clearly gave us the overview of triggers, the various clinical presentations, and a recent update on all the biologicals that are available. And in fact, you laid a lot of emphasis on acute generalized pustular psoriasis, which is indeed by itself a distinct entity, because sometimes it can be more debilitating than even a plaque psoriasis. And patients often do get scared of exanthem or think it's, pustules all over the body is quite a scary sight for all the other family members also. And are there any questions from the audience? If not, I think I would start. What about, we did mention about acetretin being very effective in pustular psoriasis. So your insights on use in children, because administering acetretin in children, is it itself a problem? So
Acetretin, there are studies showing good improvement. I have not given anything personally in childhood psoriasis, ma'am. But studies are showing good results. But in some cases, when we are worried about using acetretin in young females, they have even prescribed isotretinoin in case of pustular psoriasis.
That's right. That's right. Only thing is acetretin, if you want to administer, they say you can always put the capsule in the freezer and then cut accordingly, because
Yes,
yeah,
ma'am.
that
And
is
we-
one thing which you have to
We
mention.
had a
also.
patient and it is a tablet, ma'am. Only isotretinoin is coming as a capsule.
Capsule.
And we are getting acetylene as tablet nowadays.
That is good.
So it can be taken very well.
Right. I think if there are no other questions, we'll wind up.
Thank you, ma'am.
Thank you. Thank you, Dr. Vanati.
We are now in the last and in the penultimate session of today's event by Dr. K. Rajkumar Sir, Associate Professor of Dermatology from Madras Medical College. Professor Parimlam Kumar ma'am will be chairing this session.
May I directly request Dr. Rajkumar Kannan, Associate Professor, Madras Medical College, to start his presentation on scalp psoriasis.
So, good evening, one and all. At the outset, I immensely thank the organizers for this opportunity. My topic for the day will be recalcitrant scalp psoriasis and overview. My discussion will be spinning over the areas of introduction, the genetic risk loci, pathogenesis classification, causes for recalcitrant nature, a tiny case scenario, and finally we arrive at conclusion. Why scalp psoriasis at the fag end of the CME? We all know the fact scalp is one of the most common sites of involvement in psoriasis and poses a great challenge to the treating dermatologists, particularly in the case of psoriasis vulgaris. So at the end of this discussion, every one of us will be noting the fact scalp is both the portal of entry and portal of exit in a patient of psoriasis vulgaris who is genetically predisposed to develop this papillosquamous disorder. So what are the factors that lie behind this fact? And what are the factors that could enable a dermatologist to predict a patient of psoriasis vulgaris of long-standing duration with scalp psoriasis can land up with psoriatic arthritis over a period of time? What are the interesting factors behind that? So as far as scalp psoriasis is concerned, itching had been predominant bothering symptom for the patient. Alopecia usually is non-scarring initially, but over a period of time with recurrent episodes of lesion, yes, scarring alopecia could set in. Scalp psoriasis is associated with a 3.89-fold increase in psoriatic arthritis predisposition. Spondyloarthropathy, a subtype of psoriatic arthritis, has been found to be affecting more patients with scalp psoriasis than those without scalp involvement. So I recall the memory of the August audience. Cutaneous psoriasis, if it's going to involve specific anatomic zones like scalp, nail, and the groin, the risk of your patient landing up with grade is really on the higher side, where they finally could land up with psoriatic arthritis. So what are the parameters do we have to assess the severity of the disease? So scalp psoriasis has the following parameters: psoriasis scalp severity index, scalp modified PASI, scalp physician global assessment, and the body surface area scores. Why is it now a burning issue? So please do note the average body surface area of a adult men is somewhere around 1.9 meters square, that of an adult women is 1.6 meters square, whereas the surface area of the human adult scalp is hardly 650 square centimeters. With amounting to such a smaller proportion of the entire body surface area, please recall the amount of risk that a patient of psoriasis vulgaris with scalp psoriasis, which could predispose him or her to psoriatic arthritis, is 3.89-fold compared to a patient who doesn't have psoriasis of the scalp. So 85% of psoriatic arthritis patients also do have psoriasis vulgaris, or at least cutaneous lesions at any one of the anatomic loci. So skin lesions typically precede the joint symptoms. This is one important fact which gives the privilege to the dermatologist to predict the forthcoming or the upcoming psoriatic arthritis. 30 to 50% of psoriasis vulgaris patients will have preclinical ultrasonogram detectable changes of psoriatic arthritis who are otherwise asymptomatic joint-wise clinically. So any long-standing patient of psoriasis vulgaris with a block over a major joint like elbow or a knee joint, so strong family history of psoriasis vulgaris in the first degree relatives, earlier age of onset, or factors which could predispose the underlying joint to psoriatic arthritis, the phenomena that was presented by so many speakers before me as known as the deep Kubnerization. Yes, you need not wait for the patient to come back to you with pain in the joint. You can subject them to a proactive ultrasonogram that could pick up changes which are not detectable clinically. Patient doesn't have any symptom, but you can nicely radiographically pick up changes pertaining to dactylitis, enthesitis, and of course spondylitis. So preclinical diagnosis of the joint involvement helps the dermatologist in getting the patient recovered, not from proceeding to crippling deformities like arthritis mittelans. This is where scalp psoriasis holds good. So due to overlap between the skin manifestations of psoriasis, psoriatic arthritis, and other comorbidities associated with the metabolic syndromes, namely diabetes, obesity, hypertension, hyperlipidemia, and the systemic inflammation that could result from this immune-mediated disease, the National Institute of Health Sciences, situated in Washington, has now branded these conditions as a part of spectrum of psoriatic disease. That is how the disease now gets its new terminology. It's no more psoriasis. Please note, it's psoriatic disease, and probably this is what forms the basis for the so-called psoriatic march. So please note the cytokines which are involved in the evolution of pathogenesis and the cytokines which are involved in the evolution of atherosclerotic plaque in the blood vessels, which could take a patient to ultimate myocardial infarction. Namely, your TNF alpha, your gamma interferon, your interleukin 6, interleukin 17, and interleukin 8 are the common inflammatory mediators in the etiopathogenesis of psoriasis and atherosclerosis. So that is how the systemic inflammation, the peak form of which could be an acute myocardial infarction, brands psoriasis as a cutaneous disorder of systemic impact, and that's how it gains a rapport across the world involving so many medical faculties. So table nicely depicts the gene loci that could predispose an individual to psoriasis. Thanks to recent advances in the science, there are around 60 gene loci that can predispose an individual to psoriasis. So that's a pictorial representation of the immunopathogenesis of psoriasis. We are all well aware of the fact psoriasis is basically a T helper 1 cell mediated response. There is a crucial interaction going on between the genetic predisposition, the microbiome, and the immunological aspect. We will deal with all these aspects one by one in the slides to come. So genome-wide association studies, next generation sequencing, single cell profiling coupled with increasing computing power are all the recent upcoming investigations of choice which are throwing light into darker aspects of the immunopathogenesis of psoriasis. So there is a complex interplay, no doubt, between the tissue-specific microenvironment, the host immune system, and the cutaneous microbiome, which could ultimately make the patient prone for a psoriatic plaque. So genetic loci predisposes the patient to activation of the natural factor kappa B pathway. This in turn mediates the keratinocyte hyperproliferation and under differentiation. I would like to stress this point once again. It's a disorder, papillosquamous disorder, clinically characterized by keratinocyte hyperproliferation and under differentiation. So that is how you get cells with nucleus in the stratum corneum. There is absence of granular layer. So next in sequence will be your production of the pro-inflammatory cytokines in the T helper 17 cell lineage. There is clonal expansion of T cells and WNT signaling in the osteoblasts. So this is one common mechanism which is responsible for induction of psoriatic lesion in the scalp, bone and joint, and of course the nail. Why should we say that a patient of psoriasis of nail or scalp psoriasis could land up with psoriatic arthritis sometime in the future? So there are common denominators in common to all these three anatomic loci. So osteoblasts are one such targets which are common to all three loci. So nail by itself is a mini organ system which has a potent stem cell. Please note there are researchers now going in the Western setup where they are trying to regenerate an amputated limb with the help of the stem cells located in the nail. Such powerful and potential organ is nail, which of course is a mini organ system by itself with stem cells. The critical role of the bone morphogenetic protein, abbreviated as BME, again has to do something with the WNT signaling pathways, which act in common to induce lesions of psoriasis in the nail, scalp, and the bone. As I said a few minutes earlier, osteoblasts are the common target cells. What happens? Interleukin 17 and interleukin 23 axis is in common to pathogenesis of both cutaneous psoriasis, psoriatic arthritis, and enthesitis. Both this interleukin 17 and 23 are going to activate the plasmacytoid and the dendritic cells in skin as well as in the synovial fluid. Finally, they facilitate priming and proliferation of the T helper 17 cells. Coming to host immune system, the components of innate immunity facilitate the inflammatory cascade. So elaboration of inflammatory cytokines, particularly the IL-23 lineage, has a crucial role in the priming and proliferation of T helper 17 cells. What is upcoming is very interesting and quite novel in the immunopathogenesis of psoriasis, what is known as the neuroimmunocutaneous axis of psoriasis. So it has been found out of recent research, patients of long-standing psoriasis vulgaris, they have altered cognition. This has been proved beyond doubt by a functional brain MRI scanning. Also, we know the fact majority of the psoriatics of long-standing duration are depressed. They do have the risk factors like smoking and alcoholism. So functional brain scanning with an MRI, both in long-standing psoriasis and alcoholics, has given an altered picture compared to the normal individuals. They have altered cognition. So there are a set of neurotransmitters which are important in bringing about a neuroimmunomodulation, which ultimately plays a crucial role in establishing lesions of psoriasis in the skin and the joints. Psoriasis and psoriatic arthritis have another component as a common denominator, which is the neuroimmunocutaneous axis. So what are the neurotransmitters that have an immunomodulatory potential? First and foremost is your calcitonin gene-related peptide, the substance P, nerve growth factor, corticotrophin growth factor. So all these neurotransmitters are released from the nerve endings whenever a patient is exposed to extremes of stress. Also, when you are depressed, what happens? So these neurotransmitters bring about a neurogenic inflammation, play a crucial role in getting the release of IL-23 from the T helper 17 cell lineage. So again, the evidence and the fact for this fact comes from the observation. So when you apply imiquimod, the toll-like receptor 7 agonist on the normal skin, it induces psoriasiform plaques. It is because of the release of these said neurotransmitters from the cutaneous nerve endings. Suppose if you could achieve either a pharmacological or a radiofrequency based ablation of the cutaneous nociceptors, even after the application of imiquimod, you do not get a psoriasiform plaque over such RF ablated skin. So that's how the neuroimmunocutaneous axis of psoriasis comes into play. So smoking, alcoholism has now a profound role in the immunopathogenesis of psoriasis. Thanks to the neuroimmunocutaneous theory of psoriasis, what has come as an aftershock or as an evolution is cognitive behavior therapy. Today, we all know CBT or cognitive behavior therapy is one of the leading evolving modes of treating psoriasis, which is being offered either by the psychiatrist or by the clinical psychologists. So antimicrobial peptides, particularly cathelicidin LL37 and serine protease kallikrein 6, they do have again a potent role in predisposing to psoriasis. So apart from the superantigen theory, where infection is said to be one of the precipitating factors for psoriasis in a genetically predisposed individual. Not only that, if you go deep into the role played by microbes and its toxins, there is beautiful evidence to suggest that these microbes elaborate certain microbicides, and these are going to bind to the cell DNA and stimulate the plasmacytoid and the dendritic cells via toll-like receptor 9, or they serve as autoantigens which are being presented to the C cells by HLA C602. Bacteria play a crucial role in the host in the following, namely IL-17 mediated mucosal barrier immunity, T helper 17 cell development, and the related orphan receptor gamma T plus, and the T regulatory immunohomeostasis. So psoriasis vulgaris skin is enriched in pro-inflammatory streptococcus and staphylococcus. Not only they have a crucial role, the cutaneous microbiome, not only they have a crucial role in the predisposition to psoriasis, the gut microbiome has got something to do with the therapeutic efficacy of the drug that you choose to treat your patient of psoriasis. How does this happen? They influence the therapeutic efficacy of the drugs through effects on the host gene expression, and interactions between drugs and bacterial metabolites. Say, for example, patients of psoriasis vulgaris and psoriatic arthritis, they responded well to secukinumab. Those who responded well to secukinumab had a higher abundance of intestinal Citrobacter, Staphylococcus, and Hafnia obesum bacterium. So they do play a crucial role in determining the therapeutic efficacy of the drugs that you choose. So days may not be far. So like the same way we give lactobacillus supplementation when you treat your patients with higher antibiotics with sensitive gut, in order to increase the therapeutic efficacy of drugs like secukinumab, a day may come when we may be supplementing orally these bacteria in order to enhance the therapeutic efficacy. So coming back to scalp psoriasis, after all the recent developments in immunopathogenesis, it is quite wise to classify scalp psoriasis as an isolated scalp entity or scalp psoriasis occurring as a part and parcel of psoriasis vulgaris. In exclusive scalp psoriasis, the lesion starts at one single point of the scalp. It pretty much resembles seborrheic dermatitis. That's why many of the patients, they do not come to us in the early stage, and slowly it evolves into psoriasis, where the clinical spectrum will be overlapping between seborrheic dermatitis and scalp psoriasis. Later, multiple foci of similar lesions develop, paving the way to a full-blown scalp psoriasis. Then the lesion slowly starts spilling over away from the scalp. Say, for example, the retroauricular area, the preauricular area slowly conquers the face just to spread to the rest of the body. So the classic block type has got the psoriatic corona. Scaling and erythema typically transgress the frontal hairline, feature that helps in differentiating the scalp psoriasis from septum, in which the scaly patch is limited to the hair-bearing area. Nature of scales is greasy in septum, as we all know, and it is silvery white in classic block type psoriasis. Like any other anatomic area, Auschwitz sign is going to be positive in scalp psoriasis. So that's a classical picture. Hope the audience can nicely appreciate the psoriatic corona well in ahead of the hairline margin. So the second type, the severe psoriasis, which has overlapping features with seborrheic dermatitis. Lesions can involve the scalp, eyebrows, and the region of the ears are of seborrheic dermatitis type. Dermoscopy is now one useful armamentarium in the dermatologist's perspective, which helps to differentiate between these two entities. So dermoscopic features of scalp psoriasis will include red dots and globules, twisted red loops and glomerular vessels, which will correspondingly be representing the dilated dermal papillary capillaries. In contrast, in seborrheic dermatitis, we do have arborizing vessels, atypical red vessels with the absence of red dots and globules. Investigation of the vascular pattern can be valuable for the clinical diagnosis and differentiation of scalp psoriasis and seborrheic dermatitis. So that's the third variety, the erythrodermic scalp psoriasis. Hope the audience can nicely appreciate the erythema, profuse scaling. So involvement of the entire scalp, face, preauricular, retroauricular areas. Pustular psoriasis of the scalp can be part and parcel of generalized pustular psoriasis of the von Zambusch type. You get follicular, perifollicular pustules. Any chronic, long-standing psoriasiform dermatitis, say for example, discoid lupus erythematosus or a photogenic polymorphous light eruption of the nape of the neck could cause a clinical confusing diagnostic dilemma with psoriasis of the scalp. Last but not the least, the psoriasis amiantiaceae, see the profuse scaling of the scalp, which resembles that of asbestos. So what are the causes for the recalcitrant nature of the scalp? The main agenda of the topic. So presence of hair, the early lesions are easily missed out by the patient and sometimes even by the treating physician. Impediment for application and absorption of topical agents, again because of the presence of hair. The UV rays are blocked from reaching the skin because of the density of hair. Let us recall the fact in majority of the psoriatics, UV rays from sunlight, they do have a beneficial role. Non-compliance of the patient because of the mental fatigue that there is no response to treatment, scalp is richly vascular, the increased vascularity along with profound vasodilator changes of the dermal papillary capillaries could allow the inflammatory cytokines to have exaggerated impact on the keratinocyte proliferation. Patients conveniently assume it for seborrheic dermatitis, delay early consultation with a dermatologist. So this is how the lesion nicely comes into evolution over a period of time. Significant nail pitting starts in at least one finger or the thumb. Gradually, there will be involvement of all the fingers and the thumb. So never forget to examine the retroauricular area. If there is a linear area of streaky erythema in the retroauricular area, it gives a clue that scalp psoriasis is not going to confine to scalp. It can spill over to rest of the anatomic areas over a period of time. So during the periods of COVID-19 pandemic, let us be aware of the frictional dermatitis and the allergic erythema caused by the mask straps. Let us not get confused by that. Finally, as shown in the right last picture, patient lands up with typical scales of psoriasis. So the treatment options, it all ranges from the topical steroids, clobetasol propionate, shampoo forms, 0.05% is highly effective. We have the keratolytics like salicylic acid, 5 to 10%. Topical corticosteroids, of course, in the various forms like creams, lotions, ointment, gel, foam, sprays, and shampoos. Vitamin D analogues, calcipotriol solution, 50 micrograms per ml twice a day for 4 weeks. But in spite of all these things, when you come to topical corticosteroids, it holds good. And they say when it is offered to a patient in a foam base, is currently the most successful mode of application of topical steroids. But with a word of caution, out of enthusiasm, let the patients not use it in excess concentration. It is always associated with all the topical side effects of steroids. Coming to systemic agents, we do have a lot of options like cyclosporin, methotrexate, retinoids, newer biological agents, depending upon the extent of involvement and the chronicity of the disease. Physical therapies like PUVA, narrowband UVB, and laser light therapies are not so practical for the scalp because of the presence of hair. Maybe that the JAK-STAT inhibitors may offer promising results in the years to come. So I would like to stress the fact that scalp acts as the portal of entry and exit in a patient of psoriasis vulgaris. Let me just rush through a clinical scenario. 24-year-old female, a homemaker from a remote village, mother of a just 8-month-old baby, came to the OPD with complaints of extensive raw areas with peeling of skin over the entire body surface and the scalp for the past 15 days. She had blisters 1 month ago. She had fever, history of application of neem and turmeric paste all over the body for the past 1 week, assuming that all those blisters were of chickenpox in origin. So she had history of watering of eyes, history of swelling of legs. There was no history of mucosal involvement, no history of drug allergy, no history of pre-existing dermatosis. General examination, patient was febrile, she was pale, she had watering of eyes, bilateral pitting period edema was there. She recorded a BP of 110/70 and she had tachycardia. Systemic examination was luckily within normal limits clinically. So dermatological examination, she had diffuse crested erosions with foul smelling discharge all over the body. Entire skin is covered with dried neem and turmeric paste. Scalp showed multiple crested erosions with matted hairs. Oral and genital mucosa were normal. Palms, soles, and nails were normal. A quick rush through the clinical photographs. This is how she presented at the OPD. So she was entirely, literally painted green with neem and turmeric paste. The first picture nicely shows the erythema in the V area of the neck. There was not even a single small segment of skin on which we could offer her a biopsy. So bilateral swelling of legs with pedal edema. See the extent of neem and turmeric paste up to the toes. And on investigation, we found she was anemic. Markers of inflammation, acute inflammation were elevated. She was hyperproteinemic. So RFT and electrolytes were normal. ECG had normal sinus rhythm. XHS was normal. USG abdomen revealed grade 1 fatty liver, grade 1 renal parenchymal disease. Thank God serology was negative for hepatitis and HIV. So blood culture, pus culture, urine culture, no doubt all of them were positive for microbes, which were treated appropriately as per the culture and sensitivity with IV antibiotics. I couldn't offer her a skin biopsy. So the patient was diagnosed as a case of acute skin failure. She was directly admitted into the intensive care unit. So alpha bed was provided with frequent position changing for the fear of wet sores. She was on high protein diet, saline soaks, bactigos dressing. Fluid and electrolyte imbalance was taken care of. She was put on broad spectrum IV antibiotics. The systemic steroids we chose was injection methylprednisolone, 500 milligrams and 500 ml of normal saline, slow IV over 3 to 4 hours over 3 consecutive days. And then we switched over to parenteral steroids. Continuous cardiac monitoring, temperature monitoring was offered. Patient was stabilized in IMCU and shifted to our ward on the 5th day of admission. So this is how she looked after 5 days of treatment. So patient was happy, attenders were happy, but I was sad because as a dermatologist, I couldn't have an opportunity to find out what was the primary dermatological entity that led to acute skin failure. So at the time of discharge, I think all the audience could nicely appreciate the central portion of the scalp, which shows gross loss of hair. So rest of the areas, the hair density is maintained. So we discharged the patient happily with a request to come back to us whenever she had the next episode of lesion. We were waiting for the relapse to come. And that golden day came after 2 months of waiting. Patient came to the OPD with history of multiple pustules. Hope the audience could appreciate the multiple pustules over the elbow and the arm and the forearm. So that were the evolution of lesions over the upper back, which roughly resembles the pityriasis osseous lesions. See the beautiful profuse lesions over the scalp, the pityriasis amiantitia. And this time we could offer her biopsy. Histopathology was compatible with pustular psoriasis. The primary lesion was acute generalized pustules. With that, we comfortably landed up with the diagnosis of acute generalized pustular psoriasis of the Van Zambush variant. Patient was started on injection methotrexate 10 mg per week, and lesion started to resolve. So after flying through so many slides, what's the conclusion and the take-home message? Scalp psoriasis, beyond doubt, is a forerunner of psoriatic arthritis. We do have the osteoblasts as the common denominator to the bone, joint, and of course the scalp bone. The scalp bone, which is a flat bone, is also made up of osteoblasts, and it is intramembranous ossification that leads to the complete formation of scalp bones. Nail also shares the same immunogenetic pathway. That is how we dermatologists are able to predict the forerunner of scalp psoriasis potential to evolve into psoriatic arthritis some point of time. Scalp is both the entry and the exit of psoriasis in a patient genetically predisposed to develop psoriasis vulgaris. This I have seen in so many of my patients. See, when a patient of psoriasis vulgaris comes to you, whatever be the drug you incorporate in treating him, starting from simplest methotrexate up to the costliest biological, all the anatomic areas, they respond faster, lesions resolve totally with post-inflammatory hyperpigmentation, but scalp is the last site to bother the treating physician as well as to bother the patient. And whenever you treat the scalp psoriasis also, after the cutaneous lesion settle down, it average takes 6 to 8 weeks for the scalp lesions to settle down. After the period of remission, when the patient comes to you back with relapse, it is scalp that gets the most brunt of attack during the remission period. So unless this point is stressed specifically, the patients become very anxious about the scalp status, which associated with the hair loss becomes a stressful factor that once again predisposes to relapse of psoriasis. We all know one of the precipitating factor, stress of any kind and depression, and these patients are easily taken into that lead. Majority of the patients have the habit of applying hair dyes, which could worsen the status of scalp psoriasis by causing allergic contact dermatitis, and let us align our patients on that. Special modalities of treatment like phototherapy cannot be used effectively. Even the commonly used successful first-line topical medications, namely steroid lotions, can lead to skin atrophy of the face. Hence, it becomes very crucial to the treating dermatologist to ensure the maximum therapeutic safe window to the patients of scalp psoriasis. These are my references. I thank one and all for the patient listening. Thank you all.
Thank you, Dr. Rajkumar, for your exhaustive talk on recalcitrant scalp psoriasis.
Thank you, ma'am.
I think handheld phototherapy unit is
Yes,
definitely of use whenever there is a persistent plaque of the psoriasis.
Yes, ma'am. It's coming up nicely. Yes,
And what is your comment on intralesional steroid over a persistent plaque of scalp psoriasis?
Yes, ma'am. That really works out. Intralesional steroid really works out. In fact, honestly speaking, it gives better results than intralesional methotrexate or intralesional platelet-rich plasma therapy. Yes, intralesional steroid holds good, really holds good.
Because we can easily try on our regular skin, we can easily see the results, but over the scalp being a very, very vascular area, PGs have to be advised. They have to first withdraw. Wherever it is, we withdraw, but if they fail to withdraw, they can directly go into the blood vessel. That has to be insisted upon whenever you do intralesional steroid therapy for the scalp. It is a very, very vascular area, so you have to, without fail, withdraw and see whether you are inside the blood vessel. And my observation with reference to children, if a child is born with normal scalp, no vernix caseosa, if the child develops scaling over the scalp in the first year, I would first think of scalp psoriasis. And these are the children who become resistant to our treatment. Slowly, slowly, they become seborrheic dermatitis. Various people will diagnose, and this scalp psoriasis becomes resistant to treatment. And another thing is this pityriasis amiantaceae is really very bothersome. It is all over the scalp, and whatever medicine, maybe these are the patients where you can go for turban pua.
Yes, ma'am.
Very, I mean, it can be followed up very nicely.
Yes, ma'am.
And proper follow-up is required. These patients can be benefited by turban pua.
Thank you.
From the audience.
Yes,
systemic
ma'am.
treatment?
Yes, ma'am. So depends upon the chronicity of the disease and depends upon whether is there any first degree relative who has got a history of psoriasis vulgaris, age of onset of the lesion. So all these things I need to take into consideration before systemic treatment. Sometimes if it's going to be a cutaneous lesions elsewhere, when we follow them up for 6 months, what we think in terms of a seborrheic dermatitis lesion evolves into severe psoriasis, full-blown scalp psoriasis. They come to us with pitting of nails. I have seen so many patients with no cutaneous lesion, even in the predisposing sites like the lumbosacral area. They do come only with nail pits, scalp lesions.
I would start my patients on systemic therapy.
Globe. May I now request Dr. Dinesh Kumar sir to wrap up the day's events.
Thank you, Dr. Surya. So we have come to a end of a wonderful day where we enrich. Good evening, everybody, and thanks to all. The webinar and today's CME went on very well, and we had an academic feast where the treatment aspects, everything were covered, and we had a very good interaction. So the best is pouring in all of the country.